Go.
Let's go.
Good morning, everyone, and welcome to the 2024 National Transfer Meeting. My name is Dr. Charlie Rowland. I'm one of the adult clinical fellows in transport and retrieval medicine. And with me,
I'm Miriam Baruch. I'm a consultant here at Nectar, and I'm also a consultant in intensive care at South Tyneside and Sutherland Foundation Trust. I'll be presenting today with Charlie and some other people that work at Nectar.
Thanks, Miriam. First of all, thanks very much for joining us today. We hope that you can stay for the whole day. I think we've got a really interesting lineup of speakers for you. A couple of things to start off. This is a webinar, so you won't be able to put your cameras or your microphones on. So if you have any questions that you want to ask at any point, please put them into the Q&A box. What we're going to be doing in the background is collating those questions and generating some common themes. It's a pretty jam-packed day, so we probably won't have time to answer everyone's individual questions, but hopefully if there's common themes, we should be able to cover those. I want to say a big thank you to A-Line Anaesthesia Learning in the Northeast. They've provided a technical team who are supporting this webinar today. We've got a team of people just off-site from the camera who are running the webinar in the background. They're all clinicians. They've all given up their time for free. Running webinars isn't their full-time job. So with us if we have any technical hiccups throughout the course of the day, but hopefully things should run nice and smoothly. Without too much of more of a delay, we're going to crack on with our first speaker. So I'd like to introduce Dr. Les Gordon. Les is a consultant anaesthetist in the northwest of England with 40 years of experience. He's also got a long history of working with the English mountain rescue teams in Ambleside and Langdale in the Lake District. And he's got a particular interest in managing patients with severe hypothermia. And he has contributed to national guidelines, both within mountain rescue and within the broader healthcare services for managing patients with severe hypothermia. And so Les is going to join us to talk to us about managing patients with hypothermia, and in particular within a transport context. Les, over to you.
Thank you very much. Good morning. I'll just share my screen. Give me one sec. Yeah, there we go. Share screen, and I want that one. Okay, share. Right.
Les, and we can hear you. We can't see your slides yet. Oh,
got it. Is that first slide showing?
We can hear you and we can see your slides, Les.
Great, let's go with it. Okay, thank you very much for the honour of asking me to give this talk. I've been involved with severe hypothermia, managing cases and doing guidelines for about 12 years, and I've published about 14 papers on the subject, or co-authored them, I should say. The reason I'm keen to give this presentation is because what I wanted to specifically talk about is severe hypothermia. I'll tell you more about it in a sec, but it's quite a different level from what you'll call normal hypothermia, which is what we come across every day. So just first of all, terminology. The terms used are accidental hypothermia, which is what you see out in the street or in the hospital, even during an operation. Or on a hillside, in my case, with the mountain rescue, and it's uncontrolled, it's unintentional. The patients will be a long way from medical care, and therefore survival depends on many factors, and the prognosis won't be as good. It's always unplanned, and that's in contrast to therapeutic hypothermia, which we do in hospitals, for example, cardiac surgery. Just to remind you, hypothermia is an unintentional decrease in core body temperature of 2 degrees or more. So if we say the average is 37, which it is, it ranges, isn't it? It depends on where it's measured and what age and gender and so on, if I can use that word nowadays. But essentially, 35 degrees. However, there's some evidence that in even the presence of major trauma, even 1 degree, it'll increase, 1 degree 4 will increase mortality. So hypothermia is an interesting, for me, very interesting subject, because there's one word, but actually two physiological states. Mild hypothermia is what we probably see, weekly at least, if not daily in some cases. It's very common. It's familiar to all healthcare professionals. Anybody working in pre-hospital care, the people that are out there, waiting out there by a roadside, for example, or wherever, will have cooled off. There's good research evidence for that, and particularly when if they're examined on scene and then dressed by carers so that they can be examined. It's well understood. Physiological responses are essentially normal. It's an exaggeration of what we all do when we get a bit cold, and it's not a lethal condition per se. But what I'm talking about today is actually severe hypothermia. And that is very, very different. We're talking about temperatures below, core body temperature below 28 degrees, and there you see what you might call extreme physiology. It's rare. So most healthcare professionals are not familiar with the special management requirements and most healthcare professionals don't get any experience managing these cases. Standard normothermia parameters are not appropriate. And so following the clinical rules for normothermia or mild hypothermia are ineffective at best. And they may actually worsen outcome. For example, if using standard rules for terminating resuscitation is not appropriate in severe hypothermia. So what you need, and that's what my lecture is about really, is a specific mental model for severe hypothermia. I've summarized it in this slide really, which is a sort of, temperature is a continuum from 37. I haven't put Pyrex here, it's not a normal situation, and it's not relevant to this talk, but from around 37 at one end, in which you've got normal behavior, normal physiology, and simple measures will restore body temperature and function. But at the other end, below 28, you've got extreme physiology. Now the patients are usually semi-conscious or unconscious. It's rare for them to be conscious. They are not shivering. They won't be able to care for themselves. They'll have very deranged vital signs, or no signs of life at all. And that is incompatible with life if untreated. What's interesting is that there's a transition stage between around about 32 and 28 degrees, which they call moderate hypothermia. And there the conscious level is falling, shivering is tailing off. But what's interesting also is, or what is important, is that any of these warning signs, so trauma, frailty, impaired mental state, exhaustion, pre-existing medical problems and things like that, older people, particularly if they've got concurrent medical problems, moves this transition stage to the right. So in other words, people with those problems, those warning signs, if you like, will start to exhibit the extreme physiological features earlier on at a higher temperature. Just to give you, and it's important to know what to expect when the body temperature is 10 degrees or more below normal. The pulse and breathing rate slow, and the BP will fall, and that's appropriate. It's not a pathological situation. It's appropriate for somebody who's very, very cold. Halfway down the slide there, I've got what research has shown that the average drop in vital signs is with each 1 degree fall in temperature. And you can see that in the box on the right, by 27 degrees, it's normal to be breathing only 11 a minute, and a heart rate may be down to 45, and so on. And that cooling, as cooling continues, all of those will fall further until eventually they stop. And when the heart stops, you've got a limited window of time, probably less than an hour, to resuscitate the person before they relapse into irreversible hypothermia and death. For transfer situations, be aware that in very low body temperatures, there's a whole raft of ECG changes that can occur. Sinus bradycardia is extremely common, and it's often unresponsive to pacing or atropine. There've been 1 or 2 published case reports, but essentially it doesn't work. Slow AF is very common. And J waves, everybody talks about it in hypothermia. And in the middle of the slide there is a picture from John Osborne. He was the man who first described it, really, in 1953, working on dogs. The presence of the J wave, the second sort of upstroke after the R wave, but actually there are a myriad of causes of J waves, and I'll send a presentation to the organisers so they can send it out to people. But in this list of references there on the right, if anybody wants to read them up, there's a whole load of them that cause J waves. Oh, now when Wes is just, sorry, I've just had a text. Oh, blimey. It's just from Wes. Turn on your camera. Oh, I see. That's a general guidance. Sorry, I thought it was a specific lesson thing for me. Right. So when might you have to transfer a severely hypothermic patient? Well, several reasons that I can think of. One is as a pre-hospital care practitioner. For example, you call to a patient who's been out, somebody who's been outdoors overnight. An elderly person in an unheated dwelling is not uncommon. And UK coroners see a steady stream of these throughout, particularly in the winter times, but not just in the winter times. And I know that because I've been working with the coroners on this subject. Transfer to a hospital better suited for rewarming. So you may be taking somebody from a sort of what I might call inverted commas ordinary hospital to a hospital better suited for rewarming by ECLS, extracorporeal life support methods. You may be just simply transferring a patient from an ambulance or helicopter into the emergency department, or you may be transferring them from the ED, say, for scan to see if there's any unrecognized, unsurvivable pathology before attempting rewarming. So, for example, have they had a head injury or a stroke? That would mean that although they're cold and potentially rewarmable, actually you wouldn't want to do that because they're not going to survive the brain injury. And here's an example of the sort of thing I'm talking about. This was published in the American Journal of Emergency Medicine a few years ago, of a 65-year-old man found lying in the snow and brought into hospital with a respiratory rate of 3, no palpable pulse or BP. ECG just showed less than 6 a minute wide complexes. And in the hospital, the bladder temperature was 19.6. The echoes showed no observable cardiac contraction, but he was still breathing. And that is an important factor because while they're breathing, they're alive. And what that means is the heart may only be pumping faintly, but it's pumping enough to get blood to the brain to keep breathing going. So they're not dead. And you don't have to do anything about that at this stage. I'll repeat this message again, because normally when we think in normothermic terms, we would jump on things like that. You don't when the temperature is that low. Leave it. I'll explain why in a minute. Chest compressions were deliberately not used, and although they tried warm blankets and forced air and so on, that really had little effect. They even tried an endovascular technique, which is something, basically putting a catheter in and using it as you would for therapeutic or targeted temperature management, but using it the other way around to warm things up. In the end, they actually used thoracic lavage to rewarm the heart. And because that was rewarming the heart directly, the heart started to contract more observably and progressed to a palpable pulse. And eventually, at a slow rate of temperature rise, but it did rise, and he got to normal temperature after about 18 hours, which is typical for people who are being rewarmed with ordinary methods, if you like, as opposed to extracorporeal life support. So in other words, ECMO or cardiopulmonary bypass. So it could be 18 hours, but the point is it's doable and achievable if they haven't arrested. If they do arrest, it's much trickier. So these are the key points before and during transfer of a patient with severe hypothermia. Ideally, have some sort of a protocol, like we do for anaphylaxis and everything else, particularly for things where it's critical what you do, or you don't do them very often, and you won't do this very often. So you do need something to refer to. Assess the vital signs, temperature measurement if possible. I'll talk about that in a sec. Correct low blood glucose, because that's just good for the brain. And and tolerate any vital signs that are compatible with some sort of life. You're not talking about long-term life. You're talking about surviving a short period while rewarming gets established. And it's much better if they're doing their own thing than if you're breathing for them and doing CPR. Don't hyperventilate. Each end-tidal CO2 is inaccurate for guiding ventilation, and I'll mention that again in a sec. Handle the patient carefully to avoid precipitating an arrest. Prepare for hypothermic arrest and know how to manage it, and don't panic. Really don't panic, because it's not the same urgency as a normothermic patient. So if I just run through those things now in a little bit more detail. First of all, temperature measurement. Esophageal is the gold standard, and what it really gives you, you can measure temperature in all sorts of different places, but like pulmonary artery, for example, but actually for this purpose, esophageal is ideal because it gives you cardiac temperature, and that's what you want to know. The key is the heart. Everything else will sort itself out, but the key is the heart. So esophageal, if you can't use that, you can use a low reading infrared tympanic, so long as you're absolutely meticulous about how you're using it. And that will give you a ballpark figure within 2 or 3 degrees of what the actual figure is, but it'll tell you where you are. But it's affected by a whole load of things, which is why generally people say it's not very good. Well, in a sense, that's true, but if you're meticulous about how you use it, it can be fairly accurate. Less so, obviously, with these things listed here, such as cold water, air or snow in the external auditory meatus. Obviously, if there's wax in the ear, that's no use. And of course, you can use the other ear, don't forget. You've got to get the probe as close to the tympanic membrane as possible, and get it at the right angle. But all the things at the bottom there, rectal, bladder, skin, axillary, infrared, non-contact, and zero heat reflux, they're not actually good in severe hypothermia for a whole variety of reasons. Bladder you can use at a pinch, but you can't do that in a pre-hospital situation. If you were transferring from a hospital, if you had transferring and the patient's already been in hospital, well, that's okay. But otherwise, you wouldn't be using that routinely in pre-hospitally. If you can get temperature measurement, though, it's so useful because it, first of all, confirms a diagnosis. You know how cold they are. You know that there's a very high risk of cardiac arrest below 28 and below. If it isn't, it helps you to understand why conscious level may be disturbed. And also, you know, until they're very cold, they're not generally going to become asystolic. And it can give you some guidance as to whether to transfer the patient to an ECLS centre. So let's talk about transfer practicalities. First of all, airway and breathing, ABC, primary survey stuff. Supraglottic is fine. ET tube, very good. There's nothing wrong with an ET tube, but just don't spend ages trying to intubate, because you can manage with a supraglottic. It's rare for intubation to induce an arrhythmia in severe hypothermia, although but if it does do, you can expect that it'll be an arrest situation. It won't just be the odd ectopic. And please don't hyperventilate them, because hyperventilation, as we all know, reduces cerebral perfusion. Cerebral perfusion is already low because anyway, that's fine, but you don't want it to go any lower. Expect that SpO2 won't work because the skin perfusion just isn't enough. NIBP may not read because the BP will be so low. In capnography, is useful to verify an ET tube position, but for a whole variety of reasons, which I haven't got time to go into now, I've listed them here, but essentially the whole variety of reasons, it will underread considerably when you compare with blood gases. And therefore you mustn't use it to prognosticate in cardiac arrest as you might do in a normal situation. And in terms of a helicopter, if for helicopter transfers, one of the things that's been shown is from several studies is that body temperature does fall further during flight, particularly in patients who are already hypothermic or you've used abolish shivering. Now, people in severe hypothermia won't be shivering anyway, because they're too cold to shiver. So just minimize the cooling. Just try and deliver as much heat and minimize how much you expose them as much as possible. If they have hypothermic cardiac arrest is the big thing that is so different from normothermic arrest. You can use this Swiss system to stage the cardiac arrest, give you an indication of the risk of arrest, hypothermic arrest, and it's based on AVPU assessment. The principle basically is that, as we mentioned before, vital signs fall as temperature falls, and GCS is the most consistent of these. So it's used as a surrogate indicator of core temperature and therefore cardiac arrest risk. And GCS maps to AVPU, so it's simple and quick and easy to use, and we use it particularly on the mountains. It's really easy to use. And so long as there's no other cause of reduced conscious levels, such as drugs or alcohol or head injury or hypoglycemia, of course, then actually it's reliable, and it has been validated in a subsequent study and shown that all the pre-hospital arrests, hypothermic arrests, the group who were fully conscious didn't arrest. When they looked at a series of, I can't remember now, it was about 130, I think, cardiac arrests, those that had a normal conscious level or just mildly hypothermic at best didn't arrest. What you need to understand is that there are important differences between a hypothermic cardiac arrest, so that's you, for example, now with a normal heart but getting very cold, and a normothermic cardiac arrest in a person with, say, ischemic heart disease, and you don't manage the same. The analogy I like is that it's analogous to diabetes mellitus and diabetes insipidus. They've both got the same name, diabetes. But the only thing in common is the high urine output, and the management, the complications and the prognoses are very different. So, for example, you don't terminate resuscitation at 20 minutes if it could be a hypothermic arrest, unless there's a risk to the rescuers. The reason why they're at risk of arresting is this shown. It was an animal experiment in pigs, but it basically it was careful cooling and triggering arrest, triggering VF with a catheter in the heart. And basically what it showed was as the temperature dropped, the VF threshold fell, and then as the temperature came up again, the VF threshold rose again. So the effect of that is that even small movements of the body, here are four examples, three of which have been published, one of which was one of our mountain rescue ones, but small movements. One patient, was on a resuscitation trolley, turned on the side for us to examine their backs and had an arrest. Somebody else managed packaged correctly by the ambulance crew, VF arrest when moved onto the stretcher. So there are abundant evidence. You've got to handle them as carefully as you can, and even then you may not get away with it. This was a useful study, a very important study, because they looked at 206 witnessed hypothermic arrests and found that hypothermia alone does not cause cardiac arrest if the temperature is over 30, which is another reason why it's useful to have temperature monitoring established if you can do it. The most of them were below 28. There were a few, only a small number around 29. But the point is, the danger is that people mistake things and will attribute the wrong cause to the arrest. So if you know the temperature, you know roughly where you're going. Asystole, left on their own, asystole doesn't occur till about 26 or below, and it can be the primary presenting rhythm in about a third of cases. Because heavy handling can trigger an arrest, it's tempting to sort of jump in there as we normally would if this was a patient on the ward, a normal patient. But this is not what you need to do in severe hypothermia. And don't mistake slow, shallow breathing like that case report I told you before, which is appropriate in severe hypothermia. The body you just don't need to breathe faster or deeper. But that isn't agonal breathing. Because once a hypothermic arrest has occurred, ROSC is extremely unlikely until the heart has been rewarmed. So if the breathing is sustained, arrest hasn't occurred. So don't start CPR. It's not classical agonal breathing, honestly. Just leave them to it. While they're breathing, they're alive. Believe me, it's safe. And also don't start CPR if there's any rhythm compatible with life. As I say, I keep saying this because it's so important, and we've seen examples where it hasn't happened. But if you can avoid a cardiac arrest, a hypothermic arrest, it's brilliant, because if once they arrest, you've got to keep going, maybe for hours. I mean, literally hours, which is a big deal. If you can leave them on their own, gradually warming up, gradually improving, it'll be fine. This is a busy slide, I know, but there's a free download, the paper. It's a paper we wrote in 2018, and it compares normothermic arrest with hypothermic arrest, and there are about 16 differences between them, particularly in terms of agonal breathing, what it means and how you interpret it, and the implications of it, the actual management of the arrest, and I'll mention a couple of those things in a minute, and the fact that with high normothermic arrest, you may call it after a while, but with hypothermic arrest, you may need to go on for hours. And the longest successful manual CPR was 6.5 hours. 6.5 hours of just jumping on somebody's chest. So it is a very different beast. So CPR, if you have to do it, and they do arrest, and a number of them do, a good number of them do, is the normal, except don't use ALS drugs until the temperature's over 30, and then just increase the administration intervals for adrenaline from 6 to 10 minutes if the core temperature is over 30, but they're not normothermic. There's a recent study published, interestingly, in Resuscitation, showing that elimination of adrenaline is prolonged anyway in a normal person, even more so in hypothermia. And don't defibrillate more than 3 times in hypothermic arrest. It has occasionally worked, but most times it doesn't, and it just potentially injures the myocardium. As a last resort, if it would help the rescue situation, you can, in hypothermic arrest, so hypothermic, so in other words, the temperature is below 28, you can delay the start of CPR by up to 5 minutes, and you can interrupt it periodically for 5 minutes. The principle is based on what cardiac surgeons do, where they cool people down. I remember when I first saw this in Alder Hey when I trained there, and you put them on cardiopulmonary bypass, you cool them down, temperature gets down to about 18 or 20 or whatever it was they were working at, and then they switch it off. And the surgeon then beavers away for about 30 minutes or whatever, changing it, turning, fixing a valve or whatever. And then they start up again, and they expect them to make a normal cerebral recovery. And this is the same principle for this. And we looked at this. There are now 8 published pre-hospital cases. There were 3 when we published the paper. And it's based on this relationship here. That the bottom line is the temperature descending as you go from left to right. And the time is on the ordinate. And what we found, this is all from published case reports of patients undergoing deep hypothermic circulatory arrest, and how they would survive before they sustain brain injury. And as the younger they are, the longer they can survive. So in a child or in a baby, particularly, you could 40 minutes maybe at 18 degrees. The point is, though, that the 5 minutes is inside for every range once they're below 28. So 5 minutes on, 5 minutes off, if it could be helpful for a whole variety of reasons, such as the physical situation you're in with the patient, the fact that there aren't enough personnel available to actually keep rotating every 2 minutes, but only in hypothermic arrest. If you've got access to mechanical CPR, it's brilliant. And because you're talking about CPR for hours, mechanical is just what you need in these cases. If an arrest does occur, keep the head as cool as you can, because a cool brain survives longer. And this paper was one of many that this group have written from Poland, who have what they call a hypothermia center, which is probably the world leaders in managing severe hypothermia. In helicopters and ambulances, be prepared for the arrest, keep the patient horizontal. Obviously, all studies have shown that CPR quality deteriorates, particularly during transport. So again, if you've got mechanical CPR, then use it. And it's very, as you know, it's very demanding. So this was a specific study just looking at that and confirming that during transport, it's knackering basically. But once you get them to hospital or the hospital, then you've got a choice. If they can go to an ECMO centre, ECLS centre, and there aren't many of them that'll take them, but there are some, then for any of these reasons, hypothermic arrest or cardiac instability, cardiovascular instability due to hypothermia, then ECMO has a great outcome. And I'll tell you a couple of quick case reports in a minute to confirm, to demonstrate that. Non-ECLS is rewarming with everything else. And they do work, and they're available in general hospitals, but it works much more slowly, like that case report I said before, where it's 40 minutes. It took 18 hours. Sorry, I'm just looking at my time for my presentation. Here's an example, 2 quick examples of the chain of survival. This was one of ours from a mountain rescue one, but he was a 26-year-old training for an ultra marathon. He'd run a long way, a long distance, and a lot of about over 5,000 feet of ascent. And he started to slow down because he was cooling off, and he eventually stopped. He became confused. He was put in a survival bag by his partner, who went for help. But when the team arrived, he'd crawl out of the bag. He was lying on open ground and he had no signs of life. AED showed, sorry, it should say VF, the slide order of words is wrong, but AED showed VF. So it was an unwitnessed arrest. I don't know when he arrested, but he was still in VF. They did BLS. There was no response to 3 shocks. They used intermittent CPR for about 20 minutes while they were moving into a safe part of the ridge. So 5 minutes on, 5 minutes to move him, 5 minutes on again. Eventually, they were able to put him on mechanical CPR to take him to hospital. In the emergency department, his temperature was 19.7. He had a HOPE score, which is a way of calculating survival probability based on a number of simple factors like age and the length of time CPR has been going on, the temperature and so on. And apart from potassium, which you could get in the hospital, or you can assume in somebody like him, it will probably be normal. You can work out the HOPE score pre-hospitally. And he was rewarmed with ECMO, full recovery, a little bit of neuropathy initially, which then improved completely, and he's running marathons again. And I was speaking to him just the other day, and he's doing fine. This is another one. Group of paramedics had some training, curiously enough, on our Mountain Rescue England and Wales hypothermia protocol. And the next day, they found a man in his early 20s unconscious by the side of a lake. He had signs of life. Oh, sorry, they recognised possibility of hypothermia. So minimal movement. They packaged him appropriately, and they recognised there was a high risk of cardiac arrest. And surely enough, as soon as they moved him, that's what he did. So continuous mechanical CPR in the helicopter to hospital, rewarmed with ECMO, and went home 3 days later. So it's like day case hypothermia, really. Finally, or one before finally, just to give you the world records of hypothermia, just to show you what a different world it is. The lowest recorded adult survival is 13.7. In a child, it's 11.8. Excuse me. Cardiac therapeutic hypothermia for cardiac surgery is routinely about 80. It can go down to 18. It's not always that cold, but it can be. And people even tried many years ago cooling because they thought it might be helpful for cancer, useful treatment for cancer. And they cooled people down to 4.2. The patients survived. The cancer, it didn't sort the cancer, but they did survive. Longest manual CPR, 6.5 minutes. Longest total resuscitation, almost 9 hours. Longest persisting VF, almost 7 hours. And these things stop. The heart reverts to normal once it's rewarmed. And age is no problem either. There's case reports of extremely old people, 95, and there's neonates. So it's a different world, and you need to have a different mental model for that to manage these patients correctly. So just to remind you again, you need ideally have a transfer protocol, assess vital signs and temperature, correct low blood glucose, tolerate anything that's compatible with some sort of life. You're not, again, I say, you're not talking about a long life. You're talking about lasting the next few hours. And it's much better if they breathe 3 and then 4, and then as they warm up 5 and 6 a minute, which is fine when you're cold, than you worrying about, oh, they're not breathing enough and you start, etc. It's just, you don't need to do that. Don't hyperventilate. Be aware of the limitations of end tidal CO2. And don't forget that hypothermia is one of the the 4 H's. We've had one case, we've had a few cases actually where people hadn't realised that. Remember, one chap was out on the hills overnight. The helicopter crew found him in the morning. He had signs of life and they registered him as a GCS of 7. But then he arrested, not surprisingly, because he was cold, and they called it at 20 minutes. So it's a man in his 20s. He didn't have, the post-mortem confirmed no major, it wasn't a traumatic arrest or anything like that. That shouldn't happen. And there we go. Thank you very much indeed. Screen sharing has stopped as the window is closed. Okay, good. Thank you.
Thank you, Les. That was a really interesting talk. We do have some questions that have come in from our Q&A chat. The first question relates to any particular protocols you've got that relate to transfer of these patients. Are there any that you would use in your mountain rescue team that specifically relate to transfer?
Nothing. No. Okay. We have a hypothermia protocol which I've done for the whole of Mountain Rescue England and Wales, which includes guidance on that, but it's on transferring patients. But what it boils down to is what we said: minimize heat loss, add extra heat if you can, and transfer them gently, and prepare for an arrest. You can't get, there's nothing that in more depth than that, because that's what it always boils down to: reducing heat loss, trying to warm them up as well, because the warmer the heart is, the less likely they are to arrest, and the big enemy is the arrest.
Okay, fantastic. And in terms of looking at the mountain rescue guidelines, where are they accessible? Is there a website for Mountain Rescue England and Wales?
No, there is a Mountain Rescue England and Wales website, but there isn't it isn't open access. The protocol, our protocol hasn't. It's not that it's a secret. It's just that it's written specifically for mountain rescue teams in their environment, and bear in mind that about 95% of mountain rescuers are not healthcare professionals. So it's not at the same level, if you like, as you might write it for a group of doctors or paramedics.
Okay, and actually you very eloquently outlined the principles of that guideline for our audience, which has been fantastic. We've got a question about criteria for transfer to ELS centres. Is there any specific guidance for teams about how to kind of direct them to a specific specialist centre in certain circumstances, or is it just case dependent?
At the moment, it's cases dependent. In some countries, the organisation is much better. There was one recently, a case in Norway, and they're much more stitched into the idea that people need ECMO rewarming. But in this country, it's much trickier. I've got, funny enough, taking part in some meetings later on this year to hopefully improve the situation. But at the moment, it's very much by local arrangement. So, for example, one of the case reports I presented, gave you an overview of, was in the Manchester area, where they are happy to receive these sort of cases. The local paramedics had that arrangement. They confirmed over the radio that it would be okay and brought the patient in, and that one was rewarmed. But at the moment, there are lots of parts of the country where ECMO you would struggle to get ECMO support. Cardiopulmonary bypass does work. And you can use femoral bypass, so it's no more really invasive, but it's not as good, and the outcome isn't as good. So ECMO is the preference. This country lags behind some of the European ones, particularly, unfortunately, at the moment. So it's very much, if you think you could be getting in touch with having these cases, then if you can make it try and work out some sort of arrangement with your nearest centre beforehand, which is how we did it through Mountain Rescue, then, you know, that helps because they sort of aware of the principle, they understand that it could happen. And the ECMO centres are not going to get overwhelmed by these cases because there aren't that many of them anyway. But otherwise it's going to be, if you've got a centre nearby, get in touch with them. If not, you have to go to the nearest hospital. Always give the hospital heads up that you're coming and what you're coming with, because it's incredibly work intensive for the ED staff. Particularly if they arrest.
And just back to the kit. So are mechanical CPR devices a standard piece of kit for mountain rescue teams? Does every team have one and do you all have the same kit, or is it specific to different teams?
In principle, the same. In principle, it'll be the same. My internet connection is unstable, it says. I'm sorry if it is. Oh, there you are. You're smiling again there. I can see.
Yeah.
Okay. In principle, we all have the same thing. We have some sort of packaging in terms of lots of insulation. The individual make will be different. Maybe somebody will use a Smith & Wesson, some will use a Colt 45 bag, but they're all big, thick, essential bags. And then we use heat pads. We use a lot of chemical heat pads in the mountain rescue situation, and package those around the heart, around the chest, basically to maximize the heat delivery to the heart.
Okay, thank you very much, Wes. That was a fascinating talk. We're going to move on to the next speaker now.
That was a brilliant start to the day. Thanks so much. We're going to move on now. You'll notice that over the course of the day, we've got some half-hour slots for speakers and we've got some 15-minute slots for speakers. The 15-minute slots are from people who've submitted presentations on various quality improvement projects and things that they've been doing. So next up, I'd like to welcome Dr. Nina Taheri. Nina's an ST4 anaesthetics trainee at the University Hospital of North Tees, and she's here to talk to us about her quip to introduce standardised transport checklists to her unit. Nina, over to you.
Thanks so much for having me. Just want to check that you can see my slides before I start.
We can see your slides. Are you in presenter mode there?
I should be.
Yes.
Does that look okay?
Okay, go ahead.
Perfect, thank you. So thanks so much for having me. As I said, I'm Nina. I'm one of the ST4s currently in the region. Just want to apologise because I've somehow got a horrendous cold despite it being the peak of summer. So if my voice doesn't transmit across, I'm really sorry. I'll try my very best. So I'm going to very briefly take you through a improvement project I've been working on recently whilst I've been in the ITU. I'm looking at pre-departure checklists essentially of level 3 intensive care patients. My inspiration from this was really, like a number of presenters today, I've done some work out in the Australian outback, working in retrieval medicine in the remote and austere environment. As you can imagine, it's an incredible experience. But particularly working with pilots day in, day out, and working so closely with them, you really get a sense of how dependent they are on their checklists, but also how well they do their checklists. And I'm not sure about everybody else's experience, but particularly my experience in the NHS is that isn't always the case. They very much have a very strict protocol that you can't talk between it unless there's an emergency, and they have a very strict call and response technique. So working so closely with them, I sort of had that in the back of my mind when I came back to the UK to do continue my training. And I started in the ITU and noticed that every time a level 3 patient went on a transfer, whether that was from the ED to our intensive care unit or from the ITU to CT, or whether it's out of the hospital, transfer checklists just weren't being done. And when I've spoken to colleagues about it, or the nurse in charge, they sort of was saying, no, we don't really do that here. We don't really know much about it. So I thought, right, this is my time to make something a little bit better and a little bit safer for our patients. Why is it important? Well, as I alluded to, we've learned lessons from aviation checklists over the years. There's lots of evidence out there that shows that these checklists that pilots and aviation crew use dramatically raise effectiveness, reduces the incidence of serious errors. That's definitely nothing new. It's also a well-known fact that checklists are an imperative and crucial aspect of holistic patient care, And there's lots of evidence-based practice out there to show that that definitely is translatable to medical practice as well. Particularly in the ITU, research exists to show that checklists increase adherence to guidelines, reduces errors in medical practice, and are definitely associated with improvement in patient outcomes. We know that it reduces morbidity, mortality, and they have been proven to be particularly effective in both the pre-hospital and emergency and hospital phases, and as you can imagine. So I'm sure we've all got experiences of doing different types of checklists that absolutely varies depending on which region you're working in, trust dependent, the type of patients you're looking after. For my project, I reference both the Faculty of Intensive Care Medicine and the NICE guidelines, both of which actually do also advocate for adherence to utilisation of these checklists, that we should be doing them for every level 3 patient transfer and procedures. And I'm sure we all do, but as I said, my experience in my intensive care unit was absolutely not the case. So what did I do? I audited 20 of my transfer trained colleagues in the intensive care unit. I ensured that they were essentially they had the ability to transfer patients. This included some senior colleagues, junior colleagues, and advanced critical care practitioners. And then I re-audited the same group after the introduction of my my implementation of my project, which I'll talk to you about. So this was the questionnaire I sent out. Essentially, I was asking, are you aware that checklists exist, both for intra-hospital, so within the hospital, and inter-hospital? If yes, do you routinely use a checklist? If yes, where did you source it? And would you have any objections if I was to sort of mandate one, which we should be doing? And then I popped the little quiz in just sort of to keep everyone interested. Please feel free to play along. I can tell you the answers at the end. So the results from this showed that, yes, most people were aware that we had checklists for both intra and inter-hospital transfers of level 3 patients. But despite this, a lot of staff didn't use them, even though they knew about them. As you can see, only the minority said, yes, I use them regularly. So I definitely knew that there was work to be done here. The sources of checklists that my colleagues told me they used, Intensive Care Society website, that played quite a high number of sources. Some colleagues brought their checklists from previous trusts. Of course, NECTA guidelines were referenced. The North of England Critical Care Network guidelines were also referenced. And one colleague wasn't sure where she got her checklist from. And then in reference to the 3-question quiz, most people got it wrong, essentially. So what did I do? About 2 weeks after the implementation of that questionnaire, I've made a QR code which took you to the North of England Critical Care Network transfer checklist. The reason I chose this one was because it encompassed both intra and inter-hospital transfer checklists. So I thought it would be more likely that people would use it, given that it was one form for both types of transfers. And it also seemed to be one that my colleagues were most familiar with. So I thought it would be easiest to implement this, essentially. So I made an electronic reference via that QR code and made it into posters, popped it all over our intensive care. You couldn't miss it. Coffee room, on the transfer trolley, across the ITU itself, and everywhere else. I also printed out some paper copies of the transfer checklist as well, in case people wanted to use paper copies. That was absolutely fine. And then I sent this email out just to sort of give everyone a gentle reminder that this was happening, how important it was to adhere to transfer checklists. And I referenced the statement that essentially told us this and guides our practice, which was a statement, a joint faculty of the ICM and Intensive Care Society, which you can see there. So once that went out, so this is the checklist itself. I'm sure you guys are familiar with it, but if you're not, essentially 2 pages, which I printed on double-sided to make it really easy for utilisation, essentially. Of course, if you're doing an inter-hospital transfer, the checklist at the bottom of the first page might be slightly over the top or excessive, but you are permitted just to, go through what is relevant to your patient and your team at the time. And it also allows you to document your observations and any medications you were giving, which is definitely a safety thing for the patient, but also a safety thing for yourself. So around 4 weeks after implementation of these checklists, I re-audited the same 20 colleagues, asking similar questions really. And then I wanted to check if they'd actually been using these transfer checklists since I'd introduced them into our intensive care unit. I wanted to know if they'd been using the electronic reference or paper, and of those that had undertaken the checklists, did they feel that their transfer ability had improved? And most importantly, did they feel like there was an improvement to patient safety? I also wanted to know if they'd had any comments as a result of this as well. And then I asked the same 3 questions. So these questions were sourced from that joint statement from the ICM and ICS guidelines, sort of as a test to see if they'd actually read the reference that I'd advised or not. So the results were really great. So there were still 6 people that weren't aware that there was some inter-hospital transfer checklists, but the ones that were, there was 100% uptake of utilising them for intra-hospital transfers. The ones that were said that there was 100% said that there was improved efficiency in leading the transfer, and they felt that there was an improvement to patient safety as well. And that's ultimately why we're here. So it was a really great outcome. They weren't just my friends doing this to make me have good results. So every time the QR code got scanned, I got emailed. I saw people utilising the paper checklist. So I do believe that there was a good uptake of the improvement project. In terms of sources that people liked, people use both really. More sort of preferred paper, but there was not really any huge differences across the team there. In terms of the comments, people told me that they liked the prompting that the posters gave and how easily accessible it made the checklists be. So of course, we already have a huge workload in the NHS, especially in places like intensive care, and we don't want to be adding to people's workload, but checklists are essential. They improve patient safety, they improve our documentation, and that's been shown time and time again. So we really should be doing this. And like anything, the more we do something, the better we get at it, the quicker we are at it, the more efficient we are. So I thought introducing this at this stage and advocating that these checklists get continually used can only be a positive thing. But I essentially received really good feedback from them, which is great. And in terms of the quiz, slightly better. So they are better. So hopefully people did learn something from these, and we can go through the answer if you want. So in summary, there was 100% uptake of audited staff and implementation of the pre-departure checklist for all of our level 3 patient transfers from our intensive care unit. There's also an improvement in the theory, which hopefully demonstrated there was an increased knowledge and appreciation around this really important topic that we should be practicing and advocating for every day. There was really positive feedback received. Staff like the posters being accessible. So going forward, we'll continue to display the posters, continue to encourage people to use the transfer checklist, and hopefully we see an improvement in patient safety as a result. I've got a couple of references from both the aviation and from our side of things, and my email's there. If you have any questions or any thoughts, love to hear from you. So please let me know. And thank you very much for your time.
Thank you, Nina. That was really interesting. We've just got a few questions that have come through on the chat, well, on the Q&A section, and it's really interesting that the members of staff had a perceived improvement in patient safety, but has that been borne out in clinical practice? So have you seen a reduction in critical incidents or any other kind of data that shows you that it is in fact safer?
Really good question, excuse me. I haven't seen any incident reports just yet, and I think it's relatively short time frame, but that's something that I'll absolutely be looking into, because it'd be great to get some sort of concrete knowledge from that. But sort of hearsay things that I've heard from my colleagues, for example, prior to this checklist, one of my colleagues forgot to take a suction system with them on a transfer, and the patient subsequently vomited, which is really far from ideal, as we all know, in a CT scanner. And as a result of having this checklist, and probably a bit of trauma from that incident itself, we now ensure that there's always a suction unit on, because for some reason it wasn't in our bag. but that's absolutely something that I'll be looking into actual data points, because I think that would be really useful to show that improvement.
And again back to data. So how do you capture the data on the transfer? So is the checklist uploaded to an electronic patient record, or is it noted in the record? How do you record the transfer in the notes, essentially?
Yeah, that's a really good question as well. So what I've advocated my colleagues do, because of my previous experience, is I think it's important to document, to say, yes, I've done this checklist and it's attached here. And then what we were doing was scanning the paper record where the patient observations and infusions and so on were on, and popping that onto the electronic patient record on their system. If we were doing hospital to hospital transfers, then we were scanning it and then giving the receiving centre a copy as well, which worked as a good sort of summary of patient care.
Okay. And finally, this is clearly a great project, and you've got the staff on the unit really engaged in it. But how do you ensure that that engagement continues when you've left? And have you got, say, a local champion now? Have you got the nursing staff involved in this, such that they can take this project on and make sure that it stays kind of front and centre, if you like, when you're doing a patient transfer?
Yeah, that's a really great point as well. I have left the ICU, as we always change after 3 months, but I'm still in the same hospital, so I still pop back and just go, are we still using the checklist? Are the posters still up? Yes, that's great. The colleagues that I found amazingly useful, as we always do in the ITU, the ACCPs, because they're permanent parts of the team, as well as some of the staff grades we have at my hospital. I have really good feedback from all of these guys to say that they liked the checklists and they wanted to continue using it because they'd seen a benefit from it. And so I'm sort of going back to them continuously and saying, just make sure the new group of doctors are aware that this is actually, we need to be doing it. It's not just a good thing, but also it is a good thing, and continue doing it. And I think when it comes to August and I leave this trust, I definitely think I'll be trying to hand this over to a colleague of mine to continue.
Fantastic. Thank you very much, Nina. We're gonna move on to our next speaker now. And next is Alex Gatehouse, who's an ACCP working in the Adult Critical Care Transport Service here at Nectar. Alex qualified as a physio in 2000 and then as an ACCP in 2014. She's been extensively involved in ACC development in the northeast of England and has a special interest in advanced airway management and transfer medicine. She's been working at Nectar for the past year as one of our transfer medics, and she's come to talk to us today about her journey as an ACCP undertaking the intensive care medicine optional skills framework for advanced critical care practitioners. Oh, Alex, we can see you, we can see your slides. Over to you.
Thank you very much, Miriam, for that introduction and the opportunity to come and speak at the National Transfer meeting today. So yes, my name is Alex Gatehouse. I am the lead ACCP at Newcastle upon Tyne, and I'm going to talk to you today about advanced critical care practitioners and accreditation in an adult acute critical care transfer service. So who am I? Which is a really good question. So I actually qualified as a physiotherapist in 2000 and have worked at Newcastle Trust since then, and was primarily a respiratory physiotherapist working into surgery and critical care with a specialist interest in respiratory care. And then in 2012, I was very fortunate to have the opportunity to apply for an advanced critical care practitioner job. And at that point in time, that was when physiotherapists had the opportunity to have prescribing rights independent, but obviously from a limited formulary point of view. Since then, I went on to qualify as an ACCP, and then in 2014 came out into practice and have worked within our 4 critical care units within Newcastle upon Tyne. And those units have lots of different specialist services within each of them. So neurotrauma unit, cardiothoracics, and then 2 general intensive care units, which have specialties like burns, obs and gynae, vascular, ENT, heme-oncology, liver specialty and transplants as well. So what I'd like to say is, and the reason that I have these two pictures on this slide is I'm a little bit weird because I'm an ACCP that's come from a physiotherapy background, and also I might be a little bit strange, but I'm not a doctor. So in terms of the development and the background to advanced critical care practitioners, I think it's probably really important just to give a little bit of an overview of ACCPs. And these were first piloted in 2004, and that was following the Modernisation Agency looking at European Working Time Directives. And a national education and competencies framework was developed for ACCPs, for the training of ACCPs with those competencies. And subsequently, there has been two curriculum brought out, which are endorsed by the Faculty of Intensive Care Medicine. And there is one that was released in 2015 and one that was developed in 2023. And I think it's important to recognise that actually nationally, these are the standards that those ACCPs that are qualified have ACCP FICM membership. So it's recognition that those that have FICM membership are trained to a national standard and the competencies that are laid out in both of these curriculum. As part of the curriculum, there is a mention of intra and inter-hospital transfers and competencies surrounding those. And within the second curriculum that's there in 2015 was mention of intra and inter-hospital transfers. But obviously that's very dependent upon local provision of services. And within the UK, there are currently 380 ACCPs that are qualified, that have FICM membership, and approximately 200 trainees ACCPs. And the way in which that is now, the membership is now granted is that there are applications made at the point when ACCPs start to train. Prior to 2015, I was obviously trained according to the national standard from 2008. There were grandfathering rights prior to that, and the subcommittee assessed ACCPs in terms of their membership. So in terms of advanced critical care practitioners within the Northern region, I can talk a little bit about how our team has developed during those last kind of 15 years. So in 2009, our first cohort of advanced critical care practitioners were trained within Newcastle, and subsequently there have been 3 cohorts following that. So in total, we've got a team of 16 ACCPs, 14 ACCPs with 6 trainee ACCPs currently training at the moment. And then we've gone on to develop a regional network. So that's the advanced critical care practitioners in the Northern and Yorkshire region. And within that, there are about 45 qualified ACCPs and about 20 trainees currently within that group. And this is a group that meets twice yearly, that we allows kind of networking and peer support and education for all of the ACCPs within that region, with of course others welcome from other regions as well. And it's an opportunity for us to showcase work and projects and people's dissertations that they've perhaps done as part of their masters going forwards. I think it would be remiss of me not to acknowledge that inter-hospital transfer may well have been part of ACCP's practice for a significant period of time within their own organisations. And so therefore, what I am here to talk about today is not intra-hospital transfer, it's inter-hospital transfer. And it is, as I've previously said, acknowledged within the ACCP curriculum that there may well be, depending upon local service provision, the need for ACCPs who work within their critical care units to undertake inter-hospital transfer. And so This has been a trodden path by some ACCPs within the UK, but what I would also like to acknowledge is that I am no expert in this. But what I have done is had the opportunity to come and work at an adult critical care transfer service. In terms of competencies for advanced critical care practitioners, the Faculty of Intensive Care Medicine released an optional skills framework in December of 2022. So that's approximately 18 months old at the moment. And the faculty has also released other different optional skills frameworks. So there's advanced airway management, and there is also donation after cardiac death as well. So within this optional skills framework are competencies both for intra and inter-hospital transfers. And as part of my training and completing this optional skills framework, we've had I've obviously done intra-hospital transfers for a significant period of time over the last 10 years, having worked through all of the 4 different intensive care units, and essentially have then had the opportunity to come and work within an adult critical care transfer service to complete my inter-hospital transfer competencies. I rotated in August of last year and have worked full-time within our transfer service within Nectar since then, and will rotate back to our critical care units at the end of July. And in terms of what the OSF looks like, there is a recommendation that the inter-hospital competencies are completed within 12 months, that 3 months of that is full-time, and that it is supervised practice, so as in supervised directly by a consultant. During that time, there's basically, you have to have achieved 10 supervised level 3 transfers by a consultant in intensive care medicine. Unfortunately, as part of our Nectar transfer service, all of our consultants work with intensive care and are based at Nectar, and 2 of the leads within the critical care network, who are also responsible for overseeing regional transfer, also work into Nectar as well. In terms of the number of transfers that I've done during this period of time, so I've done 63 transfers during that period of time. 37 of those have been level 3 transfers, and 18 of them have been directly supervised. And then following completion of my OSF, which is in December of last year, I've then continued to do either distant or directly supervised transfers, whether that be by the consultant that's on call for the service that day, or whether that be by one of the stage 2 ICM anaesthetic trainees who also works within our service. In terms of the OSF itself, there are a huge amount of competencies that there are to complete, and it needs to be signed off by 2 intensive care consultants and also the lead, medical lead for the advanced critical care practitioners within the trust. In terms of the OSF itself, there is a minimum number of work-based assessments that have to be completed, and they constitute things like case-based discussions, DOPS and KEXs, and there is also a wide range of pathologies that are discussed and competencied within the document itself as well. And I suppose in terms of working within a transfer service that has a lot of regional transfers that happen and has specialties based within Newcastle, then I've been fortunate enough as part of my role as an advanced critical care practitioner to have rotated through each of those units and had exposure to all of those different types of patients and their pathologies, which has helped support this OSF when I've come to complete all of my competencies and demonstrate my knowledge and skills in terms of those different patient pathologies. So what's it been like? It's been really hard work, and I don't think there's any getting away from that. But what I would say is that I've been incredibly well supported during that time by all of my colleagues at Nectar. And I've also obviously been given the opportunity to be able to come to Nectar as part of a rotation. In terms of my experience here, I've become very much part of the team, for which again I'm very grateful, and I've had lots of opportunities to input into different things within the service itself as well, which I should talk about shortly. What I would say as well is it's been quite a significant change in terms of my mindset towards transfer medicine itself. When I think about the intra-hospital transfers that I've done over the last 10 years as an ACCP, I think, you know, we obviously follow protocols and guidelines when we do those, but it's much easier because you have, well, easier in terms of the resources and the staffing and the expertise are very much on hand right there. When it comes to inter-hospital transfers, obviously it's preparation is key, and so it's thinking and anticipating what those problems might be or that might occur during a transfer and negating and reducing that risk for transferring the patient as well. In terms of other opportunities that I've had at Nectar, then I would like to talk about the various different things that I have been able to input into. So the first one would be education. So I've had the opportunity to be involved and to contribute to our trainee transfer practitioner programme and provide educational sessions to them. We also have daily education that follows our safety brief meetings in the morning, and they are just kind of 10-minute presentations around a case for that week. And so I've had the opportunity to do that as well. We also run junior doctor medic teaching on a monthly basis as well, and as part of that it tends to be based around a case with a specific theme, with each of us providing an element of education to that case as well. I've also been fortunate enough to be able to present at the morbidity and mortality meetings that we have on a monthly basis, and I'm being involved in the clinical governance meetings as well. And during my time here, it took probably the best part of 4.5 months to complete my OSF. I then went on to do a master's module in critical care medicine as well, which was in Warwick. And have been well supported to continue my education and my competencies by supplementing that with the critical care master's module, as well as doing other things like the Future Learn course as well, I should say. And previously I've been funded to go down to Bristol to do the Bristol Medical Centre simulation course in transfer medicine as well, and other opportunities that come up in terms of going to national transfer meetings like Retrieve in Scotland of this year as well. So yes, so that's been a lot of opportunities that I've had given to me whilst I've been at Nectar and to be part of the team, as I say. In terms of ongoing competence, so the OSF very much talks about how ACCPs can continue to maintain their competence in terms of inter-hospital transfers. So there are several things that it points to as part of that. The first one is obviously a logbook, and so I log all of the transfers that I do. And within that, I also do some reflective practice on each of those transfers that I've undertaken, and continue to do work-based place assessments around those, particularly if there are certain learning points that I would like to consider. And also, this will be a requirement of ongoing review at my yearly appraisal as well. In terms of regular delivery of transfers, this is a little bit more challenging at the moment. As I say, I've been the first ACCP within the Northern region to be able to work into Nectar. And so we're having ongoing discussions at the moment about how we can continue to do that. But it would be an absolute privilege to be able to do that and continue to do that. My transfer practice in terms of intra and inter-hospital transfer will continue within my annual appraisal, and will continue to be part of my personal development plan. In terms of yearly simulation sessions, I think that's really important. We do a lot of sim-based teaching at Nectar. And I think in terms of maintaining this OSF, there are certain OSCE kind of simulations that are recommended within the OSF, which include things like displaced airway during transfer, management of cardiac arrest, vehicle breakdown, and other medical emergencies that might happen during an inter-hospital transfer. And so really what I would like to do moving forward is develop a course for advanced critical care practitioners that continue to do inter-hospital transfers, to give them an opportunity to continue to maintain their competence of those if they're doing it on the job, but also in terms of recognition within this OSF that needs to be part of what we do. What I should say actually in terms of the OSF is that nationally there are 39 people who've completed the airway OSF, and there are currently 7 ACCPs that have completed and had signed off the inter-hospital transfer OSF as well. In terms of courses and educational opportunities, as I say, there are several courses that we're looking to develop for advanced critical care practitioners in terms of trainees and those that are qualified, and also to do some joined up working, obviously, with our ICM and anaesthetic trainee colleagues as well. And I will continue to teach and to contribute to our regional transfer courses as well. From our adult critical care transfer service, we also have the opportunity to join via Teams clinical governance meetings and M&Ms as well. And as part of my ongoing role, I would like to still obviously contribute and also be part of those meetings, and that will help in terms of maintaining my ongoing competence. I think it would be remiss of me not to mention indemnity and personal accident cover. So currently, the Medical and Dental Defence Union of Scotland indemnify ACCPs and recognise ACCPs as a professional group or as a group of practitioners. And I have been in touch with them to discuss with them about indemnity and cover from an ACCP point of view, doing inter-hospital transfers. And as it's part of the job role and we're indemnified by the NHS, I will obviously continue to maintain that indemnity cover. And I think it's also just important to know about personal accident insurance as well for patient transfers, and perhaps what the Intensive Care Society or the Scottish Intensive Care Society provide, and the monetary values are there for you to see. But you and I need to be aware that actually my membership of the Scottish Intensive Care Society is only if the transfers that I do are ad hoc patient transfers, not as part of my job plan. I'd like to just highlight a couple of surveys that are kind of ongoing at the moment. The first one of which is myself and 3 of my other advanced critical care practitioner colleagues who nationally have joined together to undertake a couple of surveys, the first one of which is the advanced airway management, because of the release of both of those OSFs. And we already have 100 responses for the advanced airway management survey, and we need to look at the results of that. And then shortly there will be the release of our second survey, which is looking at the transfer practice of advanced critical care practitioners within the UK as a national evaluation. So those are two pieces of work that are kind of upcoming and ongoing. I think it's really important just to highlight one transfer in particular that I have had the opportunity to do over the last 9 months. And critical care has been part of my life for a very long time now. And working within Nectar, I've had the opportunity to do lots of level 3 and level 2 transfers. But one of those transfers was also a palliative care transfer. And what I would like to say about that is that that was one of the most privileged transfers, I think, that I've ever had the opportunity to do within my career. I would like to say it's a highlight of my career. I'm not sure whether highlight is perhaps the best choice of words, but it is an experience that I will never, ever forget. And I was very fortunate to share that with my colleagues that you can see here. So 2 of the transfer practitioners and our driver. And that was the opportunity to take a very young patient to the beach prior to going to hospice for end-of-life care. And to be able to facilitate something like that, I think I will never ever forget. And I just felt like it was a massive privilege to be able to do that. What does the future look like? I think that's a really good question, and probably a question that I would be asked as well. So I hope that we continue to rotate ACCPs into Nectar, into it as a service. And I would hope that in the future that there will be other opportunities for ACCPs to come and work from different organisations within Nectar as well. You know, there is no kind of set endpoint, I think, in terms of that. We already have paediatric ACCPs as well as adult ACCPs working within Nectar, because Nectar is a paediatric and adult transfer service. And lastly, I would just like to say a really huge thank you to the team at Nectar, because they have allowed me to have that opportunity. I'm very fortunate that I and the rest of my ACCP team particularly are very well supported by our consultant colleagues, and to be given the opportunity to come and work at Nectar has been absolutely fantastic. And so as part of that, I'd like to thank the consultants for all of their support to actually achieve my inter-hospital transfer OSF, and obviously the registrars that I work with as well. But of course, there's a whole rest of the team that you can see here. So there's the admin staff, there's a trainee and transfer practitioners. There, of course, is the lead nurse and the coordinators, as well as all of the drivers, which, of course, we cannot forget. And they have absolutely made my experience here one of the best experiences that I think I've had during my career. And I feel very fortunate to have been able to have that opportunity. So I'd just like to say a big thank you to them. Thank you.
Thank you, Alex. That was a really interesting talk. And actually, Alex is going to be joining me hosting for some of the day later on. So if you do have any more questions, please put them in the chat, because we might be able to talk about them later on. We've got a few questions just now, though. And the first one is, do you need to have the airways OSF before you come and do the transfer one?
Yes, you do. So the OSF, the inter-hospital transfer OSF, mandates that you have to have completed the advanced airway OSF for ACCPs prior to working in a transfer service.
Great, thank you. And in terms of supervision, does the supervision that you've had to complete, certainly the OSF, need to be a consultant, or have other people been able to complete some of your assessments?
Yeah, so the 10 supervised level 3 transfers that I did were all consultant supervised, but in terms of other assessments, a stage 2 anaesthetist or ICM trainee that has completed and been signed off for their transfer competencies can sign off my assessments.
Fantastic. And then the final question is about challenges. So have there been any specific challenges being an ACCP working in an adult critical care transfer service compared to, say, being a registrar from a background in either anaesthesia, ICM or EM? So is there anything that you can think of in the last year that's been a particular challenge for you being an ACCP?
I think that's a really good question. In terms of, I think specifically for ACCPs, it's all very new, isn't it? I'm probably one of the first ACCPs that's been given the opportunity to come and work in a transfer service. And for that, I've been very fortunate. I think there are a huge amount of competencies for ACCPs to complete, but I think that is correct. And we're fortunate that obviously the Faculty of Intensive Care Medicine has supported that. It's very new, it's in its infancy. I think it will change over time because those competencies will need to be reviewed. So if anything, I would just say probably the amount of competencies that I've had to complete prior to being able to independently transfer critically ill patients within the transfer service has probably been the biggest challenge. But as I've said, I've been very well supported with achieving those.
Thank you very much, Alex. We're going to move on to our next speaker.
Thank you.
Thanks, Alex. That was great. We've got one more short talk now before a break. So next, I'd like to welcome Doctors Verity Blackburn and Deepshri Sureshkumar. Verity and Deepshri have both been involved with developing a massive online open access course in transfer medicine on the FutureLearn platform. They actually presented on this at last year's national transfer meeting, and which was the sort of first version of the course, and they're here to give us an update on the second version of the course. So Deepshri and Verity, over to you guys.
Thank you, and thank you so much for inviting us to talk to you about the MOOC again. Verity Blackburn, I'm an anaesthetic registrar and a clinical lecturer at UCL in London. And the reason I became involved with transfer medicine is I did a fellowship back in 2021 with the North Central London Adult Critical Transfer Service. And there I was lucky enough to find a few people who wanted to create a massive open online course on this, which we eventually called A Journey Through Transfer Medicine, produced in collaboration with UCL and hosted on the FutureLearn platform. I'll be talking to you about the initial creation of the course and then hand over to my colleague, Dr. Deepshri, to cover the new updates on the second run.
So my name is Deepshri. I'm also an anaesthetic registrar in London. I was initially commissioned as the graphics illustrator for the first run of the course, but my role has now expanded to digital and art content management for the rest of the transfer MOOC. So we'll be continuing here.
So I'll give you an update and an overview of how we made the initial MOOC, its aims, the setup, the challenges, and then Deepshri's going to talk you through the new part with the second run and the outcomes and the feedback that we collated from that. So in the photo in the background here, you can see part of the filming of one of the videos that we used for the initial course. Noting that transfer medicine was a new and growing field at the time and continues to be, particularly since the more and more specialist restructuring of hospitals in the UK and of course COVID, we ended up finding that we had three aims. The first was to combat the scarcity of freely available learning resources in a comprehensive and interactive way. The second was to deliver the principles of transfer medicine and all the skills that are transferable to the care of critically ill patients, particularly in remote environments. And the third was to be able to create a platform to promote transfer medicine in its profile and provide a global forum for discussion across a community, particularly providing accessibility for anyone, anywhere. And MOOCs enable this. They give the possibility for an in-depth review of topics at the learner's own pace, in their own time, anywhere that you've got an internet connection. So it seemed the right approach. We set out to deliver specific but wide-reaching learning outcomes, so that on completion of this, the participants felt confident in a number of areas from basic to specialist transfer medicine. And so the course was split across 4 weeks, with the first week being an introduction of principles, weeks 2 and 3 covering a range of core topics such as physiology and human factors, equipment, aeromedical transfers, and so on. And week 4 dedicated to the more specialist topics in remote transfer medicine, including things like peds and infectious diseases, ECMO, and extreme locations. So here is a timeline of what we ended up going through. Although we knew right off that achieving a launch as we envisioned it was going to be a lot of work, we didn't anticipate it taking almost 3 years to be ready to run. And these were some of the steps that involved those 3 years, a few of which I'm going to touch upon over the next few slides. But essentially those years took us from the concept through the creation, the editing, and the endorsement to the initial launch, and a further year until this April for the second updated run, once we conceived, commissioned, and edited new content. And I think it's only expected that we were going to face a number of challenges throughout the creating process over the years, and those included finding early on that there was a lack of data specific to secondary transfer medicine. The MOOC concept was able to be grown out of the fact that we ran and managed a transfer service at the time from its roots. And so we were really lucky to have a great network of contacts and global sources to help with this, which we've gone on to develop. Sourcing, coordinating, editing a global network of contributors, and keeping track of over 100 contributors worth of content was pretty testing. And because we're aiming to reach a wide and diverse audience of different experiences, skills, and disciplines, as such, we had a lot of discussions around how to pitch our material to meet their needs, and at the same time, keeping it accessible from the lowest income setting with a poor internet connection, dealing with certain countries' restrictions on hosting platforms such as YouTube, and still keeping the whole thing interactive and engaging. And with such a large amount of content in different forms, we've got written articles, videos, photographs, interactive games, and quizzes. Keeping it all coherent and digestible was probably the biggest constant difficulty. But overall, it was a really novel process for all of us, and successful in our launching of the course in January of 2023. And so despite all those difficulties, I can say that creating the MOOC was truly a multidisciplinary effort with over 100 contributors from various backgrounds. And I'm happy to say that we were able to link military, aviation, medical device design, and healthcare organisations all in one place, including, for example, CATS in London, the paediatric transfer service, and AMREF Flying Doctors in East Africa, Human Factors chapters through Wing Factors, which is an organisation of incredibly experienced pilots whose crisis resource management relates closely to that of doctors, and for partnerships with endorsers such as SOBA to produce specialist material in their fields. But we also tried to gain some perspectives from outside of medicine. For example, we interviewed equipment designers and engineers from Draeger to look at how patient safety risks were anticipated and mitigated at the design stage for those who are interested in transfer equipment. And then finally from me, just a little on our endorsers. Since the course is mapped to the curriculum for the training of anaesthetists, intensivists, critical care practitioners, pre-hospital staff, the final stage of the creation process involved us being really relieved to pass a series of thorough vettings, and enough to be endorsed by several major societies and colleges representing our participants. And so with that brief run through of the making of the MOOC and its initial purpose, I'll hand over to Deepshri to provide an overview of the new chapters and the content updates for the second launch, and some of those outcomes and stats following the recent second run closure.
Right, so I'm just going to go through the second launch and some of the changes that we've made and the outcome from that. The second launch was just launched this April 15th, so it still remains open access via FutureLearn. You are actually still able to pay for an upgrade for certification purposes, and we were able to arrange for the certificate to be reimbursed by NHSE for London trainees, London anaesthetic trainees. But this was notable as this resus and transfer domain has become one of the 7 key clinical capabilities. If you are from another region or a discipline, it would still be worth approaching your relevant body to ask for approval for reimbursement, actually. So what did we learn from the pilot run? Really a lot. We took an analytical magnifying glass to the feedback that we received from so many of our participants. And a few of the recurring themes included the following. So number one, there was a perceived lack of depth when covering certain specific medical topics. So we aim to target a really diverse group of learners from various different clinical backgrounds. So we did not focus on niche topics such as ECMO or highly infectious disease transfers. But for this run, we've worked through some of these specialist chapters with experts in the field to give us more depth to the topics. Secondly, we've had some really fantastic examples of storytelling and roundtable dialogue, but there was a lower than hoped for participation rate in our discussion forums. So we know that the interaction from this course is actually what brings it to life rather than it just being an online textbook. And so this time we hosted a larger group of lead educators at the discussion period, and this was to improve our audience engagement. And lastly, the general feedback was in terms of reinforcing practical applications of our content. So overall, we've gone through all the different chapters, edited it further to ensure that the information is still very concise and relevant to practical transfer medicine. And some of the exciting new chapters that are coming up. So in week 1, we have a new chapter on patients with learning disabilities. We were actually really impressed with last year's conference talk on this cohort of patients. So for this chapter, we have included the care of patients with learning disabilities, focusing on the nuances of holistic care in liaising with specialist learning disability nurses and adapting transfers in a patient's home setting, which is probably a little bit unusual for most of us. In week 4 come further chapters. So trauma, this is a very large chapter. We know that trauma is the leading cause of death and morbidity in young people, and that the survival of these patients is critically linked to early recognition and intervention. So this chapter focuses on the practicalities of organizing an expedited transfer to an MTC and the challenges in what can be a fraught transfer, complicated either by airway compromise, major hemorrhage, amongst many others. Moving on to our cardiovascular and respiratory chapter, we've taken a lot from our COVID experiences about respiratory failure, transferring prone patients and those on NIV, which is now heavily highlighted. And in the same vein, patients on cardiac support such as ECMO and balloon pumps are becoming far more popular, and people are very keen to learn about this, as we've taken from our feedback. So we know that these are not easy patients physiologically and with regard to their equipment, and it requires a lot of forward planning. And lastly, and probably the most exciting chapter, ventures out into space. We have an expert who prepares us for space medicine. We learn a lot about unique space physiology, the resuscitation protocols, and what drugs and equipment might be used. So looking into some of the stats that we've collated over the last year, we are able to track a lot of information using FutureLearn, and we can see where our learners are coming from. So from April 23, we had over 2,000 participants from over 94 countries. And in this run, we have a further 820 participants coming from about 74 different countries, as you can see highlighted in this slide. Of the 820 participants, we found that only 2% left the course at the end, which is on par from the first run. Around 67% of learners were classified as active learners, which means that they'd completed one step in every week at least. And this is a 6% improvement from last time. And we had 11% feature of social learners, which means that they had commented or engaged in some social discussion. And this really is a key surrogate marker for participation and active involvement. And lastly, we have the Run Retention Index, and this is just a measure of how learners move through the course. And this was about 43%, which is similar to our first edition. We know that this course has been designed for a spectrum of professionals, so the relevance of each part of the course does vary. And so participants do have the flexibility in choosing certain elements which is most useful for their practice. And that's really what the benefit of this transfer MOOC is. In terms of a few other outcomes, we found that over 98% of participants were very satisfied with the course and it met their expectations. We found that 97% of the participants had learnt a new skill, which we're very pleased about, as this was one of our key goals. And 2/3 of the participants have applied what they've learnt from this. So this is a great practical implementation of all the techniques they've learnt from the course. And you can see from some of the feedback here, these are from participants over the last run. A lot of it was in relation to how informative, interactive, and relevant the course was, and how there's a lot of flexibility and being able to go backwards and forwards and learning things that you want to run through again. So, what to say? Now that our second run is officially closed, we feel that we've continued what remains still to be a mostly free, open access and comprehensive educational resource. And this is the first of its kind in transfer medicine, and it's already being implemented in formal training in London. The initial analysis of outcome metrics really show that the runs have been successful in delivering practically applicable knowledge and skills for transfer medicine. And the updated course remains accessible across the world, which we can see from our stats of over 74 different countries.
Thanks, Deeps. And so a look at the future. As we've been through the process twice now, we've become much better at understanding how to refine the course based on our run's feedback and how to meet the evolving needs of our learners from what they say. We've also aimed to add in and edit some of the more specialist topics to broaden our scope each time, as Deeps talked you through. And part of this is looking at how to retain MDT audience participation with varying interests and skill sets. Possibly of most relevance as we continue to spread awareness of the MOOC to improve the transfer medicine profile is to be able to leverage it for formal education, giving the growing presence of transfers across our scope of practice and probably more and more in most of our daily lives. One of the notable changes since launching initially was the incorporation of all the separate London sector services, including ours, which was NCL Acts, into the now pan-London service called Access, and the updated material reflects this and also looks into how transfer services and networks are formed and developed. We've since been able to partner with Access in London as the pan-region service here, and now the largest transfer network in the UK, to deliver the MOOC as part of their formal training for their body of transfer employees. And this allows them to have a specialised dashboard for their service leads to be able to assess and monitor participants' progress. So just to say, thank you so much for listening to us again. And I'd just like to thank the rest of the lead team, Dr. Joe Brandreth, Dr. Arndt Melzer, Dr. Anthony O'Dwyer, and Dr. Riaz Aziz, who you can see here in the background photo. And say on behalf of the lead team, a huge thank you to everyone who contributed to both the first run and the second, and to all the participants for your engagement and your feedback. We'd be delighted if you could join us for the next run of the course, which we'd hope to run next year, probably about once a year. And please follow this QR code if you're interested, which will take you to the course page if you'd like to sign up. Although the official 4-week run is over, the course remains open and you can do it in your own time. And also, we'd love to hear from you if you've got anything you'd like to say, comments or ideas. We're always looking for new content. Thanks very much. Any questions?
Thank you, Deepshri. That was absolutely fascinating. What an incredible project. The last slide, we would really like to.
Sure, we'll just bring that up here.
About sign-off. So it's become quite difficult now for registrants. It's easier to get signed off, if you like. The halos and the highly good partnership going where people can do the MOOC, and then are they working for Access so that they can get the transfer signed off? How is the process of sign-off working for your registrars in London?
Yeah, that's a good question, and it's part of where we want to take the MOOC now that it's become an established resource as such. The partnership that we have with Access is all their employees are. The idea is for them to complete it and then have the sign off as the certificate, which is available to anyone. And as we said, you can ask for reimbursement on that because it is covered as a domain in a lot of curriculums. In terms of how they run it, I educate for them in certain things, so I'm allowed to hear a little of the background, and I think it's essentially that it will move towards being a formal part of their training where you have to complete it, and all their participants will have free access through Access because they will partnership with FutureLearn to provide that to their learners.
Okay, fantastic. And you've told us how many people have done the course so far. What background are the majority of clinicians from, or is it an absolute complete spread from nursing, paramedic, medical, and other practitioner backgrounds? Who engages in the course the most?
So it's absolutely a really wide range of the MDT group. There are lots of clinicians, but there are lots of paramedics, there are lots of nurse practitioners, lots of medical students, nursing students, and anybody that is remotely involved in critical care has signed up for the MOOC. And actually, when we look in our comment section on our discussion forums, it's quite interesting because you get quite a different perspective from each different professional, and that just feeds into how we can adapt the run for next time, essentially.
We've had a lot of flight doctors and practitioners, actually. They seem to be interested, and I don't know whether that's because we've provided this forum for discussion between some niche facets. One of the things we aim to do was to be able to share that knowledge between professional groups who might not have linked up with AMREF in East Africa before and might want to learn something to add to their practice.
Okay, fantastic. So send us a slide, we'll put it in the Q&A so people have got access to it. But thank you very much.
Thanks so much.
Thank you so much.
Thank you. We're going to move on to coffee, I think.
Yeah, we're going to take a break now until 11 o'clock. I hope you enjoyed the first round of speakers. I think we've had some really interesting talks from a range of different speakers, and we hope that you'll join us back at 11. We've got over 100 people logged in at the moment, which I think is fantastic, and we hope you stay with us for the rest of the day. But go and refill your coffee pots and grab yourself some biscuits, and we'll be back with you at 11.
Thank you. Welcome back, everybody, to the next part of the meeting. Our next speaker is Dr. Mike Slattery. He describes himself as a man that works in London but has his heart in Wales. He's a consultant in adult critical care at Guy's and Tommy's in London, and alongside that, he's the national clinical lead of the adult critical care service in Cymru. He's been the lead since its inception. And his belief is that critical care is a process and not a location. He also thinks that when a patient needs to be transferred, they shouldn't be labelled as too sick to transfer. And he says this principle has guided his career up until now. I'm sure he's going to give us a very interesting talk about how the service works in Wales and is his experience as the lead of that service. Mike, are you there?
I am. Good morning.
So we can hear you. Can we see you?
I've got quite poor bandwidth my end. I've just found out from my team's meetings this morning. So in the interest of things moving smoothly, I might leave my video off if that's okay, and then put it on at the end for questions.
That's absolutely fine. Can we see your slides? Can you share your screen with us, please?
Yeah, I can do that. Absolutely. Yeah.
Thank you. Okay, pop your first slide up, Mike, and then it will be over to you.
You should be seeing a black screen, is that right?
Yeah, we see a screen. Yes, we see a screen with your name on it. You started screen sharing. Excellent. Yes, we can see your slides.
Awesome, brilliant. So I will get going if you're happy. So thanks very much. I'm not sure the description of me describing myself as some of those things sounds a little bit pompous, but I guess what I've always been interested in is how we deliver critical care and anaesthesia outside the intensive care unit. So the sort of country of Wales, not all of you are necessarily, you've probably all been there. It's not particularly different from other countries, and actually the principles of what we're talking about today about remote and rural transfer settings is very much applicable to many other settings and many other countries. And so far, those guys who've sat the DIP-RTM, for example, we're still learning from our Australasian colleagues, for example. So we're going to talk about Wales. So a country is divided by lots of people at the top and lots of people at the bottom, not very much in the middle. It's quicker to get to North Wales from London than it is from South Wales. So the road infrastructure is not particularly good, and the mountainous regions of it limit some of the aviation considerations that patients, because we think you often can't fly, so it's not the solution to everything or the panacea. So I'm going to talk to you a little bit about ACCC Cymru. You've given me a very nice introduction, but essentially I've been trying to make transfer great again since 2019. It's a terrible picture of me, but the hat's fantastic, bought for me by one of my fellows. And I think it's an exciting time to work in transfer medicine because the sort of commissioning of multiple transfer services in the UK means that there's a real community of people that work in this field, and what was traditionally taught perhaps isn't necessarily there's more dogma rather than fact. But I don't do this alone, and the two ladies there are my service manager, lead RTP, and Beth, are ops lead, and then David Brent is the ops lead in North Wales. And the chap at the bottom's our administrator, Jack, but to be fair, he's been with us since the beginning and knows as much about the service as I do. So it's really a credit to them as well, not just what I do. So if we look at Wales from a schematic perspective, there are two roads. In the north is the A55, and in the south there is the motorway for most of it, and then it sort of goes to the A48 down here. So there are no roads in the middle, as I mentioned, and the only way to get from up here is to go around the coast. If you go to the middle, there are roads which are very, very small, not suitable for large ambulances at reasonably high speed. Now, in Wales, most of our specialist services are in NHS England, and we'll talk about that in a minute. So this is the trauma centre in Cardiff, and you can see that's quite far away from if you're up here in Bronglais. Now in North Wales, we go across to Stoke. So what ACCC principally does is works with our EMRTS colleagues to transfer patients from all over South Wales and North Wales to get them to definitive care, wherever that might be. So you might ask, if you know healthcare is not particularly great, well, why would you live in that part of the world? So it's a balance. It's work-life balance. It's a fantastic place to live. I'm very happy to go to West Wales when I'm back from London, and it sort of rejuvenates the soul, because you have places like Tenby, which has beautiful boats and colourful houses and an abbey and a variety of other things. So it's great to visit. My hometown Swansea has got this is Three Cliffs Beach, where you can get involved in lots of water sports and hurt yourself, which is obviously feeds into the trauma centre. And when I'm on the HEMS team, I spend a lot of time fishing them out. You never want to land on a beach because you never get sand out of the helicopter. And then this is one of the slate quarries that you see, and if you drive through the middle of Wales, you'll see beautiful glistening slate, often as the sun sets. So it's a beautiful place to live, but you make a choice by doing that because you're so remote from specialist services and often definitive and sometimes time critical care. So the other thing to say is that patients that move to West Wales often are retiring. So you have patients with lots of comorbidities and lots of problems, but they've got those complex problems can't always be managed in their local hospital. And when they do deteriorate, we're responsible for transferring them for that distance. So I kind of apply it to a beautiful place, much like the Bolivian salt plains. But if you're looking for specialist services on the horizon, there are none there. Now, as a part of sort of cost saving and general principles in medicine, what we're tending to do is to centralize services in one place. And each transfer service is a centralization of a resource doing high volumes of things, because we know if you do high volumes of anything, you get a lot of experience, and you learn lessons, and you can share the learning, much like we're doing today. There are some people that argue that you need to have a certain level of care in each individual hospitals, and that's becoming progressively more problematic as we downgrade intensive care units to become less interesting to work in. And we get past this by talking about having clinical networks and clinical communities. This is the Starlink system, which obviously been pioneered by Elon Musk, and we'll hear a little bit more about that later. Now, fundamentally, if you need something with a degree of urgency, it always comes down to physics. And as much as I'm aspirational, I've not worked out how to fold time and space yet. But the distance and the speed at which you move limits how quickly you get definitive care. And sometimes that needs to be quite quick, and sometimes that could be a much more slow time pace. Now, if you take some examples, so if you're, can you see my cursor? Yep. So if you're down here in far West Wales, for you to get to the major trauma centre, it's at least 2 hours. If you're up here, that might be 3.5 hours. And to move within the individual health boards, your average transfer in Wales between hospitals is an hour. In North Wales, it can be even longer, because the cardiothoracic services and the neurosurgical services and trauma services are outside Wales. So this road is the almost sort of single track in and out of North Wales, so it gets very, very busy, especially during the summer. So the essential problem is that we are limited by the fact that we can only go so fast. We can't always access a helicopter, and we'll talk about that in a minute. But principally, distance is a challenge for us. So therefore, we need to focus on delivering high quality care along the way. Now, in West Wales, working in the rural unit, it's often quite difficult to recruit intensivists, anaesthetists, emergency physicians, because as you lose services and the hospitals become smaller, for a new consultant or somebody that's trying to cut their teeth, so to speak, in a management sort of setting, it really is not particularly attractive. And along with that, when we invest more money in bigger centres, often the smaller health boards are forgotten. And for any of you that work and have met farmers, most of West Wales is full of farmers. They turn up at the last minute when their arms are about to fall off, and the health-seeking behaviour is very difficult. And I think there's a typo there. Apologies for that. But the politicians and the people that design the networks really sort of sell it as, well, actually, you're going to get the best possible care when you need it, and there are steps in place to get you there, and that will be EMRTS, and more recently ACT, and we work in partnership. But if you chat to the teams and to the patients down in West Wales, there feels like the system that's described and the access to specialist services prior to the launch of ACT has been suboptimal, to say the least. So we're pretty clear that there's a gap, and what we've tried to do as a service is to step into it and to fill it as best we can. So how did we do that? So we've got two bases, one in North Wales, one in South Wales. The North Wales base is based in the Bangor hub, and in South Wales it's based at Cardiff Heliport. And hopefully in the near future, we're going to have a base down West Wales to service this population, trying to increase the time by reducing the distance for us to get there as a critical care team. So we talked about this, or you've alluded to it anyway. I mean, I think from my perspective, I firmly believe that critical care is a process, not a location. And I'll talk about how we've aimed to deliver that. Why is it fair that a patient has a step down of care when they need to go to have an intervention, when they need to be transferred between hospitals? Because when we think about it from a practical sense, if you design the system well, there's no reason why a lot of the things we do in an intensive care unit, and we'll talk about in a minute, can't be delivered in the transfer setting if you put your mind to it. So as a service, what we've tried to do is use this principle to make sure that we have equity of access for patients in irrespective of which hospital that they live in. The most useful thing, our service evaluation is due to be published very shortly, and actually the flow both in and out of the specialist centres, both within Wales and within NHS England, means that there's a very good relationship between ACT Cymru and those specialist services, because we get patients in, but we also get them out to make room for the next patient. And as a service, it really feels like transfer medicine is a bit of a blank slate. I mean, in Wales, for example, I know when I first took up this post, I had a blank piece of paper, lots of people with opinions, and we looked at, well, what does great look like, and we tried to design that as we've gone along. So what we tried to do is to deliver high quality critical care by design from the very start of the service, and we're continuing to innovate. So the problem we have is that we're not quite sure about some of the definitions in transfer. So on the operational ONC meeting, where we're looking at what defines a long distance transfer, and from my perspective, if you're transferring patients for 2.5 to 3 hours routinely, it feels like that's a long distance transfer. The average job cycle for us is somewhere in the region of 4 to 5 hours in North Wales, and a little bit shorter in South Wales. But they're long distance jobs, and it's difficult if you're looking, well, actually, when do you deploy a helicopter? When's a rotary wing useful? When we would use a fixed wing aircraft? If one's available for both options, how would you set the standard? I think that those sort of questions are things that as a community we are addressing, but it's going to take time, because if you're doing a long distance transfer from for example West Wales to London, which we relatively routinely do, those challenges can be broken up into patients, the team, and the logistic challenges. Now, what I will say is that we've tried to think about these things from the beginning. So we'll start with the patient, and I think this is not necessarily about physiology, but it's about how we address the needs of that patient within the transfer setting. So this is the inside of our ambulance. So we've designed everything around the patient. The patient is the focus of our care, so it should be the focus of our design. And the stretcher you see there is the Harrier stretcher for bariatric patients, or those patients living with obesity. And you can see that the ambulance is much wider than a normal ambulance. The clearance is much more than you'd normally have. There's seats. There's more seats in the back, and they're actually designed to be comfortable with drop-down tables and appropriate USB charging and things, so that on the way to a job, it can be an office or a study area, and on the way back, then it turns into an intensive care unit, and then it can again become a office or rest area on the way back. And people will laugh, but at the back on the right hand side, as we look at the screen, you can see there's a hot water boiler. So if the team want to do a brew when the patient's not on board, then that's fine as well. I mean, I think that was probably not one of my best decisions, but I think it's something that we tried, and it's interesting. The other thing you'll notice is that the ambulance has double doors. So that means if the patient deteriorates and you find an appropriate place, you can create more space by opening those doors, and the bags can be accessed from both inside and outside through those lockers at the back. There's a big fridge on board, which is in one of those lockers there, and we've designed the gas inlets and outlets, but to be dropped down from the ceiling, much like you'd have in the operating theatre. So I would argue, with the exception of hemofiltration, and I have found a machine that you can use horizontally, you can deliver most interventions in a transfer setting. And you'll notice that this bariatric stretcher doesn't have a bridge or anything to mount it. So we've actually designed a specific mount to go over it that we've worked with Furno to deliver that. So what we never do as a service is try to just couple things together. It doesn't fit with what we're trying to do. We always strive for the best solution, and if that's going to take a bit of time, that's what we'll do. And we've just received the delivery of the brackets. I've not got a picture on the air, but it's a fantastic solution. We presented it at the Sober conference and won a prize because it really is designed around the patient. So these are our 3 ambulances we have at the minute. So these ambulances were designed from scratch. They've got lovely names. They're Enfys, Gobaith, and Goval. I'm not going to lie, there have been problems as we've gone along, but actually we were very impressed with the platform, and we're now looking to order some more ambulances and learn from what we've done before. But the double doors has been an absolute game changer for both egress and ingress, and also managing patients when they deteriorate. So the other thing we've got on board is we've got a bronchoscope. So there's a screen that drops from the top that you can plug in this bronchoscope, because we manage these patients for prolonged periods of time. And actually, if this piece of kit is in the algorithm and you've got a consultant intensivist on board, then you absolutely we need to give the kit to the teams to do what they do well every day, and that's what we certainly strive for. So I think it's fair to say that we've developed what is essentially a mobile intensive care unit in practical terms, and there are very few interventions that cannot be delivered in transit. So therefore, critical care is a process, not a location. And if you've got the right staffing mix, which we'll talk about in a minute, I can't see the difference. In a way, the ratio becomes much more favourable for the patient, and therefore we're already seeing, again, none of this is that's published yet, but the patients often have improved physiology by the time they get to the other end, because you've had an intensivist sit and look at you for 4 hours with a focus to try and make you optimize you as best as you can. Now, John F. Kennedy, I mean, he was talking about business at the time, but I would say that the distance is actually our friend, because it gives us time to do meaningful interventions in transfer. Now, the important thing I would say about this is if we've got a patient that needs a time-critical intervention, or as an urgent uplifted care, you need to maintain clinical momentum, and that's absolutely paramount. But if when you're en route, rather than just sitting and writing down the obs, you can continue to do the things that you would do on a normal intensive care unit, because you've got the physiological monitoring, you've got the ventilator that's able to do, I mean, most of you guys I think use the Hamilton, we do as well. We've got Hamilton Connect. That ventilator is as good as we found out in COVID. Most intensive care ventilators at the bedside, and some units use those solely. So I think distance and time is actually our friend, as long as we use it appropriately. Now, the concept of being too sick to transfer is something I think is a historical relic from before specialized transfer teams, because there are, most of our services, within our service, we have full-time RTPs that all they do every single day. They're retrieval and transfer practitioners. There's experienced nurses. We'll talk about their development program, but basically they do this day in, day out. We've got a selection of intensive care consultants that work with them on a regular basis. We've got quite a small team, but by choice. But that means we've got people that look after these sick patients very, very frequently. If you work in a small rural hospital, you're going to see a cardiogenic shock patient that's really, really sick, that's Sky E, very, very rarely. But actually, because of the nature of us supporting a region or a country, we see them with increasing frequency, and that affords us experience that's much more rapidly gained than you'd see in a normal intensive care setting, in a hospital, in a small hospital that doesn't have a cardiac flavour. So we presented some work at the state of the art in the last few weeks, which has demonstrated that we've got very few complications, almost no complications for this sick group of patients. Their physiology is maintained or improved, and actually we're picking the right patients so that when they get to the other end, they're having a useful input, and they're not dying, and then they're coming back to their family. What we don't want to do is to transfer people to be palliated. So when someone says someone's too sick to transfer, I'd very much see it as a challenge, and obviously fighting off the two enemies of the patient, which would be hypotension, hypoxia. You can choose which, but I think it's important that patients should probably be labelled too sick to stay. So if there is an intervention that can help them, that is available to them by a hospital or a centre that feels there is benefit, then we should argue. What I would argue is that if you stay locally, all you're going to do is deteriorate further, because you can't fix it, and the patient's likely outcome will be poor. Now, there's that concept of a window, and that people talk about optimization, waiting until tomorrow. And what I'm saying, we don't have to rush out the door, but just because the patient's very sick shouldn't be a barrier to us transferring the patient, as long as we go into it eyes open, because there is a window, because the sun is setting on this patient, and we've got a chance to get them to definitive care safely, so that they can have their best chance. And we've because of the nature of Welsh services, we experience this a hell of a lot more, is what I would say. So the team. Now, traditionally, where we've tried to get around the challenges for the team is that we have a random, when I first started doing transfers, I got a vomit ball of drugs, chucked in the back of a van with an RTP, with a OGP I'd not worked with before, with a patient that's herniating, and good luck, lean into it, boy. And that's the situation that I found myself. Now, that's not the situation anymore, is it? We've now got pit stop teams of well-trained practitioners and doctors that do this every day, that have SOPs and experience. So how can we make sure that we're able to deliver the best for our patients by addressing the challenges of having a team that's capable of transferring a patient irrespective of their physiology? So the key thing I would say all of this is we need to make sure we look after their well-being. So that's making sure that they're appropriately rested. That if they're at the end of their shift, then we wouldn't ask them to do a massive overrun, and they have access to appropriate services for the horrible things that they see. But as a service, we're quite close knit, and everyone seems. At the start of the service, we have a 2-week induction, and it creates quite a significant bond, largely probably because of the psychological challenges of being simmed to death by me. But the key thing about training staff is that you can't learn to swim without getting wet. This is the Victorian children learning to swim in the schoolyard. And the induction weeks, training weeks, we spend a lot of time doing it. So they start off as younglings, and what you want is Jedi. So many of them have described it as an experience, not an event. And we look at all the little things. So these are specific ampules of drugs that are mocked up, that have been produced specifically for us. Because when you say in a sim, I'll just draw up some amiodarone or whatever, you've got a team of 2, so you both need to be able to do it. So the sims, they actually do things in real time, so they have that muscle memory, the practicalities around it. Now, it does mean the sims are longer, but they're much more immersive, and the sort of simitis is, and the make-believe is dispelled. So we use pyrotechnics. So this is our fire in the ambulance sim, which we got trolled for on Twitter when I first did it at the beginning. And this is the ambulance that caught fire about 18 months ago. It's not one of my new ones, thankfully, because I'd be in tears. This is a WAST ambulance that they loaned us whilst we were getting some servicing done, and this is what we find ourselves now. There was a patient on board. The team got the patient off. They got themselves off safely. They even had time to get the HX cylinders out of the side, so it did become explosive. So they did that because they'd done it before. They talked about it. They thought about it. And they debriefed it. And whilst these things are very, very rare, when the shit hits the fan, you want to have thought about it once before. We teach everyone how to use all the immersive devices. We do surgical skills, etc., so that they get the best possible experience for before they look at patients. And you know, the feedback from trainees is consistently that it's the best training experience they've had in their life. So we also use drones. So this is us. They always train in the team as how it would work, so that we don't have people pretending to be something else. You're a doctor. You're a doctor. If you're RTP, you're an RTP. And we've got a lot of faculty from both the MRTS and from ACT as we've grown. And we train for things that are rare. So this is a patient that's come across a running call, because in Wales all the ambulances are outside hospitals. So we spend time looking at. We come across things. We've had 5 or 6 running calls so far. Then the management team get involved. So this is David Brent on NIV. Doris, I think, was his name. But you know, the thing is both fun and immersive. But you can't just play on sims. And we've written and have started a advanced practice retrieval and transfer medicine MSc that's starting in Bangor University in October. If you want the link for that, I'm happy to do that, which addresses a lot of the DIP RTM components, and then is a great part of the progression pathway from a practitioner to advanced practice. Obviously not an ACCP. But you know, we have fun while we do it. I perpetually in shorts and flip flops, but it's Prateek's in the middle, who's going to talk to you later. But it's great fun. People feel part of something, and then that means they're willing to go the extra mile. Now, don't get me wrong, it's been a bit of a roller coaster. This is Velocicoaster and Universal Studios. So logistically, I appreciate I was tight for time. What we want, so this is Guantanamo Bay. I'm not supporting this, but when you get a referral, you interrogate the referral. You don't just accept it as a handover, because you need the information to make the best choices for the patient, so you can decide what you need to do, what team you need to send, etc. And we have a nurse coordinator, who's one of the RTPs that is jobbing RTP on a day-to-day basis, and they sit and support both teams and do all of the logistics. The teams focus on the patient, all of the phoning, documentation, referral bits and pieces, and also for the units, we offload the unit and take ownership of that as well. So helicopters. So the helicopters are great. I love them. They're fantastic. But you don't put a very sick patient in a helicopter because the access to the patient is very limited. The Wales Air Ambulance has been very supportive to us, but actually managing a patient in this setting is difficult, and actually often doesn't save time. So I think Mahatma Gandhi says is probably best is there's more to life than simply increasing its speed. So going very fast doesn't necessarily solve the problem, because you've got the slow bits either end. Now, the level of the patient in terms of level ICS level is really, really important. So for level 3 patients, it's quite easy. I mean, if you're really, really sick, we can do intensive care as we go. But increasingly, we transfer patients that are sort of level 2 that for uplifter care, for example, for liver transplant. Those patients may be encephalopathic. They're obviously on lactulose, and the patient needing to open their bowels in a dignified manner, for example, in the ambulance is something that is not really covered in intensive care curriculum, but we're learning, and we've now got things for long distance transfers. More recently, we've got a DRC tier, which is a FICM accredited intensivist that supports the coordinator, and then can use common language in clinical communities to work with MDTs, for example, in other services. So I think 2 sector transfer is something that we will continue to challenge as a service. I will skip to the end. I think what we're doing here is important. And if you think that just doing an SOP or something for a service won't make any change, but it's got to start somewhere. Listen to your critics. We're writing history as we go. This is ACT. I'll skip to the end. We need to capture data. We'll make some more Jedis, and we'll start where we left off. So I think happy to take some questions if anybody has any. I'll stop sharing my screen. That was a bit fast, apologies at the end.
Thank you, Mike. That was fantastic. I think we need some more Jedis as well. So I think we probably need to get some of those lightsaber things up here at Nectar. I couldn't agree with you more about the too sick to transfer concept. And actually, it's all about doing what's in the best interest of the patient. Because I agree, we don't want the Mike's cameras.
Yeah, I've tried to turn it on. It's my work laptop.
So does it, Mike? It's fine. You can. I don't.
You've seen a lovely picture of me. I can put that slide back if you want to see that one.
Whatever you want to put back on,
No,
it's absolutely fine. What I was going to say is what we don't want to do is essentially have the patient dying in a different location. What we need to that's what the decision making is about, rather than they're just too sick. I couldn't agree more. Now, there's quite a few questions, but really the thing that we were incredibly jealous about here was the design of your ambulance, which looked amazing. I mean, you had us on the T-boiler, but even regardless of that, the doors on both sides to access the kit, the layout, it just looked fantastic. So one specific question is, how many seats have you got in the back? Do you have 4 seats?
Well, 4 seats. Yeah. So there's 3 seats. There's what was traditionally called the airway seat, which is the one that's rear facing, and then there's 2 seats to the side. There is a 4th seat, which is the intermittently used. Now, with the bariatric patient in, that's slightly challenging, because with the arm deployed, so we have 4 seats to the back is the answer. So the thought with that is, you've got the primary physician, you've got the retrieval and transfer practitioner, and from the very beginning, I'm concerned that the transfer physicians of tomorrow aren't getting the opportunity because we're doing the transfer. So we built that into the ambulance, and then the slightly cheap seat, it wasn't cheap, is for a specialist payload. So if you've got like a perfusionist, for example, that's most commonly used for if we're 4 up.
Okay, and what's the weight limit on your on the trolley or the stretcher element of that patient weight limit?
I think it's 280 kilos, so we never get anywhere near that, because most of it, because the weight of it is around the trolley is rated for the weight of everything that's on it, not just the patient, isn't it? So most of the weight is actually the kit that's around it. Yeah. So either 280 or 320. I'd have to double check for you, but it's not been a limiting factor for so far.
And design, so the actual design and the kind of the work that's gone into design is absolutely evident, even from just looking at a still picture. But how much did the design itself cost, and how long did it take to do?
So I got a piece of paper. I designed it with the company. The company didn't charge us anything for the design. We did an iterative process where we went up, sketched out things, and then basically talked to them about each individual element. The ambulance themselves, if that's the question you're asking, I mean, the design, it was all in. They were 210,000. Okay.
And you said you're working on the next design already. Is there anything specific you're changing for the next design?
So we look like we'd like to get it a little bit wider and a little bit longer, because these ambulances aren't going to ever go and do frontline work. So they're only ever going to be within a hospital. So therefore, you can be slightly more imaginative with those things. The double doors we're keeping. The bronchoscope screen we're keeping, but we're enhancing it. And there are some other elements of what we're looking to do in the next generation of ambulances that you're going to hear about shortly. But what we're trying to do is build on what we've done, but connect those ambulances further from where they were, increase the connectivity, and then also try and increase the crew experience even further. So I think those seats are quite comfortable. The charging is okay, but the design of the workstation that comes out isn't as good as it could be. Mm-hmm. It works, but it's not perfect, so we have to try again. We're very happy with them. The one thing is that whenever you have a prototype, the first one that came out, which was Memphis, the Rainbow, she's been very, very difficult. We had a few problems with her when she started, but we're learning, that was, the company had never built this thing before. Yeah. So therefore they were learning as much as we were, really.
And then we also wondered how you approach time critical transfers, because you've told us about the distances in Wales and the road infrastructure. So how do you make a decision about whether you're going to deploy for a time critical transfer or whether the local team is going to send that patient to the specialist centre?
So that's a really good question. So we work in partnership with the EMRTS, which is our HEM service within Wales. So they have no ambulances. They have a car and helicopters. Now the reality of the situation is that if the patient needs to go, we'll launch and see whether we can get there. There is a challenge in Wales that the people that do the transfers, there isn't very much experience. So now the junior doctors that would normally do the transfer haven't done transfers, so therefore they haven't done it's a real problem. And then obviously there's not often an ambulance. So our ambulances aren't part of this response model. So the reality is we do a lot of time criticals, and the hospital teams during daytime hours between EMRTS and us, it's an exception rather than the norm. Because I know that's different to other services quite considerably, because you want to get the quickest possible time. But even with the challenges we have, we just launch and try and get there. And usually, to be honest, because we're delivering a lot of the interventions on the way, I appreciate we're not doing neurosurgery, they often turn up in a better situation than when they originally got ill at a hospital. Because the biggest problem for us as a service is not necessarily time critical patients, but those they can be time critical, but those patients that have some intensive care needs or enhanced care, but it's that not sick enough for us traditionally as a critical care transfer service, and then too sick to be taken by a conventional paramedic. And that enhanced care piece in the middle is the aortic syndromes. I know there's guidelines around it, but for example, when I work in London, it's all very common for a paramedic, before access, to turn up with a pump and hand it to me going, it's been alarming for the last 20 minutes, and the guy's blood pressure is 250. So whilst that doesn't have a particularly high need, that's the bit, critical care need, that's the bit that I think we're falling short of, because we're too interested in the super sick. So we always try and come up with a solution within the service.
That's really interesting, because I think that's how we're finding that we're working as well. Are you, so for the kind of time critical patients, are you deploying on minimal information and then information gathering en route to kind of make your plan, rather than getting the information at the beginning and then deploying? Is that essentially how the service works?
So we call it a send and support model. So what we send the team, and what we do with our duty retrieval consultants is, in those smaller hospitals, we'll stay on with them if they're happy, because they're often they're not intensivists, they're anaesthetists covering the rota, or they're covering a PACU, and we offer to support them as we go along. And usually, if they've been accepted by neurosurgery, it's rare that we get a stand down, is what I'm trying to say.
Yeah.
We get there, and sometimes they're not quite as bad as given, but they still do well looking after by experienced team. And
do you ever have a problem with prioritizing taking people out of the centres to make space for those going in, or do you have a specific pro forma that you try and do the people going in first and then the people going out second? Or is that not a problem? What we do in Wales every day is we chair the national sit rep. So we have a call with all of the intensive care units in Wales on the call. In honesty, North is not as keen as the South in it. They don't always attend, but that's chaired by one of the coordinator from ACTS. So we've got situational awareness of what's going on, and then we will have a bit of a huddle after that to try and work out if there's lots of requests. But in reality, our busiest time is around sort of 5-6 o'clock, as the sort of clinical stories have evolved throughout the day. So that sit rep is invaluable for us to get situational awareness of all the challenges of individual units. Okay.
To answer the question.
I think we could talk to you all day, Mike, because it's super interesting, but we're going to have to move on to the next speaker.
That's absolutely fine.
Also works within your service, so we're going to hear about
the legend. I'm excited to hear his talk too.
Fantastic.
Thanks, guys. Cheers. Thanks. Hi, Prateek.
Hello. Hi.
Next, we have Dr. Prateek Verma, who's an ST8 ICM and anaesthetics trainee in Sheffield, who's currently undertaking a clinical fellowship in transport and retrieval medicine with the Welsh Adult Critical Care Transport Service. Been working on a really interesting project to introduce live 360-degree videography into transfer medicine to help improve remote support. So we're really looking forward to your talk, Prateek. Thank you.
Thank you. Can you see my slides in a
So I can confirm we can hear you and we can see your slides, so over to you.
Lovely, thank you. So good morning, everyone. Well, as Mike's described, it's a really exciting time for retrieval and transfer medicine, isn't it? Especially in the field of innovation. And I want to share with you what me and my team at ACCP have accomplished in the past few weeks, really. At ACTS, the provision of uninterrupted, high-quality, equitable and patient-centered critical care is a process, not a location. And we therefore strive to provide this for all inter-hospital transfers. Our current model is a physician-led clinical team composed of a doctor, a retrieval and transfer practitioner or RTP, who's an ITU nurse with further training in transfer medicine, and a critical care transfer assistant or CCTA, who's an ambulance driver with further training in transfer medicine. But our next step as a service is to introduce a practitioner-led team. The clinical team is remotely supported by a duty retrieval consultant, or DRC as we call them, and a coordinator who themselves are an RTP. As a service, we've designed our entire system around the patient. Bespoke ambulances have been designed to transfer critically ill patients over long distances across Wales and on occasion to England and Scotland. The provision for remote support has been included in these ambulances from their inception, with the Tempest Pro and Causium system for the patient monitoring and the Hamilton Connect for the ventilator. Now imagine there's an emergency and the clinical team needs support. With the current setup, the DRC and the coordinator can remotely view the monitor and the ventilator. But for any clinical and situational reports, they must still rely on the information provided to them over the phone by a team that's stressed, cognitively overloaded, and trying to multitask. They've got no visual appreciation of the situation. They can see the data, but not the patient. And this can sometimes lead to subjectivity in interpretation of the situation and subsequent variability in the clinical advice provided. So how do we put the DRC and the coordinator virtually inside the ambulance, providing complete immersion and all the visual aids they need to support a team in crisis? Well, as you can see here, the conventional method of using phones, while probably cheap, is by no means immersive or flexible. So the obvious choice was to look for any existing solutions to this problem. However, what we found were costly ambulances with a defined set of features that still wouldn't give us an immersive 360-degree view and couldn't be updated as technology improves. There was nothing that was built for our purpose. Now, as a service with nearly 3 years of experience and an established record in innovation, we strongly believe that design is not just what it looks and feels like, but also how it works. So we were determined to create an innovative, beautifully designed, and user-friendly solution to this problem. We needed a system that does 4 things, basically: provides a complete 360-degree view of the inside of the ambulance, live streams it to the DRC and the coordinator, can be controlled by them so that the clinical team can focus on patient care, and fits neatly onto our stretchers so that it's easy to install and remove. We extensively researched the market for available options and trialed a few different combinations. And I'm glad to tell you that we've achieved all this and more. Today, we are redefining the way remote support is provided to clinical teams in our service and across the country. Now, no matter how well you design an ambulance, there's still hardly any space inside, and audits are difficult to conduct while in transit with a patient. Anyways, there are usually only 2 team members in the back, and they are both engaged in patient care. We've all also done simulations, hopefully in a moving ambulance, as Mike's alluded to before. We do it in moving ambulances for better fidelity. In the current scenario, while conducting sim, the facilitator stands in the back of a moving ambulance, struggling to stabilize themselves while trying to deliver the simulation, observe the candidates, and take notes, which is risky and leads to missed opportunities during debrief. So how can we ensure 100% compliance with audit performance in the transfer environment without any bias and provide better, safer, and higher fidelity simulations? Well, sure enough, the system we've designed allows us to do all of this and is underpinned by a robust governance process. So then how are we going to achieve this? Well, to lay a strong foundation, we're going to start with a 360-degree camera, use a click mount for ease of installation and removal, mount it onto a selfie stick so that its height and therefore its field of view can be adjusted, and then secure it to the bridge of our stretcher with a simple bolt. We're then going to connect this camera to a tablet known as the slave device inside the ambulance via the camera's own Wi-Fi and application. Now, this can be any tablet available on the market, an iPad, Android. It can even be a box that is running any of these operating systems. And then in terms of mounting options for the tablet, you can mount it whichever way you like. We mount it in two ways. It depends on your ambulance. We have the in-track system on the wall of our ambulance. So we use it to wall mount our tablet while we are still in the truck. And when we want to take the stretcher out of the ambulance, we have a separate stretcher mount that clamps onto the bridge of the stretcher. And then we can take the whole solution with us wherever the stretcher and the patient goes. This tablet then connects to another tablet or computer known as the master, which the DRC has, or the coordinator can have as well, via a remote support app. And this remote support app can be, again, anything you like, SharePlay as in iOS, or TeamViewer, or any other third-party app that you like. And this gives the DRC full control over the camera, as you'll see in the next slide. Now, in our test unit, we've trialed various options, including sharing the video and audio stream through the same app or through different apps simultaneously, and all of it works seamlessly. As you can see, we're not locked into a particular ecosystem. We can change any of the components of this arrangement at any point as technology improves or our requirement changes, and we'd still have a functional system. And as you see here, it actually works. The DRC with the master device has the ability to pan, tilt, and zoom the camera to the area of interest, get a visual impression of the situation, and appropriately advise the clinical team, who in turn are completely hands-free and can focus on the patient. In fact, this can be scaled up to as many devices as we want, depending on the need, and this allows us to bring the specialist in the receiving center to the patient's bedside. The control, however, always stays with the DRC, who is the responsible clinician making the decisions. As you've seen in Mike's presentation, we've got fold-down screens where we can view bronchoscopies. And with our system, the DRC can view any intervention that the clinical team is doing, as you can see here, in real time. Now, every doctor or RTP in our service does not have the same amount of training with point-of-care ultrasound, but we don't want this to affect the care that the team deliver to our patients. So using the same principles as outlined above, the clinical team can share their screen while performing ultrasound, and the DRC can view and control all functions on their screen and therefore guide examination and management. Now, we're trying to solve a problem here and simplify things, aren't we? So how do we make sure that this system connects seamlessly and does not become a chore in the event of a clinical emergency when immediate support is needed? In our prototype, we've automated this process with the help of macros such that the connectivity burden is very low. The clinical team need to physically switch on the camera and then click twice, and the DRC only needs to click once for the whole system to work. The clicks at the clinical team's end are deliberately kept at 2 to ensure they've got the power to allow access to the live stream. But while all of this looks cool, how is this innovation going to actually enhance patient care? Well, with this versatile system, we've created an immersive, remote clinical decision tool that can be scaled and tailored to the situation and user preference. We've enabled remote clinical governance, and we've revolutionized transfer training. We've even created 360-degree virtual tours of our ambulances and labeled individual sections with their contents, and we're using this to familiarize new members of the team with location of kit before their first clinical shift. This also helps in clinical situations. While the DRC views the live footage and troubleshoots the problem, the coordinator could access the virtual tour and help the team locate appropriate kit. This system also gives us the flexibility to use simulations to interview people from across the world for jobs in our transfer service while maintaining the exact same standards, regardless of the location of the candidate. Now in ACTS, we take privacy of our patients very seriously. And therefore, there are a few different checks in place to ensure it's the clinical team that have got the ultimate control over access to the system. The first is a physical cover that slides onto the camera lenses and the microphone. Unless this is taken off, obviously nothing is visible or audible. Secondly, the camera is always switched off and can't be switched on remotely, so it would have to be the clinical team who do this. The remote support software that we're using, any remote support software that we use, as you've seen, the clinical team need to click twice to allow access to the DRC. So unless they do it, the DRC is not going to be able to access anything. And whatever software we use, we have corporate licenses with them. So any access gained is always auditable. And we are working with a company to actually have a single sign-on with all Windows accounts. So, it'll always be trackable who's accessed the live stream. Now, while this system is actually functioning, how do we prevent data leakage? Well, first, there's a unique password to connect the camera to the tablet, which only we have, so no other device can connect to the camera. Second, the data is never transmitted outside the camera and tablet interface. It's just local. And third, as I mentioned, we're using corporate licenses with the remote support software that we use, so we get the highest level of encryption. And therefore, with the help of the cyber department at Swansea Bay University, we've completed a cybersecurity impact assessment and got their stamp of approval to use this system safely. We're presently working with the IG team, or Information Governance team at Swansea Bay University, to complete a data protection impact assessment. Essentially, there's no memory card in the camera, so there's no ability to record, and therefore no issues with data storage. Our SOP will ensure that every member of the team is compliant with the use of this system. And we're putting up privacy notices within the ambulances and on our website to make people aware of this system. During our induction and CPD events, though, we will be recording and timestamping for debriefing and scenario development, but that would be in a non-clinical setting. So with the power to virtually place an ITU consultant inside an ambulance, the ability to mitigate challenges around audits, and the promise to revolutionize education for the retrieval and transfer specialists of tomorrow, this system designed by ACTS Cymru is the future of transfer medicine. Although there is something else. The ability to remotely view and control a 360-degree live stream of the clinical environment is amazing. But tablets and screens display three-dimensional images on a two-dimensional surface. They're also limited by screen real estate, such that the viewer needs multiple screens to view various sources of information about the patient. And therefore, this confines the user to a predefined space and decreases their productivity. So what would be even more powerful? Enhance this experience even further. Well, we've achieved unprecedented level of immersion by using mixed reality headsets to provide the DRC with a complete 360-degree view of the environment that the clinical team is in, so they can navigate as if they are physically present in the ambulance. I'll let you watch this clip.
Okay, that's 2 minutes, guys. Right, we need to get some adrenaline. Can you just suction up there? Where's the adrenaline? There's a bit here on the floor, guys. The back. It's knocked out the bag.
So as you can see in this clip, while the clinical team are focused on the patient and struggle to locate Kate in the ambulance, the DRC can help them remotely. The level of clarity of both the video and audio is phenomenal, and it immerses the remote support team in the real life situation. multiple sources of information can be overlaid in this environment, enabling uninterrupted focus on the patient along with easy access to essential physiological information, thereby informing efficient clinical decision-making. As a senior trainee in intensive care and transfer medicine with a broad range of skills, when I ask for help, I'm looking for a consultant to share their experience. And this innovation is a gigantic leap towards bringing the consultant to the patient's bedside with me when I need them the most. At Cymru, we believe in challenging the status quo in conventional medicine and consistently pushing the boundaries of innovation. We believe that every patient in the NHS should get the best possible care, regardless of where they are located, and therefore we'd love to share the knowledge and experience that we've gained with transfer services across the country. So we've packaged a test unit with all the accessories you might need that we can send out to you for testing. So if you as well believe that every patient should get the best possible care at every step of their journey, do get in touch either via email or by following this QR code. If this is what 2 people can achieve in 6 weeks, when we collaborate with colleagues across the UK and eventually across the world, imagine how beautiful the future will be. Thank you.
Ready? Yeah.
I'm happy to take any questions.
Hi, Prateek. Wow, that was an absolutely fantastic presentation. Thank you very much. Again, we were all very envious of the systems that you've got set up in place. It looks amazing. We do have a couple of questions. So the first one is, in terms of the model that you've chosen, was there a reason behind why you chose maybe using this type of software over a head-worn option? So, you know, you've got your camera mounted on the trolley. Is there a reason that you chose that over maybe having something that the head wearer could use at the top, if that makes sense?
Yeah, so if we thought about it, but the limitation with that is that only gives you the point of view of the person who's wearing it.
Okay.
And it can only possibly be worn by one person. If it's worn by the 2 people or the 3 people that are in the team, then the consultant has to view 3 different screens. And the consultant can't actually control what they are seeing. They only see what the person wearing the headset is seeing. Whereas with this, the team are completely hands-free, you know. In a head-worn system, the consultant might have to say, oh, I can't see that. Can you turn your head around to show me what's happening there? So the clinical team is then trying to do conflicting things. Yeah. Whereas with this system, the clinical team can almost forget that there's a stream going on, and the DRC can fully control it either on the tablet or on the VR headset, whatever interface they're using.
Okay, thank you. We just wondered as well about in terms of connectivity in rural areas, and is this problematic?
So we are just about to get a Starlink in our service, and we're partnering with another, organization. They've trialed Starlink across Wales in very remote locations, and it works really well. So we're going to be mounting Starlink in a dome on top of our ambulance, and thereby we'll have uninterrupted connectivity wherever we want.
Amazing. And then just one last question that we had as well. In terms of, obviously both yourself and Mike have talked very much about delivering interventions in the back of your ambulances. I just wondered, in terms of how often you need to do that in terms of the use of obviously this type of kit, how frequently do you need to do interventions that require this kind of oversight by consultants, clinicians, while you're in the back of the ambulance?
I mean, I guess it's difficult to quantify a number for me, but as you might appreciate, we've got a range of experience in terms of doctors who are in the back of the ambulance. And while the senior consultants may not need support for most interventions, the junior trainees might. And we are transferring, as you've heard, Mike, we're transferring patients over very long distances. If we're transferring someone from West Wales to London or West Wales to Birmingham, and we've done as far as Dundee, our transfers are like 4-5 hours long. And, I've transferred a patient with an LVAD in situ who was in VT at 200, with 2 infusions running. Mm-hmm. And if I need support, I've got just the phone. I've transferred an ARDS patient who we were debating whether to transfer prone or supine, and just that oversight by a consultant who's experienced in doing ECMOs, does this all the time, just, you know, takes the doubt and the, you know, out of the equation. So that really helps.
Sure. Brilliant. Thank you ever so much for your presentation.
Thank you.
Thank you. Our next speaker is Dr. Andrew Plews. Andrew is a UK anaesthetics trainee who spent some time working with the Royal Flying Doctor Service in Australia, and he's got a special interest in obstetric transfers. Andy is going to talk to us about his experiences working in Australia, and particularly about the obstetrics work he was involved in. So Andrew, we can see you, we can see your slides. Would you like to share
Hello.
the screen? Thank you.
Yeah, just got my timer. Yeah, thank you very much for having me. Today I'm going to be talking about obstetric retrieval, the challenges and emergencies that you might face undergoing when transfer. So first off, a little bit about my retrieval experience. I'm currently an ST4 in Stoke-on-Trent at the moment doing anaesthetics. However, I've recently returned last August from Australia. I spent 2 years in Australia after doing a little stint in COVID ICU. So from August 2021 to 2022, I was working for CareFlight, which is an aeromedical charity in the Northern Territory and New South Wales, but I worked in the Northern Territory. So I was based in Darwin. August 2022 to February 23, I was in Melbourne working for Western Health Anaesthetics. And then onwards from there, I was working for the RFDS, Royal Flying Doctor Service, for a short period. So firstly, because of my main experience with retrievals with CareFlight, I'd like to go through a little bit about what they do and the benefits they provide for people in Australia. So firstly, CareFlight, it's an aeromedical charity, have fixed wing, rotary wing and jet services. They employ registrars usually on a 6-month basis, and we're tasked for day shifts, night shifts, 24-hour on-call shifts and jet shifts, and they're all incredibly unpredictable. You work together in a fascinating multidisciplinary team, learn a lot of skills working with pilots, logistics, MRC, different air crew and engineers, nurses, not including our own, but remote care nurses as well in remote areas, midwives, retrieval consultants, numerous hospital staff and teams. There's just too many to name. So firstly, little look at some of the assets that we used. We had a number of Beechcraft Super King Air B200s. These are fixed-wing planes that can travel roughly around 500 kilometers an hour, a range of nearly 2,500 kilometers. I think we had 6 of these, all in slightly different configurations, but they were pretty much the same. You could have a pilot, a nurse, maybe a doctor on board, depending on the type of patient you may be retrieving, up to 2 stretchered patients and up to 2 seated patients or escorts. Sometimes your entire day would be flying around the entirety of the Northern Territory, picking up patients until you have a 4, dropping them off, then picking up more. It was a lot of fun, very good learning experience. Next, with our rotary wing, these usually used for our pre-hospital work, or sometimes when we were going to areas where they just simply didn't have runways that we could safely land on. So we had 2 different helicopters, the Augusta AW139, which you can see on the left, and the BK117. These were in response to primary trauma, search and rescue, and for inaccessible locations. They're useful because they had night vision capabilities, so you could fly at night. They also both had winching capabilities, which you got trained on for both. And then finally for the jets, on the left you can see the me next to a Gulfstream G150. We had 2 jets. The Gulfstream was the far nicer of the jets, a little bit bigger, had a toilet compared to the Nextant Beechcraft 400, which was a little bit smaller. They could both carry 2 stretchered patients. You can potentially fit more seated patients and their escorts, but usually you only really carry 2 patients at a time, because sometimes when you get too many patients in these craft, it becomes logistically very difficult to manage in regards to the number of staff you have available for these patients and also weight. They're useful because they can do international missions. They were fantastic for high acuity emergency missions. We call those J1s, and also the lower acuity missions. So the transfers which don't have to be done immediately, but would need to be done relatively soon, are J1, J2s and J3s. They were very useful for bringing patients to a high level of care not available in the top end of Australia. For example, neurosurgery care, heart and cardiac surgery that we didn't really have there in the Northern Territory. Also useful for international other countries. So in CareFlight, we frequently saw lots of varied cases. You turn up to work and you wouldn't have a clue what you were going to see or what you were going to do. Fantastic experience. So you'd see things like sepsis, lots and lots of cardiac and heart failure, lots of valvular issues. I saw a great deal of patients with rheumatic heart disease, which is something that from the UK, I only knew in textbook. Lots of pneumonia with weird and wonderful bacteria, COPD, bronchiectasis. Great number of people with CKD and missed dialysis, just simply because of the difficulty in accessing those the care in lots of the remote areas. A great deal of psychiatric issues. I think around 20% of our retrievals were due to psychiatric issues, and this was frequently due to drug-induced psychosis, depression. Again, also paediatrics made up a great deal of our cases, lots of preterm gastro, bronchiolitis, and again, obstetrics was also something that we focused on. And the reason why I'm talking about that today is because it was something that a lot of our clinicians, myself included, would always be worried about when we'd get an emergency obstetric case, just because of the difficulties that you may face when doing these cases. Then lastly, you'd have trauma, which is, as we know, incredibly unpredictable. Australia is known for its very harsh, inaccessible terrain, and we had some quite interesting cases there. But today I'd like to focus more on obstetrics. So why is it important? Why is the aeromedical service important in Australia? So where I'm looking at the very top end of Australia, we see Darwin. The orange area is the Northern Territory. CareFlight covered the top, I think it was 2/3 of the Northern Territory. When you see Australia like this, it is massive. Northern Territory comprises of, I think, about 500,000 square kilometres. The UK itself is only 94,000 square kilometres, and England is around 50,000 square kilometres. So nearly 10 times the area of England. When we're doing our JET missions, if you're going from, for example, Darwin to Adelaide or Sydney for higher level care, this is a trip of just under 2,000 miles. Whereas if you go from the top of the UK to the very bottom, that's 600 miles, so just over 3 times that distance. This brought some unique challenges. For example, when you're seeing patients in the Northern Territory, when you get the call for these patients, you could be 3-4 hours away from them. So they would usually have police or fire service on the ground able to give immediate care. And they usually have clinic nurses. And sometimes, if you're lucky in a large area, you might have a doctor or two able to give care in those areas. But frequently, you would be turning up to a patient that may have sounded okay at the first call, but then in those few hours, they can deteriorate quite rapidly. And the same with transfers from, for example, Darwin to Adelaide or Sydney. Because of the long distances, it made everything quite difficult. You'd need to think about what equipment you have at the time. Do you have enough drugs available to manage the patient for that length of time? What are the weather conditions around? Are we able to even make the journey? Do the pilots even have enough duty time able to make these journeys? So each mission, no matter how small, required a lot of discussing the pilots in order to make sure that everything's done safely for you and the patient and everyone around you. If you're very lucky, you get to see some pretty wonderful scenery, and even if you don't see the scenery, you get to work with some really wonderful people, get some fantastic training that you may not ever see anywhere else. And sometimes you might see a dog dressed in a hiver's vest. But other than that, wonderful experience. Can't big it up enough. So, why are we doing a presentation of obstetric emergencies and retrieval? So, as I said, obstetrics is a very common reason for retrieval, but luckily, less than 1% of these progress to in-flight births. I was very close on one of them, but luckily they gave birth in the ambulance, so I helped but missed it in flight, which was a big relief for me. But without joking aside, it's the main reason I'm focusing on this as well. It's not just because it's a clinically difficult and worrisome area for a lot of clinicians, but 800 women every single day die around the world from essentially due to maternal death. And 94% of this is in lower and middle economic areas. And lots of the key reasons for this are likely due to lack of access to medical care. So being able to bring patients to a high level of care is vastly important to preserving maternal life. Lastly, it's very emotive for both patients and staff, and it's a big common source of anxiety. So, presentation outline. I'm aware that we don't have a great deal of time, so it's a very quick presentation. So I'm going to go through a few case presentations and briefly touch on the physiology of pregnancy. And just as a reminder, this presentation is just a guide, it's for educational purposes only. And some of the things I say about things like drug doses, evidence and experiences, please ensure that you're practicing to your skill set, training and local guidelines and your own formularies, as they may not match up. So firstly, the physiology of pregnancy. There's some distinct anatomical and physiological that have implications for patient management, and really what is normal. So the big things we want to look at are cardiovascular, respiratory, gastrointestinal changes. It is a massive topic. We can't cover it all, so we're going to go through the very basics. So firstly, if we start with airway, during pregnancy they have friable pharyngeal tissues and larger breasts, which may cause you issues with the airway. The airway is prone to bleeding and edema with instrumentation. It can impede laryngoscopy and intubation. So it can cause a few functional difficulties. Next, when moving around to respiratory, the patient has increased oxygen requirements. The FRC, the functional residual capacity, is reduced by about 20% to 30%. There's a very small respiratory rate increase as well. This means that patients become hypoxemic very rapidly when they're apneic. You may see a mild compensated respiratory alkalosis, and that's a very normal finding. Cardiovascularly, if you ever get worried, most things go up. So the cardiac output increases by a great deal. It's nearly 30 to 50%. Increased blood volume of around 2,000 mils. They have slight dilutional anemia. And you always need to watch out for aortocaval compression from 20 weeks gestation, which I will cover in the next slide. Why this is important. In patients with pre-existing poor cardiac reserve or disease, and this is something we saw a lot in Australia with patients with, very commonly with ACS and rheumatic heart disease, it may precipitate heart failure in these patients. The other consequence of this is that you need to really be on your toes. These patients can tolerate significant blood loss. And sometimes you can see 500 mils, no issues, a litre, no issues with blood loss. They may feel absolutely fine. And once you start to reach around 1 litre to 1.5 litres, you can see that they're starting to decompensate. And if you've not noticed that they're bleeding significantly before this, you may become in quite a sticky situation, because they may tolerate this before they become hypotensive or tachycardic. And the risk of hypotension is dreadful if they haven't given birth. There's placental insufficiency and significant fetal distress at this point. And again, with aortic caval compression, we advise a left lateral tilt. Finally, minor things: they have reduced gut motility, reduced gastroesophageal sphincter competence, and raised intragastric pressure. So they may vomit on induction, and this is quite deadly for maternal patients. So as I said about aortic caval compression, it's from 20 weeks onwards. It's mechanical compression. You get reduced venous return and cardiac output, and this can be up to a 30% decrease in cardiac output for mum, and this causes significant fetal compromise. So what do you do in this situation when you are bringing a patient on board? Don't lay your mum flat. You want to lay her onto a side with a slight left tilt. And if you have to do CPR at this point, you want to be doing either left lateral tilt or uterine displacement, depending on how many hands you have available to you. In retrieval, you may simply not be able to do uterine displacement. You may have to make do with left lateral tilt. So we're going to start off with our clinical scenarios. We're going to start off with preterm labour. So this is the most common reason for retrieval by far. I saw quite a number of cases of this. We don't have a consistent definition, but it's roughly from 24 to labour in roughly 20, difficult to diagnose. So you want to be looking at maternal behaviour, your frequency and strength of contractions. Is there a history of membrane rupture? And you may want to do speculum examination if you have the skills for this. There are risk factors like previous preterm labour, UTI, and multiple fetuses. So it's going to bring us on to case 1. So we have Rachel. She's 27 years old, prima gravida. She's approximately 29 weeks pregnant, but we're not sure because she's had no antenatal care. Her past medical history is completely unknown to us. She's had contractions for the past 24 hours. They've become frequent and stronger. She thinks that her waters might have broke earlier that day, but she's not quite sure. She lives in a remote community far from a hospital with obstetric services. There is a clinic in this community. The sole clinic nurse is not trained in midwifery, unable to perform examination. So already there's lots of talking about, are we concerned? Well, could there be an active preterm labour? The story certainly sounds like it. Gestational age approximate. We don't know at all. She's had no antenatal care, so we have to assume that it's about that age, but you could be surprised with a much smaller baby than you're expecting. There's very little information about this patient's history. We're worried that staff present, they're not obstetrically trained, so we're worried both about mum and baby here. So pre-departure, there's some things we can do. We need to prepare ourselves, and we can prepare the staff and give them some advice. So we think about what are we going to tell the clinic staff and what things are we going to ask them before we set off, because it may change the way we prepare ourselves. We need to ask about, is there any PV bleeding? We need to ask about all their OBS. We need to make sure they're doing these regularly, and to please contact us in flight if anything changes. Can they do a fetal assessment? What's the fetal heart rate? Can they work out where the patient's breech was cephalic, and can they do ultrasound for us? We often found that this may not be possible for a lot of these things, so we frequently be flying semi-blind in these patients for these patients. We need to be thinking about, where should baby be born? Can we birth them safely there at clinic, or should we try and delay to bring them to a high level of care? That is something we did most commonly. We usually tended to try and delay unless patient is imminently giving birth at that point. We want to think about the staff we're going to be taking with us. So usually we're taking a doctor on board just for an extra pair of hands, especially to deal with baby and any other obstetric emergencies. We want to be taking a midwife specialist with us as well, because they will be best able to deal with mum. We need to be thinking about how far is it to definitive care. If it's a short trip, makes the decision much easier. If it's a longer trip, 3 hours, it makes it a lot harder. And we need to think about, is mum distressed and would she tolerate this flight? So the things we want to take with us, we need to be thinking about this patient for a possible preterm baby. We want to be taking our neonatal cot with us and our neonatal resource trolley. Heat, plastic bag, hats, booties, think about access, glucose, airway, breathing, everything for CPR. And we want to be working out wet flags before we get there. We need to be thinking about what we're doing in terms of PPH, and do we need to bring antibiotics for sepsis for this patient? Now next, this is the difficult decision of whether we try to delay things. So this is tocolysis. There are factors to consider for considering it and factors for considering remote delivery. So for considering it, you might want to think of if the patient is very small for dates or they're much earlier estimated gestation. Lack of local expertise, so you may be thinking, we don't really have a team here, it may just be a couple of people that would know what to do in this situation. That's really not enough, especially if an emergency happens. We need to think about if there's an acute concurrent maternal fetal medical condition, do they have PPH? Can we deal with it there? If not, we need to try and stop delivery, slow down delivery, and get them to an area where we can deliver safely. And especially if there's a short transfer time, it makes that decision much easier. For considering remote delivery, you think of contraindications to specific tocolytic agents. If there's fetal distress and baby needs to come out now, if there's maternal hemodynamic instability or collapse and they simply wouldn't tolerate the transfer, or if there's a very long transfer time, we may want to consider remote delivery. But this is something we would try not to do if we can, and it would usually be with a discussion with the MRC, who is usually the clinical lead for the case, and we may want to also get obstetricians from the hospital on board on the call. So immediate management, what agent to use? It depends, again, as I've said, it depends on your formulary and what you're using in your local areas. So always ask for advice, but nifedipine, as far as I'm aware, is shown to be the safest, so that's what we tended to use there. It's the first line agent. In the first hour, we can give maximum 3 doses of 20 milligrams. 20 milligrams every 20 minutes for the first hour, 100. With caution, you can repeat in the 20 milligrams after 3 hours. It's a max of 160 and 24. Additionally, consider betamethasone if the gestation is less than 34 weeks, and consider magnesium IV if gestation is less than 30 weeks for neuroprotection for baby. So what we're going to do en route, we want to drive, fly, or row quickly. We want to be monitoring the patient for their usual obs, fetal heart rate, and contractions. Keep everything warm, keep mum warm, keep your ambulance warm, keep your plane warm. If things don't go to plan and mum starts delivering, do you have the delivery packed hand? Do you have everything available to care for a flat baby when they arrive? And also with the consideration that we try not to do this, because if this happened mid-air, you've got a single midwife and a single doctor there, and it can get quite difficult quite quickly. Which stretch position? Usually we'd have them head up facing the aircraft, and usually have the doctor at the head end in case you need to intubate. And as always, in trauma and transfer, 2 large cannulas if possible, please. Next, we're going to have a quick look at maternal hemorrhage. Very scary. It's the 25% to 30% of all-cause maternal deaths. It's the leading cause of maternal mortality. You can split it into antepartum hemorrhage, postpartum hemorrhage, and other, but we're not going to cover that today. Very briefly, antepartum hemorrhage from placental abruption, placenta previa. These are the common causes. You may be able to diagnose either due to the set of symptoms. Looking at our time, I don't believe we have time to go through this. Within the first 24 hours, or a 10% fall in hematocrit, a need for a blood transfusion, or blood loss with hemodynamic instability. And remember that mum can tolerate blood loss for a great deal of time, so you always need to be on your toes. It occurs in 5 to 10% of all births, so you always need to watch out for it. Risk factors are previous PPH, hypertension, smoking, obesity, and it's increased risk in Indigenous Australians. So it's usually caused by the 4 T's. Most common is tone. So there are things you can do for each of them. This was the plan we had for Careflight, which was fundal rub, 10 units of oxytocin IV, which was 5 time and then 5, and then starting an oxytocin infusion of 40 units over 4 hours, so 10 hours and 10 units per hour. And then 250 micrograms IM ergometrin if not stopping, up to twice, and 1 milligram misoprostol PO or PR. Next would be tissue trauma and thrombin. The main thing we usually discuss in tissue, if it's an APH, would be PPH. Sorry, would be, is the placenta still there? Do we need to consider controlled cord traction? It's quite interesting because data has shown that controlled cord traction does decrease the number of the volume from 500 to 1,000 mils. It also reduces your likelihood of having manual placental removal, but it doesn't change anything from greater than 1,000 mils. So it's quite dependent, and it's also dependent whether you have staff skilled able to do that. Said before, patients can tolerate blood loss until they don't. So up to 1 litre, they often don't show any signs or symptoms. So be on your toes. As this increases, you'll see the normal hemodynamic instabilities that you'd see with patients. So vasoconstriction, weakness, sweating, increasing your heart rate, decreasing your blood pressure. And just to show this quick picture, editing blood loss, very difficult. So again, on your toes. So tips for this. Again, fly faster, 2 large cannulas, do things as best you can. VCD, oxygen, always consider, always beware APH and beware twins. If first babies come out and there's bleeding, you really need to make sure that there's not another baby in there, because giving a uterotonic after first but not second babies delivered can be disastrous. Keep everything warm and consider an indwelling catheter as well. So case 2, got a 29-year-old patient with a history of severe PPH. She's delivered a very healthy baby in a remote clinic. Midwife, clinic midwife's concerned due to ongoing blood loss. Placenta remains in situ despite active third stage management. She's hemodynamically stable. 2 large IV cannula have been inserted and a close hospital 1 hour away from the road. Are we concerned? Well, she's currently stable, but she does have a history of severe PPH. Multiparous, but there is a concerned midwife, and this should always set your alarm bells ringing. Sense in situ, that's worrying. There's ongoing blood loss, worrying. So you need to remember the 4 T's, so we can give advice before we get there. Fundal rub, uterotonics. Can they do controlled cord traction? Do they have blood products? Can you bring blood products? Can they give TXA 1 gram? And keep the patient warm. We don't want them to go in a cooling spiral, as this affects clotting for the patient. Things to bring with you: blood, if you can, drugs, Bacri balloon. You need to consider whether we're going down the route of intubation and ventilation, and then other things. We can pre-alert ground staff, pre-alert the hospital, and try and get blood available for you. On scene, package as soon as you can, fundal rub, blood, IV crystalloids, it depends on what you're seeing. And then, as before, we talked about considering controlled cord traction. But frequently, it's package fast. I think we're at 29 minutes, so I don't want to delay things. I've got something on eclampsia, but I don't think we have time to go through it. But essentially, it's... Do we have time to go through it? Sorry.
We're pushing things a little bit, so it depends how. It's up to you, really. We can stretch things out for a few more minutes, Andy, or you can round things off.
I'll be very, very quick. So we're going to have a quick look at hypertension in pregnancy. So we're looking at gestational hypertension, so hypertension after 20 weeks, preeclampsia, which is new onset of hypertension after 20 weeks, plus one of the following, which is usually organ dysfunction or proteinuria. And then severe preeclampsia is preeclampsia with severe hypertension that does not respond to treatment or ongoing markers of organ dysfunction. If that's not treated, you'll go to eclampsia, seizures associated with preeclampsia. So case 3, we've got Nicole. She's 38 weeks gestation. She's got a severe headache. Her vision doesn't seem quite right, and she's had no antenatal care. She's got high blood pressure, 156 and 2+ proteinuria. This sets off alarm bells. We're 35 minutes away by helicopter, so we set off as an emergency C1. We are concerned this could get worse very, very quickly. We're concerned about maternal and fetal well-being. There is a risk-benefit in treating community, but we may want to get this patient to a hospital because we need to get baby out. With high risk of PPH, high risk of C-section, and there's a high risk of fetal distress and neonatal resus for these patients. So we can give advice for the clinic. ABC, please give us some obs. Fetal antihypertensive management. Take with you your kit for giving birth. Take with you your kit for eclampsia. So we want to be thinking about magnesium and antihypertensives. And also pre-alert the hospital. So on scene, our goal is to lower the blood pressure by 1 to 2 millimeters of mercury every minute to a target of 110 to 140 systolic. And this is to reduce the risk of seizure. There's multiple different drugs you can use. We use labetalol. Each have their own indications and contraindications, so use your local guidelines. Place an inhaler and consider magnesium sulfate infusion. So, en route, she's still symptomatic. She's got a headache, vomiting, blurry vision. Her obs are not really improved. They've gone slightly up. 162 of 92. This shows that she is still severe preeclampsia. And now she starts seizing. How are we going to manage this? Cochrane review looked at magnesium versus diazepam. Magnesium leads to fewer maternal deaths, fewer further seizures than diazepam when given for eclamptic seizures. But just be aware that it can cause profound hypotension, and combination with antihypertensives can also cause profound hypotension. It can cause hypokalemia and hypocalcemia. Toxicity can cause reduction in deep tendon reflexes, muscle weakness, and paralysis, respiratory weakness, and potentially arrest. This is non-rebreathe, base cowway maneuvers, left lateral position, and 2 large bore IV cannulas. Immediately start IV treatment with magnesium, 4 grams over 20 minutes to try and terminate the seizure. If seizures reoccur, another 2 to 4 grams, and start an infusion of 1 gram every hour for 24 hours. You also want to consider careful fluid balance due to the risk of APO. Lastly, especially if you're doing transport in an area such as Australia with lots of communities, be aware of the cultural aspects because I was a chap. But you always need to be very much aware. Are there any customs or expectations surrounding the pregnancy? And what does mum want and expect? Explore why this is the case, and can we meet this? And does the safety of mum and baby take precedence over the expectation? and that's something that needs to be decided. Thank you very much for your time. Do you have any questions?
Andy, thanks ever so much for that talk. It was really interesting. It sounds like you had an amazing time out in Australia. We're a bit pushed for time, but a general question. Sure. Do you have any particular advice for any trainees who might be listening, who might be interested in going and doing some similar work? How long did it take you to organise, and how did you go about doing it?
Of course. So RFDS, Care Flight, Life Flight, all of these places in Australia, they're very easy to contact. Essentially, if you just go to the Care Flight website, they have all the contact details there. It was very simple to organise. Simple emails. The interview was, again, very simple. All I'd really suggest is ensuring that you try and stand out. Make sure you've got ALS, ATLS, APLS or EPALS if possible. Make sure that you're airway trained. And it was the first time when I went to CareFlight, I had no prior experience of pre-hospital medicine. So they were very happy to accept people as long as they were able to demonstrate things like airway skills and also generally a willingness to learn. They had a couple of weeks before at the start to go through everything that they expect of you. They had a very strict onboarding process. So they do look after you a lot. So if you're interested, I would very much, I'd definitely say, please apply for it if you're interested. And don't worry if you think you might not have something, contact them. They may give you some guidance of something that you're missing. However, in most cases, they're very happy as long as you're enthusiastic. I believe that you need to be at least, I think, after core training, but I'm sure that a little bit before then, I don't think they'd mind too much.
That's fantastic. Thanks ever so much for your time. Just a final point from Miriam.
Yeah, there's just point out that the updated ICS critical care transfer guidelines are coming out in the autumn of this year, and there will be an appendix specifically for this specialist group of patients, which has been written by experts in the field. So just watch out for that when the guidelines are published at the end of the year.
We're going to move on now. Our next talk is by Dr. Phil Dowson and Dr. Alex Beckingsale. Phil Dowson is an emergency medicine consultant in Sunderland and a pre-hospital doctor with the Great North Air Ambulance. And Alex Beckingsale is a consultant anaesthetist in the Northeast who works with Nectar as a retrieval consultant. And they're going to deliver a case presentation on an acute pericardial effusion in transfer.
Hi, thanks for that introduction. I know I'm eating into your lunch, so we'll try and keep this as upbeat as possible. I'm Phil, and I've got Alex with me.
I'm Alex, and we're going to present basically an irregular but severe complication of a patient across the timeline. Hopefully some nice POCUS images if they come through nicely, and knitting that up along with some human factors along the way.
So for those that aren't aware of the region, Sunderland is a district general hospital and where I work. We had a patient present, 62-year-old gentleman who was 2 weeks post mitral valve replacement, which he had done at James Cook Hospital, which is about 25 miles away. He was on warfarin post-operatively, and he presented by ambulance because of an increasing shortness of breath over the preceding few days. At about 10 to 2 in the afternoon, he was pulled out of that ambulance queue in the corridor and moved into one of our high acuity bays because he looked so unwell with pallor and breathlessness. He had venous blood gas done fairly quickly, which showed a lactate of 14 and a pH of 7.21. The emergency medicine clinician consultant that saw him initially was obviously concerned in the post-op period about the possibility of a large pericardial effusion. So did a point of care ultrasound scan and has documented it there. So it's a difficult views, but on the sternal and subxiphoid views that they'd attained, they couldn't see an overly large pericardial effusion, so moved on to alternative differential diagnoses and arranged a CT pulmonary angiogram looking for the possibility of a large PE, which he had at about 4:05. Those were his observations in that time window. So you can see hemodynamics were fairly unremarkable, but quite tachypneic with an increasing oxygen demand. This was a CT. Hopefully you can see the cursor there and the qualities come out to a satisfactory degree. So you should be able to see the cardiac border there and this very large hemopericardium here. Now you can see straight away why the clinician initially struggled with the point of care images from a subxiphoid and a sternal view, because they're coming from this angle here, whereas this effusion atypically is loculated around that left ventricle. The CT was reported as such, so major hemopericardium compressing the left ventricle with left ventricular output compromise and secondary right ventricular failure, which is different to what we're normally taught traditionally about cardiac tamponade, that it usually compresses the right ventricle. So some atypical features there, making it a little bit more challenging.
And meanwhile, north of the water and west of the city of Newcastle, at Nectar, we get essentially a referral call from a rather stressed ITU consultant who's a good colleague of mine at Sunderland, explaining that this gentleman, there was little information at the moment. This gentleman really wasn't very well, but he felt at some point he was going to have to go back to his cardiac surgical centre from whence he came 2 weeks prior. And we would probably need to be involved at some point. At this point, we would normally have a conference call where we'd pull all parties in, but Pete himself was very busy, had a lot of other things to attend to, and A&E there was very busy as well. So we took the decision not to do the conference call, but to start getting the kit ready to mobilise, and I would get an update from him later on.
In ED, we had his INR back at that point, which was over 8. And as you'd expect, the team promptly arranged some reversal with Beriplex and vitamin K. They then had their first discussion with cardiothoracics at James Cook, who did the initial procedure, who'd advised that ideally they'd like the patient to be stabilised in Sunderland with a drain, and suggested getting a formal cardiology review in Sunderland, who have cardiology on site to that end.
And north of the water, I get an update from my ITU colleague, who has gotten 3 additional tasks now on his list. And at that point, we start to do our trolley checks and assess what teams we had available, because like Sunderland, we were also busy that day with both adults and peds.
4 o'clock, so over 2 hours since the patient arrived, we get not one but 2 cardiology consultants who arrive in the department and do a formal echo, and they comment on the echo that there was a mainly posterior effusion or hemopericardium. It was felt to be a small pericardial window, and with an INR of over 8, it would be high risk. And there were no echo features of tamponade currently were written in the notes. So with the update to cardiothoracics, they said, well, if it felt like you can't do a drain at Sunderland, then there needs to be resuscitated and anticoagulation reversed and transferred to James Cook. And in that time, we had a point of care INR post reversal of his warfarin, and his INR was down to 1.3. Observations in that time, you can see the blood pressure is starting to take a turn for the worse, increase in tachycardia, persistently tachypneic and hypoxic, which doesn't do the guy justice for how unwell he looked, although he was still GCS 15 and conversing normally at this point. So hopefully this will come through all right for you. So these were the echo images that the cardiology team were documenting on as showing no features of tamponade. Now, there's a couple of things I'd like to draw out here. One is the obvious big pericardial effusion that you can see there with some septations. Notice how it's all fairly jet black, so suggestive of nice free blood, which is to be expected with an INR of over 8. But it's clearly not a happy heart and not beating particularly well. And I think the key feature to look at is the septal wall, seeing how that's bowing over to the right-hand side of the heart on inspiration, which would certainly be an indicator of a heart under stress in tamponade. So that was possibly a misdiagnosis early on. I was at home. I was doing a 5 till 9 late shift in ED, and the lead consultant in ED rang me at home to say, just to let you know that when you come in at 5, you might have to go immediately on a transfer to James Cook with a thoracotomy kit in case someone has a cardiac arrest. I had numerous questions, although I was elated at the idea of potentially missing a few hours of rapidly assessing a frail ambulance queue. But other than that, it didn't sound like a great idea. So I did have some concerns as I quickly jumped in the car to head in for my shift.
So our official time for leaving our north base, north of the water, was 29 minutes past 4, and we made our way through to Sunderland with, just to stress that all the information that you guys have seen in blue and the images that you have seen, I have not at this point, and our team haven't yet at this point seen all that. So we're still working on some very minimal information, but have taken the decision to just kind of head across there, particularly knowing what the traffic gets like on a Friday afternoon.
So myself and Alex and the Nectar team more or less arrived at roughly the same time to a fairly chaotic scene in a busy department, lots of senior clinicians around from cardiology, intensive care, and the emergency department, as well as numerous nursing staff. And the patient looked very, very unwell in high acuity. So at that point, the ED lead clinician very much took a step back and allowed us as the fresh pair of eyes to go and see the patient, which we both did, recognised how unwell he was and the fact that he was peri-arrest. I think he had a lactate had repeated around about the same time, which has climbed from 14 to 18 to just compound that. And we then came together in a smaller group, myself, Alex, the Nectar team, and the cardiologist who was reluctant to do the drain, to discuss the fact that he was, now approaching a peri-arrest state, and we needed to do some intervention because he certainly wasn't going to be transferred in that state. And then it became clear during that discussion that the risk assessment of our risk assessment of the patient was and the procedure was different to the cardiologist, in that they were quite concerned about the potential for complications. They were worried about giving the chap a pneumothorax. They were concerned about the fact that it was going to have to be an apical approach, which isn't the traditional approach for a pericardial drain that we're taught. And it became clear that we're quite uncomfortable in doing the procedure. So at that point, we made it clear that we were happy to manage those complications, and we were happy to do that procedure as a team as a pre-hospital consultant. I've got a little bit more experience in the high acuity, low occurrence or halo procedures, so I was happy to do the procedure. I also like a little bit of ultrasound, which was a useful skill to have, which I'll talk about in a sec. And Alex and the Nectar team were very keen to help with procedural sedation and prior preparation. So we made a decision at that point to move him into our resus room to get those things done.
And at this point, it was quite important to stream down that kind of big mass of group of individuals that had all become interested or partly involved in the patient's care. It was handover time for critical care, and critical care was very busy. A sick obstetric patient was on the horizon. So basically, there was some fairly slimmed down role allocation went on. I said that I was happy to administer procedural sedation and then manage any airway complications that we needed to, and had a very experienced ODP, an excellent ODP, James Blomar, with us if we needed a practitioner. So at that point, the ICU consultants hung close but went and did their handover. And we managed to slim down the white noise that had accumulated in the corridor, so to speak. At this point, we moved him through to resus in the same manner that you might mark up for emergency cricothyroid. We'd already marked a window, or Phil had marked a window for insertion of the drain because of the atypical post-coidotomy type complication that had occurred. We gave him a little bit of ketamine, and then just as the drain went in, we confirmed drain placement and blood coming out. We drained about 200 mils of blood. I gave him a bit of fentanyl just to tide over any ketamine side effects, and also to add to that co-analgesia effect of those two agents together. He remained spontaneously breathing with good SATs, and we had all our airway kit drilled and ready to the side of us should we require it at that point. And he then continued to improve very dramatically and looked a very relieved and different gentleman altogether around 10 minutes later.
For those that are interested, these are the ultrasound images. They obviously were taken in a bit of a rush, but you can see how jet black that blood is, so the confidence with which you could expect that blood to come out free flowing rather than lots of clots, which you might see in a traumatic hemopericardium, where we're traditionally taught not to aspirate if we can avoid it. You can see the depth of that. So that's roughly about between 5 to 10 meters, 10 centimeters, sorry, deep at the apex. So quite a large window to aspirate from, which was good. And yeah, so once that was done, which went fairly smoothly, he made a very, very good recovery and stabilized. And I went along with the Nectar team to troubleshoot the drain. Well, that's what I told the rest of my team. It didn't really need much troubleshooting, but it was either that or stay and do the rest of my shift in rapid assessment. And we had a fairly unremarkable journey down to James Cook to hand over to his specialists.
Okay, it's important to say that prior to that bit, we did do a pre-brief and we made an active decision that Phil come with us in case there were complications with that drain, given the kind of atypical nature of that collection. But mindful that takes a clinician away from the Sunderland environment and the safety of those patients as well. So each decision was made kind of actively with careful consideration. Now, from the patient's perspective, I spoke to this chap the week after. I also spoke to him last week as well to catch up with him. So he had a metallic mitral valve replacement. And unusually he was a very fit, very active chap previously in the army and then a retired history teacher. Normally you'd expect those with that fit to have their mitral valve replaced, and from James Cook they would go home between 5 and 7 days post-op on their warfarin, obviously with a fairly high INR target. He's probably had rheumatic heart disease in the past, but just not realised. And like many, he presented with a kind of non-specific pneumonia beforehand, which is quite common for kind of occult mitral valve disease. Now, those 2 days before he came back into Sunderland, he says one of his main symptoms that he will never forget is just the kind of unquelling sense of shortness of breath, that he could, no matter what position he is, no matter what he did, he could not make it any better. And he knew that something was very wrong, probably after around 24 hours, at which point he presented. He feels that the swiftness of treatment, although we've stretched this timeline out to show you, for us, as immediate care physicians, it feels like a longer timeline. But for him, he felt it was very swift and he got his treatment really quickly along with his diagnosis. He remembers the ketamine experience very vividly, which I found particularly interesting, being an anaesthetist background. He said it was like rushing through blue sky with clouds, seeing the faces of his close friends and family on either side. He wasn't distressed by it. He had no further flashbacks thereafter. And he said it was a very relaxing feeling. He also remembers the journey vividly down to James Cook. He said he remembers it being extremely quick, but really smooth. And he was impressed by the driving, which obviously fed back to Justine, our IAS driver afterwards. And he's just generally very, very grateful for having that team with him at Sunderland and then with him in the ambulance afterwards. He's doing well, and hopefully he's moving further. Well, he's moving down to South Yorkshire in a few months' time.
I think the learning points for me from the emergency perspective and the non-technical side of things, I think first is the value of point of care ultrasound in these scenarios. So, but also the pitfalls. I think from a pitfall perspective, they got scanned more or less the moment they came out of the ambulance queue by emergency clinician who wasn't able to identify that large effusion because of maybe not having the depth right, not fanning through the whole organ, whatever that is. So it does show one of the pitfalls of POCUS as a rule in, rule out. Sorry, a rule in, not a rule out tool. But also that when it's used well, the confidence it can give you in procedures that might be less common. I'd never done a apical pericardial drain before, but having the proficiency with the ultrasound meant that I was confident with the window that I had to access the effusion, confident about the nature of the fluid in the pericardium, and that I was going to be able to aspirate at least enough of it relatively easily. So I think that's a big learning point about the fact that if you're using point of care ultrasound in your practice, you must be doing everything you can to keep proficient at it and keep improving. The recognition of the atypical presentation of tamponade, nothing ever presents typically, particularly not in the ED. So that left ventricular compromise and compression as opposed to the right from that loculated effusion and tamponade wasn't something I'd seen before, but is a recognised complication of the mitral valve operation. And from a non-technical side of things, just the civility of the Nectar team. I hadn't met Alex or any of her team beforehand, before they arrived, but they were polite, assertive, but in no way aggressive, very open to others' options and opinions, but clear about what needed to be done, and we worked very well together. Although I spoke loads since then doing this presentation, so I hope we're mates now. Are we mates now? Yeah, she hasn't said, but I think that's maybe a yes.
I'll wait till the microphone's off before you know. No, so I think from my perspective, it's more and more of the transfer stuff that I do, and that every case is very different. And again, bringing in the civility idea and being non-judgmental about what's gone before and what is there presently. I think importantly, you deal with what's in front of you and you help support the teams that are there in front of you, and you help join those dots. So in this situation, I learned that it was definitely the right thing to do, is to step in and use some of my procedural sedation anaesthetic skills in a kind of unfamiliar site and allow their teams to carry on doing some of the other critical stuff that they needed to do. That might not be the case in the next transfer that I do. And I think being fluid and flexible with that approach is really important. I think also the one thing that I have taken from this was the difficulty, which is always a challenge in a transfer team where you are a mobile team that changes through the course of the week and you work other places as well, is the ability to debrief and debrief properly. And actually this whole process of giving this presentation, I think has allowed us all as a team to properly debrief eventually, even though it's a few months later. But the challenge of trying to debrief, even if it is via Teams in the days after, is really important. So thank you very much for listening. I hope you've got your lunch, or you're having your lunch, or you now go and get your lunch, and we haven't held that back too much. Thanks very much.
Thank you, Alex and Phil. That was a fantastic presentation for a really challenging case. It demonstrates some really complex decision making from a senior group of clinicians across several specialties and actually across different kind of work areas. We've got one question which I think is probably worth asking, and that is, was there an option for cardiothoracics to come to Sunderland, and was that discussed in the team kind of huddle? And how did you make the decision ultimately to carry out the procedure in Sunderland?
So I think ultimately, from the point Phil and I were involved, we came in almost quite late in the process, around between 4:30 and 5 o'clock, even though obviously we'd had the referral earlier on, at which point it was a case literally of us both sticking our heads around the door of this chap's room and looking at each other and saying, I'm not putting him in the back of an ambulance. We can do something, and he's almost peri-arrest, so we need to do something at this point. So actually, it's a really good question to ask, because in hindsight, could we have then made a move to do that, but warned a mobile cardiothoracic team that we may need them? Yeah, that's a really good question. It's not something that Phil and I have actually spoken about. I wasn't party to the discussions earlier on down the line. And I think us two stepping in was just literally the fresh pair of eyes approach that was needed. And he happened to start to fall off his perch at that point. It's interesting observation from Justine, our driver, who said she heard these awful noises coming from his room and couldn't believe how different he looked after the procedure. So, and Justine is not medically trained by background, but even she knew that this chap was incredibly sick at the point that we arrived. So we dealt with what was in front of us at the time, but I think that's an excellent question. And I probably can't answer that honestly, unless Phil has got other information about previous discussions with cardiothoracics.
No, I don't think I have anything to add. I'm not aware that it was discussed by the ED team before we got there as an option. I think the focus was always on trying to get him to the point of definitive care. I think logistically to get the right cardiothoracic person or team from James Cook up to Sunderland to then I think that would have been challenging, and I think people were aware of how acute it was. It's still 25 miles by road. It's a reasonable journey, and I think people were aware how sick he was and that he was deteriorating. So I think that probably wasn't considered. I think what was more important was just recognizing that the skill set we had within the team to do the procedure within the team, and I think recognizing the not limitations, but a district general cardiologist is going to come at a patient like that with a very different background of experience and consideration of risk versus benefit. So I think it was recognizing that, particularly when you go into a district general, yes, they may be a cardiology specialist, but that doesn't mean that they're going to be experienced in putting in pericardial drains in the acutely unwell patient from an atypical approach. So I think it was just about using the skill set they had on hand appropriately.
I think about mobilising a cardiothoracic specialist surgical team that don't normally and regularly mobilise is a big undertaking as well, when you're considering whether you obviously can't take bypass with you necessarily, or not all teams can, and all the other things that go alongside specialist cardiothoracics is another challenge. But yeah, it's an excellent question to ask and us to think about in the aftermath of this. Thanks, Miriam.
And listening to the talk, it sounded like the key element here was in the communication and having an understanding that the cardiologists were uncomfortable with the prospect of putting a drain in, and the intensivists and the ED team knew the drain had to go in, and then squaring that circle and going, actually, we have the skill to do this here if we do it between us. And that seemed to be the crux of it, the thing that kind of got the patient to the point where you could transfer him, certainly from a listener and a viewer perspective. I've just got one further comment prior to lunch, which I'm sure you're all desperate for, and that's that we don't often recognise every single member of the team in the same way. And it's really interesting that you've talked about Justine, who's one of our blue light drivers. She's an absolutely excellent blue light driver, and it's really nice that the patient has recognised her as a really crucial part of the team in getting this patient to definitive care. We are going to have lunch. We're sorry it's a little bit late, but I think the quality of the talks has been so brilliant today, we didn't want to cut anybody short. But we are going to give everybody half an hour lunch, which means we'll restart the webinar at 1:30. So if everybody goes and has some refreshments, we'll see you in half an hour.
Good afternoon, everyone. I hope you've managed to have a decent lunch break. We're going to push straight ahead with our next speaker, who is Dr. Scott Grier. Scott's one of the national leads for the English Adult Critical Care Transport Services, and have been deeply involved in developing national services over the last few years. Scott, I know you're on a tight schedule and you need to disappear at 2, so without more of an introduction, I'm going to hand over to you.
Thanks very much for the introduction, and thank you for the invitation to come and talk today. I'm going to talk about something slightly different. So if you've heard me talk before, you probably haven't heard me talk about high consequence infectious disease. As colleagues have already said, so I've got a number of roles across a variety of organisations, and for the sake of today, I'm essentially not talking on behalf of anybody. So the views are very much my own, although I'll wade my way through some of the things that we've done in Retrieve and also with NHS England as well. So talking about high consequence infectious disease, we have to start with some definitions, and some of these will be really familiar to you if you've done a job in a centre that is an HSID centre, and many of you may never have come across that, and that's okay. So an HSID is defined nationally by the UK government, and that work is done by the HSID network and also by the UK Health Security Agency. And basically, an HSID is a disease that's acutely infectious, that has a high fatality rate. It may not have acute and effective prophylaxis or treatment, can be difficult to diagnose, particularly might need specialist tests to diagnose, can spread widely both in the community and in healthcare settings. And as a result, we need to do something different to normal in order to manage it effectively within the healthcare setting. And we subdivide HSID into 2, so contact and airborne. And neither of which is a group of diseases that I think you particularly want, but ultimately contact are those that are spread through direct contact with the patient or their tissues or other materials that are contaminated with those things. And the types of diseases we're talking about are the hemorrhagic fevers. Most commonly known are those such as Ebola, Lassa, Marburg, Crimean Congo hemorrhagic fever, those sorts of things. Airborne diseases are those spread predominantly through respiratory droplets and aerosol transmission, but can also be through the contact routes if someone is contaminated with those respiratory droplets. And these are the things that we often read a bit more about. So the avian influenzas, SARS, MERS, some of the Mpox clades, and a variety of other things that are relatively weird and wonderful, but again are on that list of things that I don't think any of us particularly want. And you may ask, why is this relevant? Do we see these cases a lot? And the answer, of course, is no, we don't. But if you track the numbers, and this is data from the HSID network, so the colours are a bit random, I'm afraid, but if you track the data over the course of the last 50 years, the number of HSID confirmed cases in the United Kingdom is increasing every decade. And some of that is because we're much better at looking for these types of diseases. Some of it's because we're better at diagnosing them, and our surveillance programs within the sampling services are much better, but it's also because our populations look really different. We've got a much more broad diaspora than we ever had before. People travel in a very different way. Families are much more complex than they perhaps ever were before. And so when you talk to experts in the field, not just nationally, but internationally, they all say the same thing, which is we've seen a series of epidemics. We've seen the outbreaks of things like SARS and MERS. We've seen Mpox. We've seen outbreaks of Ebola, but we've also seen the pandemic associated with COVID in the last decade. And all of those things are a sign, a signal that we're going to see more of this. So unfortunately, most of us in this meeting today will probably see another epidemic and may well see a pandemic in our working careers. So it's really relevant, even if the numbers on a day-to-day or week-to-week or month-to-month basis in the UK are pretty small. So the way that the provision currently is set up to deal with cases that have, or patients that have got confirmed contact or airborne HSID, is that there are a small number of centres that are dedicated to treat them. So for the contact diseases, there are 2 centres, one in Newcastle and one in London. And there are 2 surge centres, so Sheffield and Liverpool can admit those patients if London and Newcastle are full. For airborne diseases, there are more. So again, those 4 plus 3 new sites that are currently being commissioned, so Cambridge, Oxford and Bristol. And the intention of having these is to cover as much of the country as possible, to cover as much of the population as possible, but also to reduce the transfer times of patients and their relatives who need to be transferred into these centres once they've got a confirmed disease. You'll note that the devolved nations currently don't have this capability. There are ongoing conversations in Wales. I'm not aware of what's going on in Scotland, but Northern Ireland is developing a capability. Obviously, their geography is a bit more challenged in terms of being able to get across the water. So I think we'll see a slow growth of this, but ultimately you're not going to see these sorts of treatment centres popping up in lots and lots of different places. And the HSID network, under the umbrella of NHS England's highly specialised commissioning team, are doing a lot of work day to day. They're also working with the UK Health Security Agency to keep an eye on what's emerging. So if you look at the last year, for instance, there are things that are on the up. There are things that are just out there that we need to be aware of, and there are things that are potential threats. So if you go to sub-Saharan Africa, there have been outbreaks of Marburg. There've been over 6,000 cases so far of Lassa fever in Nigeria this year. But closer to home, there are cases of Crimean Congo hemorrhagic fever that have been found in ticks in Turkey. And those same ticks have been found across the Mediterranean countries into southern France. And so there's a really big surveillance program going on watching those, but it's only a matter of time before we start to see those kinds of infected ticks and indeed people getting infected in countries that are much closer to home. And so having this sort of national capability is really important. But with that capability also comes a load of questions. So as you're probably aware, and we've heard from other colleagues talking this morning, the provision of critical care transfer, particularly in adults, has changed immeasurably in the last 5 years. So before COVID, we had nothing in terms of coordinated service in England. We've got EMRS in Scotland, and we've got NISTAR in Northern Ireland. And of course, the contrast between that and what's previously existed with neonatal and paediatric transport services is really stark. So things have come a long way, which is great, and we've heard from Mike and what's going on in Wales and similar things going on in England, as you're probably aware. But for some of these niche diseases, the question that keeps coming up is, but how do we meet the needs of these patients in a way that is sensible, in a way that is resilient and effective, but also in a way that's actually deliverable, because we are all resource limited. So when we started looking at this in 2021 and with more rigor in 2022, after there being a couple of critical care cases, we started by saying to ourselves, what are the challenges? And at the beginning, we didn't really know what most of those challenges were, because with the exception of COVID, there have only been 2, perhaps 3 critical care transfers of HSID patients in the UK. And there have been less than 5 critical care admissions of HSID patients in the UK. So the numbers that we're dealing with are really small. And if you go and talk to people elsewhere in the world, there are similar experiences in developed countries. So there isn't a massive amount of resource to pull on here. But when you start to pull together the challenges and try and work out how we do this, there are loads and loads of stakeholders. And those stakeholders range from the patients and their families all the way through and up to and including UK government. And everyone's got a different need, everyone's got a different set of priorities, and the patient isn't always at the centre of all of those priorities. So we're also dealing with something that's really high, that is high complexity, but very, very low volume. So we need to pull together all the experience that we can get. So in the ambulance services, and I'll talk more about this in a moment, there are teams called the Hazardous Area Response Teams. They are the people who've been tasked historically with the transfer of these types of patients. They've got a whole load of other expertise and they do a lot of training and they're brilliant. And so they're a key stakeholder. The military have traditionally been the aeromedical solution to these types of patients. Some of you will remember images of patients coming back from the Ebola outbreaks in sort of a decade ago in the ATI, the air transport isolators, the sort of big plastic sort of frame and sort of patient isolation system. And then there are some commercial providers, and then there's a new capability across the European Union called Rescue, which is run by the Norwegian Air Ambulance, but for all EU countries, which unfortunately we're not one. So looking to all of those, there is a reasonable amount of experience, a lot of resource, but also there's a lot of great minds thinking about how do we solve this. But the bottom line is that often the priorities are quite different. So we're often prioritising the safety of staff and people over the safety of the individual patient. And sometimes that means that the timescales that we're looking at, whilst they're not disease specific, they are safety specific. And so we've got to find something that allows us to deal with the population and the types of patients that we see and the locations that it may be, whilst also making it absolutely deliverable. So in really simple terms, with my slightly average graphics, essentially we've got a patient in hospital A and we're trying to move them to hospital B. And the key stakeholders in that are UKHSA, the HCID Infectious Disease Network, along with NHS England EPRR, so that's the Emergency Preparedness, Resilience and Response Team, and NARU, which is the National Ambulance Resilience Unit. And when you bolt those elements together with loads and loads of other stakeholders as well, you have this journey that the patient needs to go on. And when they're at ward level, it's actually relatively straightforward. So there's a heart team in each region. Sometimes there's more than one team. And they have something called the Epi Shuttle, which is this sort of plastic kind of almost coffin-like thing that you can see at the bottom of the screen, that you can use for patient isolation. And if the patient doesn't fit in it or they don't like being in it, then they can be in a closed ambulance and the team wear PPE, a bit like the PPE that you see on the screen. The difficulty when we're talking about critical care transfer is that we have to bolt that in, we have to put it into this system somewhere. And there are different options available to us. So we could just reinvent the wheel and say, let's do this from scratch, let's build a deployable capability that can go anywhere in the UK to pick one of these patients up. Or we could say, look, there's a massive amount of expertise and the infrastructure already in place. How do we bolt the critical care bit on the side? Because actually, the most important thing here is all the safe work systems of work, all the communications processes, all the SOPs that already exist. And actually, putting the critical care bit on the side isn't that great. And so it's probably not surprising today that that's what we're choosing to do. So in order to try and work out how we navigate this and what we deliver at the end of the line, we've had to bring together loads and loads and loads of different people. And I'm not going to talk about each of the points on this slide, but it gives you an idea of the kind of things that we've had to think about, the kind of priorities that each of these different organisations and networks have, but also we've had to dive into each of those in really quite granular detail. So if you pick, for instance, our transfer services, we have gone all the way into the individual bits of equipment and so on. If you look at the HCID network and the work with EPRR, we've looked at who's involved in phone calls and teleconferences, when do they get involved, how do they get involved, what kind of information do different people want. And so it ends up being quite a lot more complicated than we think of for most of our normal transfers. And even some of the more complex transfers that we've heard brilliant talks on this morning, this is just another level of complexity because of all those stakeholders. So when we started building adult critical care transfer services in England, we wrote something called a service specification, which is the sort of commissioning document for ACCTS. And we started with really key principles, and they were around standards of care, a national network of interoperable services, and so on. We've taken the same approach with this because actually, whatever we try and do, the patient does have to be and must be at the centre of our universe. So the principles that we started with when we're trying to work out how to provide this capability are first of all around safety. So unlike pretty much everything else we do in the NHS, the team around the patient, they are the priority, and the safety of them is a higher priority than the patient. And to put that in really stark terms, if the patient is behind a set of closed doors and they have a cardiac arrest and the team are not in PPE, they must go through the normal process that they would go through to don that PPE and go into that room. If that takes 15 minutes, that takes 15 minutes. And that sounds really strange to all of us, I'm sure, because it's not what we normally do. But for these particular patients, we've got to be really clear that that's built into every element of this, but also that the thread of that is woven in right from the training and education all the way through to the standard operating procedures that we've got. Whatever we do has got to be practical. So we've actually got to be able to deliver this, and we've got to be able to deliver it tomorrow as much as we've got to be able to deliver it at 3 o'clock on a Sunday morning. Crucially, it's got to be adaptable. So lots of conversations around the fact that the majority of ACCP patients are adults, but not all of them are. And so we must have a capability that is equitable and that is deliverable for all sizes and ages of human being. And then we've got to build something that's scalable. So it can't just be okay to transfer a single case, because often when you have a single case, you have more than a single case, because you've got the index patient and you've got contact with them. Sometimes you get a cluster like you get with mpox. Occasionally we get epidemics. And as we've all experienced in the last 5 years, sometimes you get pandemics. So whenever we're thinking about each of these things, we're not just thinking about how do we deliver this on the irregular basis that we think we're going to have to as business as usual. We're also saying, for instance, with education, how do we create something that's scalable so that we could roll that out to every transfer service across neonates, pediatrics, adults? What would the PPE requirements be for that? What would we need to do in order to develop the command and control processes that we would need to coordinate those sorts of things? And that's learning that we've got from the pandemic, and we'll hear much more about that, I'm sure, with the COVID inquiry later in the year. But it's all focused on trying to make something that is fit for the future rather than just be a single patient focus. But we are in pretty challenging times, so it's got to be affordable. The NHS is facing real challenges when it comes to the amount of money that's available at the moment and the resource that's available. Everyone's super busy. And as a result of that, we've got to make something that fits in with the day-to-day for our heart teams, for our critical care transfer services, and for the clinicians who work for them, who majority of whom don't work full-time for those services, so they have other commitments as well. So when we're looking at training and education, how do we train people in a resource respectful way, but also what's the maintenance of currency requirement there? So how often do they need to put PPE on? How often do they need to train with the heart team and so on? And then finally, and I'll come back to interfaces at the end, everything that we do has got to be interoperable. So we've got to be able to deliver this system from hospital A to hospital B, or from runway A to hospital B, if the patient comes in from abroad with a commercial provider, or they come in from another country with the MOD. So we've got to be able to link these things together, but also work out how we get people off the Highlands in Scotland, Isle of Wight, the Isles of Scilly, all the places that are beautiful, but actually really difficult when it comes to this. And putting someone in an epi shuttle, putting them in a helicopter, unfortunately, is not as straightforward as one would hope it would be, partly around legislation and what organisations and responsible people are willing to do, but partly about that interoperability, which is so key to all of this. So to give you some examples of the kind of level of granularity that we've explored with the national team around this, just want to pick out two discrete elements. The first being the transfer team, second being the equipment. So when we talk about our transfer teams, we've heard from colleagues this morning talking about some of the adult critical care transfer services around the UK, and the majority of our services are operating with a doctor practitioner model, and typically teams are 2 people. And so when we distill the transfer team right back down to basics, we have to say to ourselves with HSID, who do you choose? So what skill set do they need? How many people do you send? Is 2 enough? Probably not. How many, if we have a team of 40 or 50 in Nectar or Retrieve or Access or ACTS in Wales, how many of them do we train? What does resilience look like versus currency? What does the training look like, as I've talked about? What's the maintenance of it? But also we've got to be able to tell those team members what's the true risk, and be really honest about what the unknowns are, because that's where the fear comes in this, because everyone is a little bit fearful. We'll all remember how we felt in COVID. And so you've got to be able to help them manage that, but also be really open and honest about what processes we're putting in place to address all of those questions and many more. With regards to critical care transfer equipment, we're pretty used to as services operating in an environment where we're relatively resource limited. But we're typically used, but that said, we're typically used to having our own ambulances with our own critical care transfer trolleys, and having a lot of equipment bolted onto those trolleys in our bags and so on. So we do have to ask ourselves what's absolutely necessary, what isn't, who brings what, who doesn't, who, if you use the Epi Shuttle, for instance, where does it fit in? Does it go onto a transfer trolley, excuse me, or do we bolt our stuff to the side of it? Can you even do that? Does it fit in the ambulance? It doesn't fit in all ambulances. We found that out. Does the patient fit? So we know that I fit. I'm a pretty big bloke. I've got very broad shoulders. I know people who are 6'7", 6'8", who also fit in it. So there's a pretty broad range of people that do fit into it. And also, how do you set stuff up, and does that matter? So when you bring all that together, you get something that looks a bit like this. And this might, on first glance, look a little bit untidy, but it's not intended to be. And we've done this quite a few times now. This was at the Royal Free Hospital with all the great and the good across the HSID network, NARU, Heart and so on last summer. And really it was to start to try and play with this in a much more operational way and say, can we make this work? So when you start to peel it apart, we took everything apart, right back to basics. And we realized that you can put an Epi Shuttle on a critical care transfer trolley. We know what the weights are. We know exactly where to mount it. We know how it mounts with the Furno trolley and the Pare trolley and so on. So we can make that work effectively. We know from a patient perspective, as I said, that actually there's a really broad range of patients that fit into it. But there are concerns about how you manage smaller patients. So if you're ventilated, it's pretty straightforward. If you're not ventilated, who will tolerate this? Who won't? And we know that a reasonable proportion of critical care patients are not ventilated. So is this something that you could put an awake, non-agitated adult in? Yeah, of course it is. The longest time that any patient has spent in an Epi Shuttle awake is 37 hours. In some Greece or Turkey, I think it was. That's a long time. I spent 10 minutes in it. It's quite uncomfortable. But what do we do about children? What do we do about agitated patients? What do we do about claustrophobic patients and so on? So there's lots of considerations there, and almost every page that you turn over just has loads of questions and not necessarily many answers. We also have to think a bit differently. So the arterial line transducer is actually on the outside of this Epi Shuttle, and there's an extra 3-way tap in this as well. But you can't just add these things to a transducer set because they are manufactured a particular way, for those of you who've done anaesthetics and learned the physics of it. But you can purchase longer sets. You can purchase sets with specific things built into them. So you have to think about each one of those various elements. And then once the patient's in the Epi Shuttle, the principle is that we don't want to take them out until they get to their destination. So how do you manage some of the events that happen or that may happen? So clearly, we want to be in a position where physiological stability as much as possible is achieved before they go in. We absolutely don't want to be managing or having to think about managing cardiac arrest or airway problems, but we have to have a plan for all of those. Cardiac arrest, ultimately, the lid has to come off, but you have to put PPE on first. Airway management, there are videos on YouTube that show that you can potentially intubate someone on one of these. I wouldn't want to try it. We're not keen on advocating for that, but you can put a BVM in there in case the ventilator fails. You can put other airway adjuncts and a bunch of other stuff. And there is room to be able to put some of those things in just to try and anticipate some of the emergencies that may occur. And then you've got to think right down to the granular detail. So each one of these cables has got to come off the Zoll, be threaded through the access port, have little electrical tape put onto it to show that it hasn't moved. So you put different colors on the inside and the outside so that you can see if it moves in, which is not a problem, or moves out, it is a problem. And each one of those then has to be reconnected. And then you've got to do the same with the infusion lines and everything else. So the setup takes a lot longer. And then we want to try and not snag stuff just as we do with our normal work. And we can't package this patient in the same way as we package our normal patients. So we have to find things. And sometimes Amazon or eBay is your friend. Naru just purchased these really cheap cable tidies that only cost a few quid and it can just be burned at the end of it. But again, they're really useful. So when you bring all that together, it's quite a complex beast that we're trying to create. And that's before you get to the point where you have to interface either at the referring hospital by getting the patient into an epi-shuttle or getting them out of that, or at the receiving hospital. So this is in the Royal Free. This is the Trexler. So this is where they treat Ebola patients, for instance. That exercise that we ran last year, we learned massive amounts about interfaces, what works, what doesn't work. The whole process has changed as a result of that. And we're going back there later this year to do some different work with them. But again, I'm sure we will learn loads, because all of this high complexity, low volume stuff means that we have to keep picking it apart and keep iterating the processes as we go. But these interfaces are also really important when it comes to communication. So normally you'd have your referring hospital, your receiving hospital, they talk to each other, transfer service, and it's all great. But there are so many more people here involved in this that everyone wants a little bit of the pie, but also there are people who need to know stuff. And it's how you then create that sensible coordination. So for instance, with critical care transfer, we're advocating that we take 2 consultants rather than 1, and a transfer practitioner, and one of them won't touch the patient, won't go near them, won't put PPE on, but they'll be externally facing. So they'll do all the comms. They could even do some of the note writing, because you can create a closed radio channel, and you can do all sorts of things with that. But you just start to offload those people who are doing the patient care, because there's so much else going on. So I suspect what I've helped summarize, or hope what I've helped summarize, is that this is pretty complicated, but we are well on the way to having a solution. So later this year, I'm hopeful that NHS England's highly specialised commissioning will commission the provision of this. Quite what that looks like, we've got some really good ideas, which I'm not allowed to share yet, but what it will probably be is a small number of paediatric and adult services covering the United Kingdom. What it won't be is every one of the neonatal, paediatric and adult services across the UK being commissioned, because that just isn't deliverable, it isn't practical, it doesn't fit any of those principles. What's also key is the collaboration. So there's a huge amount of work going on. I've got time tomorrow with NARU, for instance, and we've got time in September with the RAF. We're going to the Royal Free in October. So there's lots of this still going on, and that some of the relationships with individual critical care transfer services we're going to start to build, along with rescue, with the wider MOD and the commercial providers, because ultimately whatever solution we have has got to look quite broad and got to be able to manage quite a lot of different situations. And then, just because it's not complicated enough, every so often someone comes along and says, why wouldn't this solution work for something else? So if you have another Novichok poisoning, or if you have patients who are exposed to serious levels of radiation, would this sort of provision work for them as well? And therein lies an entirely different set of talks, but also it gives you an idea of how perhaps we look quite differently with transfer now in comparison to where things were 5 years ago. So that's a whistle-stop run through HC critical care transfer. Essentially, it's a complex beast. It's never going to be something that we ask a referring hospital to do. And I hope that by the end of this year, we'll have a really high quality and really granular level of detail in terms of the plans, but also in terms of how we deliver this, so that when the next patient comes, not if, when, we're really ready for that. That's my email address. Really happy to chat to anyone who's got more questions about it. But thank you very much for having me.
Scott, thanks ever so much for taking the time to talk to us today. I don't think anyone's put forward any specific questions right now, and I'm conscious that you've got another commitment in about 5 minutes. So if anyone does have any questions for Scott, please put them in the Q&A section over the course of the day, and we can feed those questions back to Scott, and we'll get answers back to you as and when we can. But thanks very much for your time, and we'll let you move on to your next commitment.
Thank you for having me.
Thank you. Are you?
Yes, me. Yeah. So our next speaker is Becky Pink, and she's a retrieval practitioner working with the East of England ACCTS. She's going to be presenting to us on a project she's been working on, looking at the feasibility of pupillometry in transfer medicine. Becky, are you there? Turn your camera on. Yeah. Can you share your slides?
I can. Can you hear me okay?
Yes, we can. Over to you.
I just need to share, sorry, a bit non-tech savvy. Okay, there we go. You should be able to see them now. Is that all okay?
Yeah.
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 Okay, perfect. Thank you. So I'm Becky. I am a transfer practitioner with the East of England Adult Critical Care Transfer Service. I've worked in critical care since 2011 at Adam Brooks Hospital with a background of general ITU and neuro critical care. So I joined the transfer service in February last year on secondment for a year and fell in love with the job and luckily got a permanent job, and I now work there full time. So I'm going to speak to you today about pupillometers in transfer and are they a feasible tool for us to use? So I'm going to go through the pupillometer itself briefly, the pupillometer versus a pen torch, the implementation into our transfer service, the potential issues that we thought we may come across and how we combated them, the survey that we put out to our staff and the results. Is it a feasible tool? The ultimate question. Has it changed our practice and what we're going to do moving forward? So this is the pupillometer itself. It is a handheld, non-invasive device that measures the size and reactivity of pupils. The NPI stands for Neurological Pupil Index. As you can see in the middle picture, it is a numerical score. If it's 0, the pupils are non-reactive. If it is below 3, they are sluggish. And anything between 3 and about 4.9, they are reactive or brisk, as we say. They have a smart guard as well, which you can see on the right-hand side of the screen. This clips onto the back. It has a microchip in the top, so you can register it to your patient through an NHS number, or we use an MRN number in our trust. And then you can recall previous readings of this patient back up. The smart guards hold 168 paired readings of pupils. They're mainly used in ITUs, especially neuro ITUs. I've seen them a bit more in EDs now, but they've never been used before in the pre-hospital setting. So this is just a demonstration of how they are used. You balance it on the patient's cheek. You press the button for the right or left pupil, whichever one you're measuring. It takes 3 seconds per reading, and the results are instant. So why use the pupillometer versus a pen torch? There's lots of research out there looking at this and looking at user error with a pen torch, looking at different environments that we are in when we're using them. So they are more reliable. They give you a very quick result. As I said, it's only 3 seconds per reading. They are objective. There's no, or is it reactive? Is it not? Is it sluggish? They will give you a definitive reading of what those pupils are doing. You can look back at your readings and see trends over time, which for us in transfer is good if we've been doing this on a patient from when we go to the referring hospital. We can show neurosurgeons or whoever's interested the timeline of what's happened to this patient's pupils en route. The smart guards, as I said, you can review previous readings. It actually shows you a video of the last reading you did. They're timestamped data. And you can use these for the entire patient journey if the referring hospital, the transfer service and receiving hospital are using the same pupillometers. This offers a continuity of care. We can deliver ICU standards earlier in the patient journey and can be used in many different environments. So I've had practitioners say to me they've been in the back of an ambulance with the sun shining through the top and they've had to put a coat over themselves to try and use a pen torch. Or if you're in a bright environment in an A&E, the pupillometer eliminates all of those variabilities and can be used anywhere. So it came about being implemented into our transfer service when I had a discussion with my practice development lead. Obviously, I've used these a lot in neuro ITU, and it was raised in one of our team meetings, had a lot of support for them. However, I raised some issues of how are we going to charge them? The charging dock is not going to be stable in an ambulance. Will the battery life last? How are we going to store them? They're normally used in ITUs. They don't come with bags. How are we going to safely use them en route so nobody's put in danger? And would they work en route in an unstable environment with the state of the roads and the potholes? You can imagine that's very bumpy at times. So myself and my wonderful colleague, Robin Winters, embarked on trying to find out the answers to all of these questions. So here is the timeline of what we have done. So in May of last year, I contacted our local neurocritical care unit. I knew they had some old devices as they bought new ones, see if we could borrow those to run a trial. Unfortunately, they weren't in very good condition. So after a lot of toing and throwing, I then decided to contact Prospect Diagnostics, who have agreed to give us a 6-month loan of 2 devices. In September, we then received the devices and we started to discuss this project with one of our local neurosurgeons. We had a lot of great ideas, but after meeting with our research support team, we ultimately brought it back down to the very basic question of, are they feasible to use in transfer? Because if they're not, we can't go any further with any research, because if we can't use them, that's not going to happen. So that was our question. We commenced staff training via online presentation and a quiz afterwards that they had to pass. We did training sessions in our multidisciplinary team days, and we did ad hoc training when we bumped into staff on shift or working with them, and we just ran through how to use the pupillometer. We registered it as a service evaluation and devised a staff survey, which we ran between December last year and March of this year. So ironing out these potential issues that I mentioned. So with regards to the pupillometer, these are ours that we've currently got at our base. As you can see in the docks here, they're not very stable. If you bump into them, they're going to fall out of them. In an ambulance, they're not going to be steady and safe. So I left them off charge once they'd been fully charged for 5 days. They were untouched and unused in this time. And then I used them every 15 minutes for an hour before I got called out on a transfer. So I did a second test where I took them off of charge and used them for 2 hours every 15 to 30 minutes. This is probably the average time that we would use them on a patient. And the batteries lasted absolutely fine. With regards to storing them, the pupillometers itself, as I said, they're normally used in hospitals. We don't have storage bags for them. So I found a couple of EPOC bags, so blood gas analyzer bags lying around. And as you can see, they fit quite nicely in there with a smart guard. And I'm a bit savvy with my vinyl cutter, so I made some labels to go over the top so we could identify what was in the bags. So this is myself and my practice development lead, just demonstrating how we could use these safely within an ambulance. So I'm sat here in the rear-facing seat. I have my seatbelt on. We did discover that you can use the pupillometer at different angles. As long as you're holding it in the right angle and the pupil is center, you're able to use it upside down, sideways, the normal way up with no issues whatsoever. And the patient head is slightly lowered here. I know with a lot of our neuro patients, we like them to be at 30 degrees. However, it takes about 10 seconds to do these readings. So if we can lower the head of the patient, you can sit in the rear-facing seat, do their pupils, raise them back up again. Or if you've got long arms and your patient doesn't have any spinal injuries, you could tilt their head towards you. And from the side seat, we have had some staff able to reach the patients and do the pupils that way. Otherwise, you would have to pull over and do readings if you were concerned. So the survey we put out was of 9 questions. We had a response rate of 22%. They were very basic questions, again, just to answer if they were feasible to use in transfer. So was the smart guard easy to attach? Was the pupillometer easy to use and the readings easy to interpret? 100% yes. Pupillometer was easy to store. 95.2% said yes. One person said no, and I will come on to that at the reason of why. The battery life was lasting for the entire shift. The pupillometer and pen torch readings match. So I did ask staff to do both. A lot of our staff are very experienced in using a pen torch. They're neuro-ITU background, they're neuro consultants, they work in neuro theatres, or they're ODPs that work in neuro theatres. So I believe this is why we have quite a high yes on this, but some no. How often did you use a pupillometer? This was a multi-answer question. So if somebody used it on pick up and drop off and every 15 minutes or every 30 minutes, they could answer both of those sections. So as you can see, the majority of our patients, they were used every 15 minutes and on pick up and drop off only. I then asked just to have any positive feedback or what they found useful about the pupillometers. And as you can see here, this is just a breakdown of the answers. So it assisted with diagnosis and withdrawal of a patient. You could use the same smart guard from referring hospital through the transfer to the receiving hospital so that they could see all the results for that patient, eliminate human subjectivity, worked well on blues and bumpy roads, timely and appropriate escalations of care, confidence in results, and provides clarification, and useful with difficult reading pupils, so such as dark irises, and the ease and accuracy of the device. So this is my favourite slide because it only has 4 issues on it, which I think is brilliant for something we've never used before. So storage of more than 1 smart guard. You can fit 2 into the bag, but there's plenty of storage within the ambulance. We have silver cabinets on our trolleys, so we can put spare smart guards in there if you were out doing back-to-back transfers and you needed more than 1. A stylus for entering the patient ID. This person fully admitted their fingers were a little bit bigger, so you could buy a stylus for them. It would work as it is a touchscreen device, but you can also buy printers, wristband printers, and the device itself has a scanner on it. So eventually you'd be able to just scan the wristband and it would automatically enter the ID for you. Pupil readings of 0 and asking for a rescan. This was actually my patient. It was on a very, very, very bumpy road. His pupils were equal and reactive when we left. I struggled to get readings throughout. And when we finally got to hospital and were stationary again, they were equal and reactive. So I wasn't too concerned. However, I do believe this was probably due to it being an old device that I was using, that had been used for training a lot from the company that provided them for us. And also from Kings Lynn down to Cambridge, there is 1,000,001 potholes. So it made it quite difficult. And the battery not lasting for the whole shift. I had a look back at when this issue was logged, and it was when we had the 2 devices on loan. We have 3 teams as we run a 24-hour service. So I believe that potentially Pupillometer had been out with the day shift all day, put back on charge briefly. The night team came in, took the same Pupillometer off charge, and again had it off charge for another 12 hours. They do go into a battery saving mode after 5 minutes and turn off after 30, but 24 hours is quite a long time for it to be used and not on charge. So we have actually purchased 4 pupillometers. So we have 3 in use, which allows each team to have a fully charged pupillometer before they go out on their shift. So is it feasible? Yes, is the basic answer. We have had such positive feedback, as you can see from the results of our survey, compared to the issues that we have come across. A lot of staff still give me positive comments about how easy they are to use, how it took out the guesswork, how it guided their use of, say, hypertonic saline on a patient, how they were able to provide confident data to neurosurgeons or other ITU consultants whilst on transfer. And we have had a lot of interest from A&E departments and staff in there asking what the device is, how it works, how good it is, etc. So they work well in the back of an ambulance. So I believe they are definitely feasible. Has it changed our practice? I have 2 case studies here for you to have a quick look at. So this one's a young female with an intraventricular hemorrhage. She was going from the NNN to Cambridge, and her pupils were 2 millimeters and non-reactive from the start of her transfer. There was no change en route. The plan originally was to admit to the neurocritical care unit and a potential for a repeat CT. When her pupils were checked on the unit on arrival, they had dilated to a size 5 millimeter and were still non-reactive. The neurosurgeon questioned when this change had happened, and when our practitioner said that it just happened, he kind of got the and she said, no, it has. And we were able to actually pull the pupillometer out, attach the smart guard and show all the readings. And we could pinpoint within a 10-minute time frame of exactly when these pupils had changed. So that responded in them fast bleeping, the more senior neurosurgeon having an urgent CT, and this lady actually went for an EVD urgently. The second case study is again of a young chap, had an intracranial hemorrhage, was in Colchester, and the plan was to go to Cambridge. He had a low GCS and was intubated, and pupils were reactive, but then they had become sluggish. When our team arrived, we assessed them with the pupillometer, and they were actually reading as being very fixed and dilated. They had a conversation with the neurosurgeons at Adam Brooks and provided this information, and the decision was then to unfortunately stand down the transfer, keep the patient where he was, and they withdrew treatment on him. I think this is quite a significant change in our practice, because if that reading was just done as a pen torch and we weren't quite sure of whether they were sluggish or whether they were fixed, that transfer may still have taken place. That patient would have been away from his family, away from his local hospital, and it would have been more stressful for the family to have withdrawn treatment somewhere so far away from their home and their support system. So they decided not to transfer this patient, and they did withdraw at their local hospital with his family around him and any friends and things that could come and see him. And I think that's quite a big factor for families in such difficult circumstances. And it gave us certainty and confidence in saying, no, these pupils are actually fixed and dilated. And again, it took out that guesswork and aided decision making for this patient. So moving forward, we have, as I said, bought 4 pupillometers for our service, as we think they have added to the safe transfer of all of our patient groups. We transfer a lot of neuro patients into Addenbrooke's, liver patients, because we've got transplant centre, but also a lot of cardiac patients to the Norfolk and Norwich, and post-cardiac arrest patients to Papworth, Royal Papworth Hospital as well. We are continuing to use it and continuing to train new staff and current staff. All of our practitioners are trained in the use of pupillometers. Doctors, I think we're about 50% there. It's just difficult to catch them if we're not on shifts together. And we are currently in further discussions, again, with our local neurosurgeons about doing further research on pupillometers. When looking back at the research over the last 10 years, it's evident that there's still a point of interest. However, there is no research or evidence about how these are used in the pre-hospital setting and how this could aid in decision-making and increasing patient care. So it's a very exciting time. And I know that was a very, very quick whistle-stop tour because I understand we're short of time, but I have my email address on here if anybody would like to contact me. Hopefully we'll have a few time for questions now. And I just want to say thank you to our service in the East of England for the support in this project, because it is something very new, and to Robin, my fellow transfer practitioner, who has helped me out with this as well. So everyone's been very engaging with this. So thank you.
Thank you, Becky. That's really interesting. We actually don't have any specific questions in the chat, just some comments saying how useful the piece of kit seems. And you've clearly presented that within your talk. It seems that the advantage is that you can use it while seated and seat belted, which for transfer is really important, because we certainly can't check the pupils when we're sat down and seat belted. But I wonder, are doctors and practitioners, nurses or DPs within your service still using the pupillometer exclusively, or do they do both? Are they checking the pupils with a pen torch as well? What are people doing on the ground practically?
I think the majority of them are actually using the pupillometer, because again, it takes out that guesswork. If they're not 100% sure on what the pupils are doing, the pupillometer gives you that definitive reading of exactly the size and the reactivity of the pupils. So I believe that they are all using the pupillometer exclusively. The pen torch, I don't particularly like using it too much, because I find we don't tend to check the battery on the pen torches. You know, so yes, I've got a pen torch, but is that battery depleting? Is the light reduced? Whereas all of that is eliminated with the pupillometer. As I said, I constantly have comments when people come back from transfers about, oh, it was great because this happened and I was able to use it for this and it guided this treatment, or we were able to give the details. So it's been a very exciting time introducing them, and I've loved every minute of doing it. And I think to any service, they would be a great addition.
I think the key here is that the neurointensive care unit that you're taking the patients to have adopted it, and they use it, and therefore are interested in you doing it and looking at the results of it, whereas the neurointensive care unit, certainly in our region, haven't adopted it. So I think it would be a little bit different, and I guess it depends on you whether you've got buy-in from your neurointensive care unit to start off with. But I can see the advantage of this continuous monitoring, and then it could be used on the patient when they get there. Thanks a lot for your talk, and we can put your email address in the Q&A, and then people can email you if they've got any further questions. Thank you very much.
Thank you very much.
Our next speaker is Dr. Jonny Mayes. He's an ST3 anaesthetic trainee working in the University Hospital of North Durham, and he's got an interest in critical care transport. He's going to present to us a guideline for the transfer of patients with acute aortic syndromes. I can see you on the screen there, Jonny. Yeah.
Okay, great. So yeah, thank you for that. Thank you for that introduction. So yes, I'm one of the anaesthetic trainees based in the northern region. I'm going to talk about a case of aortic dissection that I had at a district general hospital, Northumbria, for those that know the northern region. And what we did, and I'm going to touch briefly on some of the guidelines that are available for kind of transfer of these patients. So a bit of an introduction about the epidemiology of aortic dissection. There's about 4,000 deaths per year in the UK, and a type A dissection, so that means involving the aortic arch, is identified in 62%. And in a city the size of Newcastle, this probably means 60 per year. Half of those patients will die before they get to hospital. The kind of mean age of someone who with an aortic dissection is 72. Survival rates are much better if you're kind of below the age of 80. And primarily it's kind of 50 to 60 is kind of the average age that people are operated on with this condition. And this was our case. So to set the scene, this was a busy A&E on a Saturday morning, and we had a man in his 50s collapsed with chest pain and loss of consciousness. He was witnessed by his wife, who phoned an ambulance, and he was brought into the A&E. He was usually pretty fit and well, really. He had two hypertensive agents. One was a beta blocker, which is relevant a little bit later on. But he wasn't kind of vascular, wasn't a smoker. He played badminton 3 times a week. He wasn't diabetic, and was previously pretty fit and active. On arrival, he kind of on examination, all his observations were completely normal. They had a blood pressure cuff on the right-hand side, which again is important and something I'll come on to later on. But it was noticed that he was in pain. His main complaint was pain in his right leg, and he was unable to move that leg, which seemed very concerning. And with that in mind, and combined with the chest pain, he had a full body CT once he arrived within the department. And this is what it showed. So it showed a type A aortic dissection involving the aortic root extending to the abdominal aorta and involving the right kidney and right leg. So he had an ischemic kidney and his leg had critical ischemia as well. He had a CT aortogram recognized by the radiographer after the kind of the initial CT. And he's been extremely unlucky to have 2 of the most common complications from an aortic dissection. Looking at the literature, each of the complications that I've listed, sort of kind of cardiac tamponade, well, not cardiac tamponade, that's actually more common, but mesenteric ischemia, acute renal failure, and lower limb tend to be present in about 10% of people with dissection. So to get 2 was incredibly unlucky, but it did add to kind of the obviously urgency of the case. So this is the kind of ideal management. So analgesia, and that is primarily to obviously for patient comfort, but also to bring down the blood pressure. So he had received some morphine and paracetamol. Monitor and treat blood pressure, and I'll come on to talk about the treatments for those. Refer to cardiothoracic. So this was he was initially referred to vascular, who said cardiothoracic would be the first point of call, and a rapid transfer. The kind of this think aorta quite a few times when I was researching, and basically dissection is incredibly difficult to diagnose. This was quite a severe presentation that actually made it a bit easier that CT scan was going to be appropriate, but there can be more subtle signs and perhaps like initial presentation to A&E as a kind of herald bleed before a second larger bleed. So chest pain, which is maximum at when it first comes on, is one that is the most specific sign for detecting aortic dissection. Type A, more likely to be chest pain. Type B, more likely to be radiating through to the back from the kind of evidence of how you recognise these. So this man had some of this treatment. He was being treated by one of the SHOs in the emergency department as the consultant registrar was busy with another case. We were kind of phoned to assist, and I'll come on to the timeline of how this all happened. But so I was the anaesthetic for general theatres. The ICU team were already conducting another neurosurgical transfer of a patient to the kind of tertiary centre. So they'd taken the transfer trolley, and there was limited staff available for this transfer. And I'll come on to talk about who should be doing this transfer later on. The ED team had put an arterial line in the right-hand side. Unfortunately, this is the kind of wrong side to guide your treatment to. It should be in the left-hand side, and that's because one of the kind of nominant artery which comes off the aortic arch can be involved in dissection, so it can give you kind of false readings. You don't actually have to have an arterial line according to the guidance. Non-invasive blood pressure is fine because of kind of the whole thing about speed of transfer. He had a blue light transfer with myself, a paramedic, and an ambulance technician as well. He was starting a GTN infusion. The first line for bringing down patients' blood pressure who've had a dissection is a beta blocker, unless they're already on a beta blocker, which this gentleman was. The guidance difference on local protocols on the second line, calcium channel blockers are mostly second line, but the GTN was started basically for familiarity of the ED team in this patient. And it's quite simple. It's kind of 1 milligram per mil and targeting a kind of blood pressure below 120 systolic on the left hand arterial line. The transfer was uneventful itself. It's about a 50-minute drive from Northumbria's A&E department to the Freeman, which is the tertiary centre. But then we had this prolonged handover to the cardiothoracic team, and this is where kind of human factors came into this. It was clear that the consultant hadn't had great communication with his registrar to whom the referral was made, and he went into quite a long history, which included kind of TB history in this gentleman, and also quite a long consent process, which can obviously be appropriate, and his wife was there as well. But this man had different painkillers. He was still able to respond to questions, but was a little bit confused and in a lot of pain for a surgery that this man kind of essentially had to have. So the mortality, the 30-day mortality without surgery is above 90%. With surgery in patients who haven't got the complications that he has, it's about 25%. But this man had already kind of been briefed by the ED team and myself that he was going to require kind of operative management of this condition. So this was the kind of timeline. So he collapsed around 9 a.m. or shortly therebefore, and by the time he arrived in A&E, it was about 9:30. The CT scan was performed an hour later, and the referral made and accepted about 40 minutes after that. I was phoned to assist about 11:30, and the ambulance transfer took place about 12 o'clock, and we arrived in the anaesthetic room by 12:45. Mortality increases in this in aortic dissections by about 3%, 1 to 3% every hour delay from the initial event. So time is really of the essence in all of these. And so I've identified some kind of areas for improvement, and we obviously work in an imperfect system, to say the least. And this was a busy Saturday shift in A&E with minimal staffing. One of the recommendations that I'll come to about is the kind of transfer of images and how quickly that happens. And the guidance produced is by the Royal College of Emergency Medicine and the Royal College of Radiologists for a reason. These basic CTs should be sent immediately to the referring centre. There was a delay in the acceptance of the referral because they couldn't see the images. And basically what we found out from this is that the images are sent without a priority. So they're just sent and join a queue, which are going across to different hospitals. There's no way of prioritising these images. So that meant a delay in the referral. So that system kind of needed to be looked at. There probably could have been things improve in terms of what we use for monitoring. So arterial lines do take a little bit longer to put in. We did actually have time to put them in while we waited for an ambulance in this case. But you don't need an arterial line for aortic dissection. You need blood pressure in the left arm, and again, that was one of the pieces that comes up in the guidance. And then half an hour to get from the Freeman into the anaesthetic room was a bit frustrating for this gentleman. And again, that's probably my learning point, that actually maybe a bit challenging, and I could have the consultant spoke to the patient for me, and I could have handed over and summarised perhaps in a more succinct way. So that's one of my learning points. These were the two main guidance. There's not a huge amount of guidance when it comes to thoracic aortic dissection. There's a lot more for aneurysms and type B dissections. And there's the first one, as I said, is produced by the Royal College of Emergency Medicine and the Royal College of Radiologists. The second one is the Acute Aortic Dissection Pathway Toolkit. This is produced by the Vascular Society and the Society for Cardiothoracic Surgeons. And it's a little bit older, but this more is setting standards for things like transfer and how quickly it should happen, and kind of who should be involved. And I did slightly disagree with their recommendations of transfer, and I'll talk about that as well. But the key points to summarise that guidance is we should be maintaining a systolic from 90 to 120 millimetres of mercury. It should be a consultant referral. There's no essential investigations other than CT to make the diagnosis prior to transfer. Bloods or any further imaging should not delay transfer. Patients should not travel with blood products unless already commenced, and transfer should be within 30 minutes of making the diagnosis. So we didn't quite hit some of those targets, and I think that led to a delay in transfer of this patient. And they give guidance on who should be transferred. So if you're under 85 with no mild or moderate systemic disease, you should be eligible for transfer. If you're over 85 or have severe systemic disease, especially of cardiac or respiratory issues, then a consultant discussion should take place. Contraindications indicating kind of severity of dissection, kind of cardiac arrest in current admission or on presentation. Intubated patients and those requiring inotropic support. And then this question about who should complete this transfer. Fortunately, I was available and able to take this patient to transfer, but kind of the traditional teaching is this doesn't necessarily require an anaesthetist or doctor to transfer. And essentially, the role in this transfer was to titrate the GTN to the blood pressure. And I guess the ideal person might be some ICU staff or one of the nurses working resus would also be appropriate. The guideline I mentioned before on acute aortic dissection suggests that this should be done by an adult critical care transport service. And I don't see how that's feasible in a case with with the urgency of the transfer and where time is of the essence. So I did kind of disagree with that recommendation. So these are the kind of key learning points I thought of. Making the diagnosis is tricky, so kind of the think aorta points, and consider this is a possible cause of kind of chest pain. The time critical nature, so do not delay transfer where it's a kind of scoop and run situation. And then finally, hypertension should be based on the left arm. It doesn't have to be an arterial line, but if you've got time to put one in, that's fine. But non-invasive blood pressure is absolutely appropriate in these cases. So that's the end of my talk. I will stop sharing. I don't know if there's any questions that I can answer.
Thank you, Jonny. Again, another interesting talk. We do have a question actually, and you slightly started to answer it towards the end of your talk, and it's about the utilisation of a transfer service. And the thing that you talked about fairly clearly through that was the timelines and the frustration with some of the timelines. So a really quick transfer from NSEC, I think it was NSEC the patient was at, yeah, to Freeman. Now 15 minutes is quick. 20 minutes is fairly standard for the people who are not in the region. So that's a quick transfer. And you were clearly frustrated by the 30 minutes then it took to get from your arrival, which I'm guessing could have been these kind of assessment area at the Freeman rather than critical care. Is that correct, Jonny?
We went straight up to cardiothoracic theatres. So we were straight into the kind of reception area of cardiothoracic theatres. Yeah.
Okay, so I can see how that may have been frustrating. The other bit that was a problem was the imaging, and I am totally with you on this. So blue light images from hospitals out with Newcastle can take 20-25 minutes, even when they're at the top of the image sending queue. So I think there were potentially an opportunity earlier on in that decision tree, if you like, to potentially mobilise a transfer service. Do you think with this particular case, there was an opportunity to have the adult critical care transfer service at the bedside at the point of decision to transfer, based on what you know of the case?
I would potentially. I think one of the issues as well that kind of identified was a bit of a lack of senior input for the ED team to make those decisions. Yeah. And they ICU were involved and made decision to phone us to transfer because they thought it would be quicker. I think with that delay in imaging, they might have been potentially trying to get the adult critical care transport team across. But certainly if there was any kind of hint of delay, I say time is of the essence to just get him going as soon as possible. So I don't know exactly how long the critical care transport team would take to get to NSEC, but they're based in the city centre. I imagine again 20 minutes, half an hour, and I think ideally just get them across as soon as possible, basically. So.
Yeah, there is going to be some new regional guidance about this for the people who are working in our region in the northeast of England. But I think once you have a diagnosis, and if you're waiting for Freeman to accept, or you're waiting for images, because the images have probably been reported locally, then a heads up to the transport service, to our transport service, and we can always mobilise on blue lights and be with you in 20 minutes. So a kind of consultant to consultant discussion could have potentially meant that we could have done this transfer from the point of decision to the point of arrival at Freeman. I'm not saying we would definitely have been able to do it in this case, because it depends on whether we were immediately available, but there is a potential for that to happen in the future. Yeah. Is there any other questions in the Q&A? No. Okay. Thank you very much, Jonny. We're going to move on to the next speaker. Thank you.
Right, so time for our next speaker, and joining us all the way from Ontario, Canada, I'm very pleased to introduce Dr. Hilary Whyte. Dr. Whyte's been the medical director of the Sick Kids Acute Transport Service for 25 years. This service is responsible for the retrieval of all critically ill neonates and children up to the age of 18 years of age within Ontario. And Dr. Whyte has been at the forefront of this service, spearheading a standardised model of transport, critical care transport competencies, and all sorts of processes and equipment to enhance patient safety. And Dr. Whyte's going to talk to us about her journey over the last 25 years in building this amazing service. Over to you, Hilary. Thank you very much.
Thank you very much indeed. I'd just like to begin by saying a big thanks to Charlie and the organising committee, of course, for inviting me to talk to you about the acute care transport service at Toronto's Sick Kids Hospital. And we are celebrating our 50th anniversary of transport medicine. Just making sure that you're all aware that although I have no specific or potential conflict of interest, I clearly have an implicit bias, as I have been the medical director of this acute care transport service team for the past 25 years. And I therefore assume complete responsibility for what you are about to receive and learn. I'd like to take you through a journey spanning 5 decades. And we've got a relatively short period of time in which to do that. I hope during this time, however, that we would be able to learn a little bit more about the key components of this specialized interfacility critical care transport service for neonates and children. Also, talk a little bit about the key healthcare performance indicators, which really have shaped decision-making and ensured the safety of not only our patients, but also our team. And look closely at some emerging technologies and therapies which can be integrated into a transport service of this nature. I think it's important to begin with understanding the context in which we operate. Ontario covers about 415,000 square miles, so we are a very, very big province, the second largest province in Canada after Quebec. And we have a population of about 15 million people, of which 21% are under the age of 18. We're a very highly regionalized healthcare service with 5 children's hospitals that you see in the red dots here, of which 4 have a pediatric intensive care unit. We have also 8 tertiary neoperinatal units and 5 remote modified level 3s across the province in the northern region, since they are rather remote. And these were established back in the late 80s. Today, we have now
Hilary, sorry to interrupt. We don't, your slides at the moment aren't advancing. So we're just going to try and sort that out for you.
I'm so sorry.
No, that's okay.
I don't know what's happening. Let me see if, no idea what's happening.
We've sent a request for control of your slides. Is
that better?
Can you click on the allow us to control the slides from here remotely? You should have.
Yeah, sure. Let me just check one thing. Is that working better? Can you see the slide advance now?
No.
Okay. Let me see what I can do.
We've requested control of your slides.
Yep.
Is there a pop-up to allow us to control them?
I've given you permission. Can you see it now?
Can we advance the slide? No. I think you have several screens open, Hilary.
All right.
Just bear with us while the tech people work in the background.
Let me see what I can do. Okay, my apologies.
We have a copy of your slides, so we are able to play them from here, and we can see.
Next zone 1, all clear. Code red, annex zone 1, all clear. Code red, annex zone 1, all clear. Thank you.
Maybe we can advance to slide 4.
Yeah. Can we advance the slides, Colin?
Yeah.
Okay. We've taken over control and we'll advance the slides for you.
Okay, my sincere apologies.
No problem at all. No problem.
The problem is obviously working remotely from Toronto. We could have the next slide actually, because we've discussed this one already. Just pointing out that our interfacility transport service, of course, not only relies on the 4 hospital-based specialized teams, but we also have a great deal of patients transferred through our emergency medical services. Of course, 59 locally based teams with 830 ambulances, and these operate throughout the entire province, Northern and Southern Ontario. The only provincial system is our Orange Air Ambulance program, and they operate across 13 bases, including both fixed wing, rotor, as well as some ambulance services. In addition, as mentioned, we have the 4 hospital-based teams, with sick kids being one of these, and I'm so sorry, I'm having difficulty seeing my own slide at this point. With sick kids being obviously one of the largest in the country. Next slide, please. Next slide, please. Thank you. That's much better. With regard to our own ACTS service, we obviously operate on the following principles. We are a consulting service. We provide advice and support to physicians in the community via a 1 number to call, which is known as Critical. We coordinate the patient transport for both emergent and urgent transports. We do not do transfers of more stable patients. ACTS operate on the basis of a timely dispatch. We put the patient first and bed second. So we typically at the time of dispatch have no idea where the patient will end up, hopefully in an appropriate and tertiary setting and hopefully as close to home as possible. We do advocate for antenatal transfer, and I was very pleased to hear the previous speaker talk about the challenges in Australia, where I've also spent about a year and a half working, and so very familiar with the territory there as well. We do really attempt to provide antenatal transfer for pregnant moms less than 30 weeks gestational age, even at long distance. Our team also supports palliation and bereavement in the community, and so we are frequently used to repatriate patients closer to home for withdrawal of or end-of-life care. We provide provincial support when other teams across the province are unavailable in our region. And you'll see from the table or the slide on the left that the three other teams operating in the province operate out of the children's hospitals in London, Hamilton, and Ottawa. Next slide, please. So the scope of practice for our team is attendance at high-risk deliveries when the mum cannot be moved, when it's unsafe to do so. We also provide neonatal stabilization, pediatric stabilization up to the 19th birthday. We do ECMO transports, and we provide a limited number of international transports with a partner in the air ambulance private industry. Next slide, please. What may be unique and different about our program, and certainly quite distinct from the adult services in our province, is that at the time of the first call, the Act's most responsible physician, or MRP, accepts responsibility for the patients and to a limited extent, accepting responsibility for the patient from that time of first call. However, we do accept full responsibility for the patient's care, resuscitation, and stabilization through transport from the arrival of our team at the referral facility and through to the arrival at the final destination. This is in distinction from other services where the transport program only accepts responsibility when they leave the referral center throughout the transport process. Our team operates under medical directives with medical online control provided by a staff consultant, either in a NICU or PICU. And obviously, the teams have a digital cell phone facilitating communication and a medical director on call 24/7 for all operational concerns as a backup to the MRP, who may have less situational awareness about where the patient is, the level of care being provided. Next, please. So this is a number of our transport service team members currently on the team. We operate obviously an RN and RT team, which is very common in the North American context. Next, please. And clearly, while the model of specialized team varies across both our own country as well as across the world, I think in the North American context and specific to our province in Ontario, we generally use the RN-RT model and therefore do not rely on physicians to provide support for the patients during the transport. This is indeed in distinction to other parts of the world where the RN-MD model is the most commonly used and the one in which we've heard a lot about this morning in the UK context. In Christine Collinson's publication back in 2011, she actually described 26 different models of team across the US, of which 40% were the RN-RT model. And there is clearly lots of literature that supports that there is no specific model superior one from another. In my own personal experience working with 3 different models of care, I can attest to the fact that what's really important is identifying appropriate professionals willing to learn the art and science behind transport medicine, rather than the actual professional designation. We've also published on a couple of occasions that in our context, the addition of an MD at a trainee level, that would be equivalent to a fellow or senior registrar, did not add any specific value. That said, next slide, please. We operate very much in a context where our physicians are very much part of the team while they're being educated in the art of transport medicine. Next, please. So all told, the ACTS team consists of 32 FTEs, actually, with the RN-RT complement, 27 RTs and 11 my apologies, 27 RNs and 11 RTs. We are supported by a manager and educator, and I want to note that more than 40% of our team have 15 years or more experience. At the same time, we are constantly in a learning mode and expanding and bringing new members onto the team. And so almost a third of our team members are less than 5 years experienced in transport. Next, please. I want to recognize my two associate medical directors. On the left, Marco Koljat, who just joined us following 2 years as a transport fellow, and supports the neonatal service as an associate director. And Andrew Helmers, my colleague in PICU, who has joined the team back in 2021, along with Haley Christian, who is one of the pediatric cardiac intensivists, who is my cardiac liaison with the cardiac critical care unit. Next, please. I should have mentioned we have a dedicated staff neonatologist who operates on the transport service on a 8 in the morning till 6 in the evening, providing a special line of service for the transport activities, which tend to be most busy during those hours. But naturally, over the course of the night and weekends, we very heavily rely on a consultant staff in both the NICU and the PICU. This slide is not intended for you to be able to read it, but rather to understand that the ACCS team operates in conjunction with our provincial partners. Over on the right, I've mentioned already EMS services, our land and air ambulance, and our one number to call service, Critical. But importantly, this ACCS team would not exist if it wasn't for the leadership provided by our director, seen on the left, Jackie, our manager on the right at the top of the slide, Christy, as well as our full-time educator. And in the right-hand corner, showing off a set of HIPAA goggles, our hopeful next step in telemedicine and offering us a virtual care is Jennifer, who is our communications expert. So it does take a village to raise a family, or a child rather, and clearly takes many, many people, including our physicians, our medical support staff, as well as our biomedical engineers, our IT systems, and our quality risk management in order to sustain the service. Next, please. So I'm not going to belabor the point that we are 50 years old, and so we have a really important history. I will, however, touch on the fact that over the last 50 years, we have clearly evolved from the early start in 1974 as an RN neonatal only transport service through to my taking over the team in 1998 and expanding into the realm of pediatrics and adding a large number of the people and supports that you saw in the previous slide. And finally, in the most recent epoch, which has become an era, I should say, of specialization and innovation in transport. I do want to highlight that it was Graham Chance, an Englishman, who was responsible for co-leading the early transport program, and I would suggest published a seminal article back in 1979 indicating that high-risk babies born outside a tertiary setting, transported by a specialized trained team, would have a significantly decreased mortality and morbidity rate. And I think this was a seminal article which really did change the face of how we view transport specific to the neonatal population. Next slide, please. And again, just to highlight that our early beginnings are also thanks to the gentleman seen on the left, another Englishman, Professor Paul Swire, who began the neonatal intensive care unit back in Sick Kids in 1961 as one of the first 2 newborn intensive care units in Canada. So thanks to two Englishmen, I think relevant here to today's discussions, and furthermore, the fellow Dr. Derek, I should say, Matthews on the right-hand side, that the team began its early stages in 1974. And subsequently, next slide, please, over the course of the next decade, these individuals were responsible for training up a group of RNs. At that time, we were an RN only team, to really provide a very sophisticated level of care equivalent to what would be provided in any tertiary critical care unit in a neonatal ICU. Next, please. At that stage, Barry Smith, the gentleman seen in the middle, who was actually a Canadian, not English this time, really dedicated a significant amount of time. As division chief, he actually took a personal leave every Friday and went on transports with his 11 ladies. You'll see some of the earlier members of the team here in this slide. And of course, we still have a couple of those individuals working with us today. Next slide, please. Andrew James was actually in the early 90s, the medical director of the team. And moving on to the next slide, we operate, of course, out of the Hospital for Sick Children here, seen on this slide, established in 1993. And we're in the process of building a new hospital where our transport team will be co-located with both cardiac, pediatric, and newborn ICUs. Next slide, please. So in 1998, I was approached by the then CEO, a previous NICU nurse, who was well known to me, asking if I would be interested in taking over medical leadership of this team. This team, which was providing at that time a neonatal only service at a very sophisticated and high level of care. With my background in neonatology, as well as pediatric emergency medicine, since I had practiced for, or have practiced for over 30 years in our pediatric emergency medicine program as well, I think it gave me some credibility to expand the team into a neo-peds model. And so I only undertook this new job activity, if you wish, with the understanding that we could hire respiratory therapists onto the team, that we would expand to the population at least up to the 13th birthday, and that I would need the addition of both a manager and an educator in order to achieve this. I'm pleased to say we achieved all of the above within a 2-month time frame. And so we began looking at our training program and what that curriculum would look like for both newborn and pediatric education. The RN-RT team that is hired, and we still have the same model today, hire from either Peds Emerge Medicine, Pediatric ICU, NICU, or cardiac ICU. You have to have a minimum of 3 to 5 years before you would be considered to come into the Transport Associate Training Program, which typically lasts for about 6 months, during which time individuals can decide whether they feel that this is the job for them, in it for life, and when they are interviewed and assessed as appropriate for clinicians in training, they move into a competency-based program, which takes approximately a year. So it's almost like doing a fellowship in pediatric ICU or NICU medicine. At that time, they become a certified clinician. And it would be fair to say that there is expected to be a small failure rate of between 5 and 10% of individuals who, while they may wish to do this, clearly do not beat the bar. And we really do have a very high bar set since we do not have doctors on each of our transports. Next, please. So again, this is not a slide for you to be able to see or digest, except to say that we have a very robust curriculum, a robust training program, which is multimodal, and we do use a lot of simulation in our training, as is the case with most transport services. Next, please. Most importantly, and again, unique maybe to the model we've established in Ontario and specifically led by our team, the ACT service, we insist that the RNs and RTs are completely cross-trained. And that provides us maximum flexibility for staffing so that 2 RNs or 2 RTs might actually go out on a transport rather than an RN and an RT. And because they are fully cross-trained in all of the skills necessary, both vascular access, airway management, advanced airway management, of course, as well as the emergency skills of thoracentesis, paracentesis, defibrillation, and so forth. And it's really important to recognize that the level of care that they are providing essentially is a mobile ICU, where we bring the intensive care environment to the patient, as is the case with any sophisticated transport program. Next, please. One of the fun aspects of our training is our underwater safety training. And this here is just a few slides showing how, while it's quite a tough day and quite an energetic experience, it's also a great team building experience. We also subject our team to winter survival training, just in case they should ever be stranded in the event, unlucky event, that a plane or a helicopter were to go down. Next, please. And just to mention that while the competencies of clinicians are clearly important right across all 7 competencies that we expect of our team, or buckets of competencies, I should say, we adopted the communication tool, the SBAR, from the air medical industry. And in fact, as a result, we decreased our error rate or our safety rates significantly, and have published a couple of times on how important it is to have a communication tool that everybody, both your community as well as your team, understand. And the SBAR has proven for us to be highly effective, improving accuracy, not only on the phone, but also accuracy in handover at the receiving centers. Next, please. The 7 buckets of competencies you can see there include, of course, professional responsibilities and competency, communication, health and safety, the assessment and diagnostics, which is a very big bucket, of course, therapeutics, and the full integration of that into critical thinking and problem solving, as well as the all the tools and tricks of the trade, which are covered under the bucket of transportation. And these competencies, which we developed many years ago as a requirement for each of our team members, have been adopted by Accreditation Canada as a minimum standard for all clinicians in transport. Next, please. I won't spend a lot of time on this in the interest of time, except to say back in the early 2000s, we recognized the importance of recording all of our consultations as well as our advice and transport recommendations. And this has really served us well and gotten many referring community providers out of a difficult situation when there was a potential medical legal suit, because it really is the only source of truth. Despite however hard we try with documentation, having the recorded line on a bridge, a conference call is really, really important. And these are kept for as a permanent record and associated with the medical chart. Next, please. Just a plug also for the fact that in 2002, as part of the ask, I recommended that we would be able to provide a training ground for transport physicians who were completing their fellowships in ICU, be it neonatal, pediatric, or for that matter, pediatric emergency medicine and pediatric anesthesiology. And so we've attracted individuals post-fellowship, post-training in those 4 disciplines into our transport medicine training program, which is a clinical training program lasting for a year. And our first 3 fellows, Frank Broomfield, New Zealander, Irfan Chima from the UK, from Oxford specifically, and Eugene Ng from Toronto, Canada, were supported through their training program by myself, of course, as medical lead, and an associate medical lead I was able to bring on that time, Dr. Kyung Soon Lee. Next, please. The fellowship in transport medicine has been really quite popular with people from all over the world. And this map just demonstrates that in the last 20 years or so, We've trained 75 people in the art of transport medicine, bringing critical care to kids and newborns. And the majority have gone back to faculty positions in their home country. I've managed to make sure that a number of them have stayed in Toronto and brought a couple of them on faculty to help us with our transport mission. Next, please. And so the final epoch, which by far and away has been the busiest epoch, has essentially demonstrated the need for a Canadian NeoPEDS transport network, which began with those 16 teams that I spoke about back in 2013. We came together, we developed a database, and it has been a real pleasure to see how that has come together, with now something over 40,000 patients entered into that database, which provides us with tremendous opportunity for benchmarking and comparing our metrics overall. We use Critical as the one number to call for both neonatal and pediatric transports. And we expanded our mandate through the age of 13 and then finally up to 19 years of age. A big important part of the work we do is having appropriately standardized and certified equipment. And I'll just show you, I think, in a slide or two, the kind of setup which would be familiar to all of you in transport medicine, both for newborn as well as pediatric systems. And the Air Canada requirements for certification in each individual aircraft is really quite rigorous. And so it's important to recognize that not only do you choose the best of brand, but the best of brand has to be appropriately secured and not only to the system, but also to the stretcher. We've also introduced a more robust quality improvement program, and we have finally achieved dedicated ambulances. And that took many, many years to recognize that a 911 responder coming to pick up our transport team from the hospital to move out to the referral center was a tremendous waste of time and resulting in patient morbidity. Finally got the go-ahead to have dedicated ambulances as part of each of our team. And we operate 5 teams around the clock. So we actually have 3 dedicated vehicles. Next. And I'll advance the slides again, please. This just demonstrates our 16 teams. And on the right, in the very first year of our transport database, you'll see on the right 850 neonatal critical care transports transported by our team. So we are by far and away the biggest and busiest in the country, and therefore have the privilege of having a dedicated system with many people that support us and have been able to provide a great deal of leadership for transport medicine generally across the country. Next, please. I'll advance the next slide, please. And so to recognize the database, which we collect from across all of the teams, now a neo-pediatric database, we obviously have many metrics that we adhere to, very similar to the GAMUT system, which some members, some of you may be members of, or certainly our Australian colleagues have adopted in some places. In terms of our system and process at the moment, we're really focused on out-of-scope births and trying to make sure that we play our part in limiting the number of out-of-scope deliveries. While we attend deliveries, we do try to make sure that the mothers are transferred appropriately ahead of time, ahead of delivery. And we pay particular attention to both our dispatch and mobilization time, now that we have our own dedicated ambulances. And similarly, we pay a lot of attention to adverse events, as would be common across any teams. Procedural success is really important to us. And the advent of focus on transport, which occurred about 5 years ago initially and continuing to grow inevitably as it does across not only vascular access, but also lung, heart, and brain, is really important to us. Next slide, please. And this is just to show you that while the neonatal and pediatric calls come in initially as a consultation. In the world of neonatal medicine, we are transporting only about 57% of those calls. About 31% end up in advice only. On the other hand, within our pediatric population, we transport about 64% of the advice and consultation calls that come in. And so I think this represents the fact that over the course of the last 30 years, the ACTS team have really been responsible through our outreach program for helping level 2 units get up to a much more advanced level of care, so that we are surrounded by a network of about 20 level 2 units who can provide CPAP or non-invasive respiratory support for newborns, 30 weeks and greater, and a short-term ventilation, usually until the team can arrive. We haven't been as capable of developing the pediatric aspects of critical care within our community, and that's work that's currently in progress. Next slide, please. And again, not to belabor the point that since we do neo and pediatric transport across the age ranges, there's a large number, of course, of our patient population have either infectious or respiratory illnesses, of course, particularly during respiratory season. And this is seen both in the neonatal as well as the pediatric populations. But knowing what a patient population is, seeing there that we have a large number of neurological presentations really does help to drive our curriculum and our maintenance of competencies. And next slide, please. You will see that while the level of respiratory support provided in the newborn population is about 35% invasive ventilation and a similar percentage non-invasive, in other words, about a third of our neonates, largely surgical newborns being transported for developmental anomalies, a large number do not have airway management concerns. And about 30% of the advanced airways are actually carried out specifically by our team. A much smaller number, in the region of 4% of children, are actually needing to be intubated on the arrival of our transport program, since I think adult anesthesiologists and pediatricians are more comfortable with intubating the older population. Next, please. And cognizant of time, I'd like to just move on to the next slide and demonstrate that up on the left, you see that we have tried to adhere to the best of brand, and I've seen many of the same ventilators, monitors, biberon pumps, etc., in your systems in the UK. But importantly, we've also tried to maintain a similarity across our pediatric and newborn systems. And obviously, our pediatric stretcher and neonatal stretcher are fully certified for air and land. Next, please. And as a result of our dedicated ambulances and reflecting on the fact that we have taken these vehicles and modified them, customized them to meet the needs of our patient population, our equipment and supplies, and we made actually almost 50 modifications in the back of the ambulance to suit our patient population 0 to 18. Next, please. And I'll advance further just to say that we obviously at the time of dispatch, because we are a busy service transporting well over 2,200 patients a year, all of them critical, and taking about 4,500 consult calls a year, it's really important that we have a system for triage. And so we've adopted from our pediatric emergency medicine colleagues the Canadian triage and acuity scale, which we used at the time of that first call to determine not only our dispatch appropriateness, but our dispatch and mobilization time for our teams. Next, please. And we'll move on just to say that we have been recognized, hence the previous slide, by our hospital and by our foundation as being exemplary in providing quality care. Over the last 5-7 years, we've had a quality care lead. One of our senior clinicians, Bridget, helped ably by our Jen, who is in control of our telemedicine program. and also provides a lot of support in the community. We've developed neonatal rapid response teams to the emergency department. We've developed to our the point of donning and doffing in the world of pandemic, an expedited process, because it's most important to keep our teams safe, even when dealing with emergencies. We had to adopt this very rapidly, of course, at the beginning of the pandemic, and we were given precisely 5 days in order to train our team, have the appropriate supplies and equipment in order to transport free ECMO adult patients. And we transported about 50 ECMO patients over the course of the pandemic using the skill set of our NeoPeds team. Next, please. Quality improvement projects are really abundant. One of the ones we're entertaining at the moment is providing desired feedback to our community providers on all of the patients they transfer or require or request transport to our tertiary facilities. And I may add, we transport to not only our own hospital, but our tertiary perinatal units as well. And that quality improvement project is being launched in a formal way, as there's many aspects to this, so that we have a sustainable model going forward. We do a run review, next please, of every single transport on a daily basis. And so while it occupies a significant amount of the physician lead time, as well as our fellows in training and our transport coordinators, the clinicians, the clinical teams that are in-house really get a lot of benefit from these run reviews. And we really operate an all teach, all learn environment. When we discover that there's been a very challenging case or potentially a mortality during transport or prior to moving the patient more frequently, we offer a joint debrief as well as the obvious structured debrief to our teams. And those joint debriefs have gone down extremely well, so that we are now inundated with requests from our community to provide them with the clinical debrief situation. Next, please. And I'm just about to wrap up. If we can move on one more and one more, to say that we were recognized for our leadership in safety and systems innovation by being given the Sick Kids President Award in 2019, of which we're very proud, and we get to wear a badge should we choose to do so. I can promise nobody does. Next, please. And so what's in store next? Well, we are trying to incorporate telemedicine routinely into our program. This is really a challenge because of a lack of funding, and obviously a lot of people doing a lot of telemedicine in a variety of different ways. So it's really like spaghetti junction at the moment, but we are trying to establish a system that works for transport and for our team. We are moving rapidly through our POCUS program, gaining experience not only in vascular access, which has changed the face of how we do business in the community. Most patients will have central venous access as well as peripheral arterial line. We are looking at a mobile PIC team to serve our community well, and we're obviously always looking at opportunities for better monitoring of our neurocritical care patient population, which is quite significant. And I think we can that would be the final slide. And I'd really like to thank you. We can move on from this, please. Like to thank you for your attention, and recognize that this really has been an incredible 50 years in transport medicine, an incredible 25 years for me in the field of transport medicine, wearing both my emergency room as well as my neonatal hat. And when I add up our current group of transport clinicians, we add up to 450 years of clinical caring. Thank you. We might have time for one question, I suspect, and I do apologize for the slide problems. I had taken out a number of those problems after sending you the deck. And so it really is a mad dash through a 50-year history.
Thank you very much, Hilary. That was fantastic. And thanks for working with us with our tech. I'm glad we managed to sort things out so we could progress the slides. We do have a couple of questions for you. And one is about families. And are they able to travel with sick babies and children? And how are they supported by your service when they do?
Always. So all pediatric transports I would say all pediatric transports are accompanied by either a parent or an accompanying adult. There would be very rare situations where that would not occur. In fact, it's one of our quality metrics. So if the family is not a parent or two, not accompanying the child, we want to know why. The neonatal population is much more challenging. And so that's where we always offer for a parent, typically a father, to join the team and come back. Most of our transports, 97%, are actually done by road, which makes it very feasible. It's much more challenging, obviously, for the neonatal population, where invariably the partner is really challenged with staying with the mom who's just newly delivered versus coming with the baby. But we do encourage it, and sometimes we'll bring a grandparent if that's the wish of the parent. Okay. So it is a quality metric, and it's a really important part. And how do we provide support? Well, now that we have our own dedicated vehicles, we also have 2 paramedics in the front of the ambulance, because that is the Ambulance Act requirement, 2 paramedics in every ambulance. And so we use our paramedics a lot to provide family care, family-centered care, and maintain that connectivity throughout the entire transport process. We never ask parents to leave the room or leave the bedside during resuscitation or stabilization. They're part of the team, and I think it works really well. And of course, there's literature supporting that as a notion, because parents need to see just how hard we work to stabilize their baby or their child.
Absolutely. And it was interesting that you talked about how you upscaled, if you like, or changed the scale of your work during COVID to facilitate transfer of adults requiring ECMO or specialist respiratory services. Is there a similar model now established for adult critical care transfer in Ontario, or is that still done by, is there not the same need? Is it different?
No, it's not. So that's a great question. And obviously I didn't say too much about the Orange service. So the only adult service that has critical care paramedics is the Orange service. And so while they started life in 1998, combining 5 different bases to create this Ontario-wide program, provincially funded, direct line of communication to the Department of Health and funded by them, they are the only service providing critical care for interfacility transport for adult patients. They have both rotor as well as fixed wing aircraft. And more recently, in the last 10 years, have developed a provincial interfacility transport program with their land-based service. So we do have a similar adult service, but it's limited in resources, and our service being largest and busiest, we were approached as the obvious service to help within the province of Ontario and indeed beyond. We did some transports across boundaries, across provinces during that pandemic, which was helpful to the adult service. So yes, rather than the adult service helping the children, we did the other way around, because of course there were far more adults who were sick with a very critical illness than there were children.
Fantastic. And finally, because I think this has generated a lot of interest amongst our audience, people want to know how they can apply for a fellowship to come and work with you potentially, and how long in advance they would need to think about that.
Send me an email. I run the program, and my email should have been on the last slide, but never mind. I'll put it in the chat in the Q&A. send me an email, and really, ideally, the sooner the better. But we do make decisions 9 months to a year ahead of our intake. We try to intake at the beginning of our academic year in Canada, which is July, but we make exceptions for people coming from Australia, the UK, who may be finishing in February or September. And so we will intake in essentially to suit the needs of the individual. We have a very flexible program because although we're training in transport medicine, many of our fellows decide to subspecialize during their time with us, maybe do rotations for a significant rotations in hemodynamics, neurocritical care, focus, probably forgotten one or two. But not only is transport medicine a focus, they can actually decide they want to become expert in neonatal neurocritical care, for instance. Yeah. And so they can spend a considerable amount of time training with those specific services.
Okay. Thank you very much. It's been absolutely illuminating and fascinating to hear about those in Canada. We're going to go to a coffee break now, and we are running slightly behind, but we still hope to make time up and finish on time. So we want you to come back from the break at 3:35. So if you can turn your cameras, turn the webinar back on at 3:35, have a break, and we'll see you back in just over 10 minutes.
Thanks, Will.
Thank you, Hilary. Welcome back, everyone. We're down to our final two speakers for the afternoon now. We're running slightly behind, but it's been an absolutely fantastic day. So thank you for staying with us. Next, we've got Dr. Andrew Helmers, who is also dialing in from Canada with the Sick Kids Service. Andrew is a staff physician in the Department of Critical Care Medicine at the Hospital for Sick Kids and is an assistant professor in the Department of Pediatrics at the University of Toronto. He is also a clinical bioethics associate with the Department of Bioethics at Sick Kids and is also the Associate Medical Director for the Sick Kids Acute Care Transport Service. And Andrew is going to talk to us about the challenges that we face and some of the ethical decisions we make in paediatric critical care transport. Andrew, over to you. Thank you very much for your patience.
Thank you for a kind introduction and your patience with me today. I think I'm your, or at least one of your last speakers, even though it's still mid-morning here. So glad to have this opportunity to chat a little bit through some of the issues that we face here, which I presume are shared at least in part by many others working in pediatric and of course in neonatal critical care transport. I have myself no actual or potential conflicts of interest here in relation to the program today, and we use one or two cases, but just to say up front that those are entirely fictional. Was hoping in terms of objectives to review some of the common ethical dilemmas that we find ourselves facing in pediatric transport medicine, articulate some of the values and principles which inform decision-making in our context, and then reflect on a few other situations that are sort of challenges that we continue to work through and try to understand better. So just going to list a few of some of the day-to-day challenges that our team faces when we reflect back on cases that we've worked through. And end-of-life care, of course, is a big one. Duty to care as well, and I'll go into both of these in more depth as examples. Communication, challenges in communication, articulating differences of value and different approaches to the same problem with our community hospitals is always something that comes to the fore. Family presence, and I know that was alluded to towards the end of Hilary's discussion as well. How much do we include families and how do we support their presence with our team? And shared decision-making, how do we facilitate that? Access, equity, and geography, and I list all of these because we're challenged in a special way in Canada in general, and certainly in our province of Ontario is no exception, with quite a dispersed geography and are accountable for patient care quite a distance from our referral centers. So there's the challenges there in terms of ensuring that we minimize the barriers that might exist for children to access critical care support in spite of living further from a tertiary center. We talk also in transport medicine about the triage and about emergency preparedness. So kind of how to deal with large-scale disasters. And of course, we all had to work through that to some extent through COVID in terms of just the extreme resource constraints and challenges that we faced in responding to all the work that we were asked to do. And moral distress, and that's something we'll come back to in just a second here. And then transport medicine and its intersection with mental health care as well. And certainly we have, a number of teenagers that we'll be supporting in the transports that we do, that we always are trying to challenge ourselves to do better in terms of supporting what their needs are and understanding even what the risks might be posed to our team as well. And I'm flagging moral distress here because that is something that has become a bit, du jour in terms of how hospital systems as well try to frame their approach to wellness, to resiliency, and so forth. But I list it here. It's not an ethical issue in and of itself, right? That moral distress is actually the recognition that there are ethical issues. It's that tension between, I think something could be done better or in a way that is more aligned with my moral compass, and I feel that there are some constraints preventing me from doing so. And really, it's that tension, that feeling of unease and dissatisfaction with the course we're plotting, that really is the core of what ethics is, which is that effort to articulate and discuss and understand, what are the values at play, how do we prioritize them, understand them better, and move from there to impact how we actually function on a day-to-day basis, how we build policy and practice in the work that we do. And if you allow me a couple of minutes digression into bioethics, properly speaking, the nature of bioethics is, or its roots really are in that philosophical tradition, that effort to sit and reflect and talk. And some talking is something that we all do too much in pediatrics, I think, in general, and I'm very much at fault for that. But that talking with each other, with those with different values, different views, and trying to understand, how can we reconcile this in a way that can serve our patients best in this particular situation. Ethics is, unlike the sort of very abstract nature, of this painting of the School of Plato, by Raphael. Ethics is about the nitty gritty. How do we pull these ethereal kind of values into the work we're trying to do in the back of an ambulance with a patient? And efforts to bring that philosophy into the practical realm have included any number of philosophers. Now, I'm the nature of a lot of the bioethics literature is overly focused on fairly elderly white males, unfortunately. But these three are often held up as the exemplifying some of the traditions of thought that remain with us today, for better or worse. Aristotle being one who articulated what we call in bioethics that virtue ethics, that sense of what is it that is incumbent on you as an individual to seek to become a better person, fundamentally, the virtues that might be at play. And that plays a lot into the different codes of ethics that many of us ascribe to as we navigate our professional careers, in terms of what virtues are sort of meant to be in play in the work that you do. In the middle, you have Kant, who exemplified the deontology and that primacy of duty and a bit of moral absolutes at time. And on the right, Jeremy Bentham, of course, a Brit who articulated consequentialism, utilitarianism, and those theories of philosophy continue to inform a lot of the discussions that arose during COVID, especially around triage, and how do we deal with resource limitation? How do we ensure the greatest good for the greatest number of people? To further distill these into bedside decisions, you'll see these framed also as principles, which are built on this text. It's an American team, and so they're pronounced Beecham and Childress instead of Beauchamp. But this principle of the biomedical ethics has been quite impactful in terms of articulating basically 4 key principles that are meant to be part of these discussions around decisions that have to be made. And they talk about autonomy, beneficence, non-maleficence, and justice. And in pediatrics, we have that extra flavor to autonomy where we talk about parental autonomy and what are the proper limits of that as well. And then the justice piece, especially in the world of transport medicine, is very much about resource allocation, distributive justice, but also equity and access and barriers to care that we play a role in enabling or in overcoming. And just to say, the limitations are many of this model. The goal here is to try to bring together disparate philosophical traditions, to say that someone who might come from a particular tradition of virtue ethics versus consequentialism versus care ethics or any other number of different theories that are out there. The idea is to bring them onto the same page, literally in some cases, to try to hammer out, what are the ways in which those theories might correspond to principles that inform action and decisions at the bedside. So using a little bit of this, we can talk about a couple of these themes in terms of challenges that we find ourselves facing in transport medicine. So to jump to the whole area of end-of-life care, when to stop, when to actively support palliation, for example. And this is a case that unfortunately happens all too often, where in our center, we'll get calls from community sites, and sometimes they're actively engaged in a resuscitation. And so one case fictionalized, but again, with common elements to many real cases, a 13-month-old who was left for a period of time unattended in a bathtub and was found ultimately submerged, unresponsive, vital signs absent, and was brought by EMS to a community emergency department. They initiate a call to us and achieve ROSC after about 40 minutes of resuscitation, and they achieve that during that call to our center, and we send our transport team. So these are, troubling and tragic cases, of course, and some of the ethical tensions that our team struggles with, right, is first of all, that idea of do no harm or non-maleficence, right? How can we work with community sites to stop CPR, to empower teams to appreciate the limits of what we can do? And then in those patients where, for example, like here where ROSC has been achieved, how might we facilitate transport and disposition in a patient whose outcome we anticipate to be mortality? And when we have an anoxic 40-minute PEA arrest, we don't anticipate that this child will survive. Do we still work to bring them, with all the risks entailed in that, to a tertiary center? Do we work with the sending facility to potentially explore palliative care in the local context? And so there's other issues that come to mind as well, not in the moment typically, but we talk about resource allocation, and there are always some detractors who would say that transport medicine, has to serve patients primarily who we can cure, as it were, instead of working through palliative questions. But of course, I think many of us here on this call appreciate that there's even a growing role for our transport expertise in facilitating palliative care in patients. There's two issues that play here. One is that, when do we reach the limits of what we, and by extension, our teams present at community sites, might be able to achieve, and then palliation itself that we'll talk about afterwards. So there are challenges rampant in terms of trying to establish guidelines around termination of resuscitation. And these are criteria that are typically built even for that pre-hospital, the EMS teams that work with children that are in cardiac arrest. And this is just one example of a paper that achieved something, but still the criteria becomes so restrictive that there are many patients that don't meet their criteria who do not survive. So it's not the most discriminatory thing, and it's meant to be something that would still result in many patients coming to an emergency department in spite of challenges there. So the sort of bad things that we all have in mind in terms of what makes this resuscitation seem that we're not winning, right? So unwitnessed arrest, no lack of bystander CPR, or the time taken to initiate CPR, the duration of the arrest, of course, number of epinephrine doses, the presence of a non-shockable rhythm, non-cardiac causes, especially asphyxia, younger patients, trauma. So different factors that we might work with some fluency in terms of here are predictors of what may be a bad outcome. And our engagement in these cases is, as a team that has seen, unfortunately, many of these cases evolve, and sometimes you're getting a call from a physician who has never experienced a pediatric death before, right? So there's that difference in perspective that we bring to things as well, and how to convey that compassionately to teams that feel like they cannot stop can be a challenge. There was one paper I could find out of Johns Hopkins, this is about 7 years ago, where they developed a bit of a policy to navigate some of the ethical dilemmas that arise when called about children who are actively undergoing a cardiac arrest. We often find ourselves sitting mostly in the first 2 points here in the first row, where our bias is that we would generally dispatch our team while we sort things through. And we support the referral team in providing high quality CPR, but we also are often tasked with supporting a decision and ensuring a decision is made to stop resuscitative efforts and pronounce a death in that patient when those efforts have become futile, when they reached a point where they're not going to save that patient. We don't, some of these subsequent points here reflect a commitment to rescue that is, you could use different words for it. You might say heroic, cutting edge. You could also say, that you may have some doubts that this is something in the grand scheme of things that's going to be the best use of resources, as kind of selfish as that might sound. But really, we don't, in our center, for example, buy into eCPR in patients who experience a cardiac arrest outside of our hospital. So we would not dispatch a team with an expectation of cannulating a patient who is undergoing a cardiac arrest at another institution. So these are, these guidelines will differ by region, for example, and this is clearly something that's quite unique to the center that built these. They also talk in the third row about active CPR and the question of providing that on transport. Again, that's something that we rarely find ourselves doing, and I think speaks to decision-making pre-transport of patients that are at high risk of arrest, and acknowledging the risks to the team of committing to providing CPR whilst en route. So when to stop, some of the ethical challenges here is that it isn't a clear-cut sort of path, and our neonatal colleagues are in a bit of a different context, and for there are guidelines that are more tangible in the resuscitation at birth context in terms of and neonatal resuscitative processes aren't going to work beyond this point in time. In the adult literature, again, there's some sense that if it's an asystolic PEA arrest, after 20 minutes, you can feel fairly confident that ALS is not working and will not work for this patient. In pediatrics, that guidance has eluded us. There has been acknowledgement of a need for more guidance in some documents, but ultimately, there is a range that everyone will kind of find as their inflection point. I think for most, it's certainly at no longer than 30 minutes in the case of a PEA or asystolic arrest. Would one think that PALS has any role to play in changing the outcome in that patient? So we encourage, of course, our community sites to call us early and often when they find themselves in these situations, but we do feel like there are perhaps even an increasing number of quite prolonged resuscitations that we end up being involved with, where it can be difficult to redirect teams that are find it very difficult to stop, basically, and I think that's something that can be troubling for us, when we're used to seeing more arrests and appreciating the limits of some of those therapies, but something that often falls on us to help teams navigate. And that how is important. So again, if you're working with a team remotely that has no experience with pediatric mortality, for example, so ensuring that they understand the importance, of allowing family presence, making sure they're not putting this on the family, asking permission to stop something that has become evidently futile, and make sure that they can be supported through this, and potentially even connecting, with the tertiary center to work through what bereavement care might be available, grief support, peer support, and so forth. Of course, the context of all of this is, how resuscitation is depicted in the media, and this is just one of many papers that have outlined how the TV shows, that will depict cardiac arrest will typically portray a very positive outcome to something that we know is not generally so survivable. So we also have, this is an example of a recent fundraising advertising campaign by our hospital at Sick Kids, and these are great campaigns. They raise tons of money to support important research and other capital projects, but you can see that there's a theme, I think, in a lot of pediatric healthcare about not giving up, fighting to the end. You can see the slogan here about versus the odds, and I think that plays into how other teams might struggle to navigate the limits of the care we can provide when it comes to things like a prolonged resuscitation. And this is just some suggested reading, a nice but sad kind of perspective piece on why why sometimes stopping is the right thing to do, even if it can be the difficult thing. Palliation is a bit of a different beast, and I think it's an unknown the extent to which our palliative care and transport expertise overlaps in the world of pediatric ICU, something that is, I think, ripe for further exploration. So what we'll do when we dispatch our team to sites that are actively engaged in a prolonged resuscitation is our team is often helpful to guide family presence and support families in navigating something that our team, again, unfortunately has a bit more fluency with. If ROSC has been achieved, we'll work through our team with that family and the medical team there to establish a no CPR order in the event of further deterioration, and to make sure that if that decision is ultimately to still bring that patient to our ICU, that it's very clear what the risks of that transport are, that patient may not survive that transport. And we place clear limits on any escalation of therapy, again, predicated on that child's best interest. If this has been, you know, a 50-minute anoxic cardiac arrest, then we really don't think we have more to offer in terms of therapies that would have a curative intent. So that's one branch of overlap of palliative care and transport medicine, of course. And there's another important one that has a little more support in the literature, and something that our team also engages in on a fairly regular basis, which is those transports out of ICU to another destination to facilitate end-of-life care. And that might be, in some cases, to a child's home, in others to a hospice, where the team will support withdrawal of life-sustaining therapy, sometimes to a hospital that is closer to home that can facilitate ongoing palliative care provision. And so really seeing the transport team as a way to be creative and understand and accommodate families' wishes, values at the end of life. And then I feel like this is an important part of the work that we do, and one that we're trying to work towards having, you know, better understanding of how that might challenge our team members and how they can be better supported to provide that level of care for patients and families at such a sensitive stage of their journey. So I'm going to talk extremely briefly next about duty to care, and because that's one other thing that comes up with some regularity in the work that we do. All of these things do, but just these, picking a couple that have been a little more challenging. The ethical tensions or clash, you know, that is present when you talk about a duty to care is that, should I stay or should I go? You know, what are my personal responsibilities in the face of activities that place me at personal risk? This is something that certainly came to the forefront during COVID, and I think was discussed at some earlier talks today. You know, the fact that as a transport team, you know, we are often implicated in transporting patients with contagious illnesses, right? When you have an emerging illness such as COVID, or when you have a lack of effective personal protective equipment, as we all faced, you know, earlier during the COVID pandemic, those are moments, an example of something that places a team at special risk, and that brings this tension to the surface. You know, how much do I put myself in danger to care for a child who needs that medical care? So there's a number of circumstances that we run across that bring this tension back to the foreground. You know, so parental presence is one. We've talked about how we make that a goal of all of our transports and do our very best to facilitate that. But we know that there are some contexts where you may have a distressed caregiver, for example, or where there's suspected non-accidental injury or abusive head trauma, and you don't know like how safe having that parent present might be for the rest of the team members closed up in the back of an ambulance. Equipment securement is something that we certainly are always trying to improve and acknowledge when there's deficits there that might place the team in danger. Infectious diseases, as noted, weather is an important one. You know, the safety of that travel, whether it's by air or ground. Urgency, you know, how do we accommodate an urgent call in a way that doesn't, or that mitigates risks to those in the ambulance? So the controversies around use of lights and sirens, and fatigue. And as mentioned, especially with the geographic challenges we have, often placing team members into overtime or into very prolonged transports, something that especially over time, you know, can cause challenges. The culture we have in healthcare is, you know, you go down with the ship, unfortunately, and that's something that I think COVID has shifted the needle somewhat. This is just an example of the Titanic to illustrate that, and the more recent disaster of this cruise ship in Italy, and I'm blanking on the name of the ship, but the captain of that ship, who abandoned his ship quite early on instead of staying to make sure that everyone could be evacuated safely, ended up serving jail time for that decision that he made. So there's a societal expectation of those that are sort of in charge, the ones that are running the show, that there be a principle of sort of non-abandonment. But just to move through a few things here quickly for the sake of time, is that we've moved away. This is an 1847 code of ethics, where there's this advocating that even when there's pestilence, you know, the sort of the contagious illness in that day, that the heroic physician must stay and continue their labors even at the jeopardy of their own lives. But this is 1847, right? And we've moved beyond that sort of lone physician practitioner wandering the hills with their black bag, and we work now with complex teams, and there's layers of accountability now to ensure that the work that those teams do is done as safely as possible for the sake of those team members, and of course, ultimately for the sake of the patients we serve. This is just a screenshot of some attention that we got when things got pretty busy with a viral surge 2 winters back, and just illustrating the complexity and size of the team that we have in transport medicine in particular. And everyone in that team struggling with a divided duty, duties towards patients, yes, but also towards family members, towards their own children, towards the next patient that they need to serve. And how do we reconcile those? And one diagram that we worked through at the time when we were discussing PPE limitations, for example, is the importance of a broader accountability for team safety, that there must be solidarity and reciprocity to that clinician caring for the patient by the broader healthcare community and by community at large, everything from industry to education and childcare. And that moves the fulcrum such that healthcare worker is no longer tasked with bearing the full burden and full risks for everything that's involved in caring for patients, because that risk is not meant to be heroic. And this is just for reference, and I can be happy to share these slides later, where there's policies that have been built around, for example, use of lights and sirens, again, to make sure that there's transparency, there's accountability, there's system level processes in place to mitigate what those risks are for caregivers that are present in the back of that ambulance. I'll finish with just a couple of lines about communication. Quote from George Bernard Shaw famously said, single biggest problem in communication is the illusion that it has taken place. We work in a field that involves high stakes communication that has to be so careful, so sensitive, and that is so rarely value neutral in what we say and how we say it. And content expertise that we are tasked with providing on the phone or at the bedside is only as useful as the expertise we bring in communication and troubleshooting differences that arise in the work that we're doing. So many virtues or principles that are needed to make that communication effective and ultimately to prevent errors in crisis resource management and cognitive biases. And finally, would just say that we have quite a privileged insight into where the pressure points, where the limitations lie in our healthcare systems at large. It's our team that will feed back to us, hey, we went to retrieve a child in DKA and they were running insulin at, the wrong dilution, or they're running at the wrong rate, or this patient got a bolus of D5 instead of normal saline, things like this. All of these are moments and opportunities for learning, for example, for community centers, learning for us as well, and to cultivate a meaningful and mutual feedback network is something that requires, again, a commitment to communication and understanding the values inherent in what and how we communicate. So I'll finish there just reviewing objectives and hoping to leave a couple minutes for questions. Thanks so much for your attention.
Andrew, thanks ever so much for that talk. It was really, really thought-provoking. One main question, I wonder if you have an approach to teaching these sort of quite complex non-technical skills within transport teams where perhaps we're traditionally focused on more sort of technical task-based skills?
Yeah, that's a good question. We, as Hilary mentioned, we take time daily and whether it's neonatal or pediatric, we'll be reviewing the runs that the team has done. And part of it is just trying to facilitate a culture where all the team members feel that they can, articulate concerns that are beyond the technical, right? We're worried that, this parent wasn't able to come with us, or we're worried that this patient maybe could have undergone palliative care with, closer to home in their community site and so forth. So we try to tease out those questions and have good discussions around those. And so that's a sort of learning in the moment around some of these cases, just an opportunity for for people to identify some of the moral distress they might feel after a particular run and be able to talk through that. And then we'll also have, we have opportunities for we have education days with all of our clinicians and another structured teaching for our transport fellows. And we'll typically have at least one session on the regular that gets into the ethical dimension of our work, communication challenges, and kind of work through that on a more formal basis too.
Thanks so much indeed. Thank you very much.
So our final speaker of the day is Dr. Andrea Tomaselli. He's an Italian paediatric and neonatology specialist based in Milan, and he's got a wide range of other interests out with paediatrics and neonatology. And one thing he's recently been involved in is the planning and execution of a large-scale aeromedical evacuation of refugees from Ukraine. He is here to talk to us about this experience. Andrea, we can see you, we can see your slides, so over to you.
Okay, thank you very much. Thank you for the kind introduction, and thank you for having invited me to this Congress. And today we talk about an aeromedical retrieval that we did in 2022 using a long-range commercial aircraft. First of all, I just would like to give you a little bit of background. I think that everybody knows about what is happening in Ukraine right now. And when we woke up on 24th February 2022, and we saw the news and we read the newspaper, we all knew that something terrible was happening. And maybe for the first time after long years in Europe, everybody was scared of what was happening everywhere in the world. Fundraising campaigns started, and people started to send help to Ukrainian people, like food and drugs. But Italy also decided to open some refugee camps over there in Ukraine or along the borders to help people who lost their house and to help them with their health issues. Moreover, Italy has consistently expressed its willingness to accommodate Ukrainian refugees within its borders. And I would like to think that it's because, as you can see from this picture, Italy has always had a strong immigration of Ukrainian people, and especially in the north of Italy, there is a strong Ukrainian community. And what astonished me the most at the time is that all the Ukrainian men I knew told me that they would have left Italy in the next few days to go back to their country to help their families or to take part into the war. And so in this scenario, Federico Emiliano Ghio, who is the CEO of iHelp, a company specialized in long transport of critical ill patients, and in a big mass event together with Itara Airways, the flag keeper of Italy, decided to provide an Airbus 320 to Areo. Areo is the emergency public service in Lombardia. After 15 days, as you can see, Areo told us, yeah, it's a good idea, we can do it. It's something good and something that we can actually do. And so they told the Cross, who is part of the civil department of Italy, to finalize the flight. And on 2nd April 2022, the flight was done. As you can see, we didn't land in Ukraine, but we decided to land in Lublin, who is near the borders of Ukraine, for two main reasons. The first one was because the refugee camps were mainly in Poland. And the second one was for safety reasons, because we didn't want the crew and the doctors and nurses over there to be at risk. And so we did everything in just 32 days. And I know that maybe for you it's quite a long time, but for how things works in Italy, it's quite a short amount of time. When I say that we used a commercial aircraft, I mean that we use this kind of aircraft, that it's aircraft that we usually use when we go on holiday or when we go to see our family back home. And after the excitement and the happiness that we felt at the beginning, we knew that we have to face thousands of problems. And here in this slide, I just write down some of them, but I can assure that we faced thousands and thousands more. And the first thing that we did was try to look in the literature if someone or something could help us to organize the flight. But we were the first one doing that kind of flight. And so the only things that it remained to do was to create a well-organized multidisciplinary team who could overcome all the troubles that we were having. And so in the team, we included doctors, nurses, but also people that are usually involved in the emergency settings, including some engineers. And so we tried, and I think that we did, solve all the problems and all the issues that we needed to solve. The first and the biggest one, I think, was the types of patients that we would have liked to transport and that we would have been able to transport. As you can see on the right side of the slide, there is a picture of how an Airbus is, and it's the kind of Airbus that we used. So you have plenty of seats, but you have nothing that can help you if an emergency takes place. And in the left part of the slide, you can see the normal air ambulance, in which we have everything you need in case of emergency, including stretchers and equipment that can actually help you a lot. And so we needed to have a think about it. And we could set up to 3 stretchers on our plane, on our Airbus, but not more to ensure a safe weight distribution. And but you need also to consider that for each stretcher, you need to take out at least 6 seats. And so we had a long chat about it, and we decided that it was better to prioritize the number of seats and not the numbers of stretchers. And we did that for several reasons. The first one was that we needed to evacuate large numbers of patients. And the other one was that we knew that we wouldn't have been able to treat that much, too many critical ill patients. And why we wouldn't have been able to do it? For several reasons. One of the main is that when you fly on a commercial aircraft, you always need to consider the amount of oxygen that you can use. And on our plane, we had 2,700 liters of oxygen, and the maximum flow rate was from 4 to 6 liters per minute. And we all know that it's not enough if you have a critical patient that needs to be ventilated. And moreover, we couldn't use all the oxygen for just one patient, because in case of emergency, you always need to think about the other passengers and also the staff who is working on the plane. So this is one of the reasons why we decided not to have more than 1 stretchers. Another problem that we faced was that not all the equipment we had was met standards for the airline. In fact, when you decide to do a project like ours, you need to check if the airline allows you to bring your equipment on, and every airline has different standards that you need to look through. And all the equipment you decide to bring on board must also operate on batteries, because you don't have access to electrical power once you're on board. And what we suggest is to have batteries fully charged, first of all, and that the batteries can allow for twice the estimated operational duration, because you don't know how long the flight will take at the end, because there could be problems with the landing or with the takeoff. And moreover, as we know, equipment tends to lose efficiency over time, and you don't know if the duration of the battery is the same that when you bought the equipment in the first time. And maybe you are guessing why I'm here speaking with you with my very bad English. And that's why when they received the list of patients, they realized that out of 165 patients, half of them were children aged between 1 month to 15 years old. In Italy, if you are not a pediatrician, you are not used to work with children, and especially not critical, especially if are children that are not critically ill. And so they asked me to help them with children with minor conditions. The first thing they asked me to do was to check on the triage they did and to establish the fit to fly of the pediatric patients. And another task I had was to go through the drugs they would have liked to bring during the flight and told them if they could be useful also for the pediatric population. What I found out was that they chose great drugs in case of a critically ill child, but they didn't think about children with minor conditions such as dehydration or gastrointestinal disorder. So at the end, we brought also rehydration solutions, flu syndrome treatments, gastrointestinal disorder medications, and minor pain relief medications. They are all over-the-counter medications, but if you work in a pediatric emergency department, you know that you can treat several conditions just with this kind of over-the-counter medications. Then we also tried to create a child-friendly environment because during the flight we transport also orphans, and we thought that not stress them too much also in a psychological way was a good idea. And so we guaranteed the presence of 2 educators that can speak Ukrainian, and also we gave toys for each child on board. And what I can remember clearly was that during the takeoff and during the landing, you can hear children playing with their toys. And so I think that we made it, and that we at least made them have a good and safe flight and not to be too much anxious. We didn't expect emergency during the flight, but we were ready to face them in case of something wrong happened. The first interesting thing that you can see in this slide, I think it's how we set up the emergency zone. So there is a stretcher, emergency nurse, and an advanced life support bag kit. And we decided to bring 2 of them just because we could have set up at maximum 2 stretchers. And so we brought with us 2 bag kits. And the content of them is the same of what you usually have in the UK or in wherever you are. And so I want to go through them. Then we brought also monitor and defibrillators and supplemental provisions. And I already talked about the over-the-counter medications that in this kind of flights maybe and are very helpful. And finally, one thing that was fundamental for us was the presence of personal protective equipment, and I'm talking about masks, N95 or FP2. I don't know how do you call it usually or where you're from, but for us they were fundamental because we had more than one issue with infectious disease. In fact, we had several infectious patients, and we decided to to accommodate them on the right side of the plane, as you can see, to isolate them from people who didn't suffer of any infectious disease that we put on the right side of the plane. Then we decided also to place them according to the severity of the illness they had, starting from the top to the bottom. So at the end of the plane, we decided to accommodate the more severity ill patients. We did it for 2 reasons. The main reason was that we wanted them to be near the stretcher, so as close as we could accommodate them to the stretcher. And moreover, during the takeoff and during the landing, we sat where you can see the red seats, and so we wanted them to be as close to us as they could. As you can see at the end, we decided to have 2 emergency nurses and just 2 doctors during the flight to maximize the number of patients that we could have transported. The educators, the EMT people were near the emergency exits, because in case of emergency, we needed someone that actually could have done something useful. We could do everything in advance because we had an effective way of triage the patients. And I'm talking about the SVEI, that stands for Immediate Needs Assessment in Italian. And from now on, I'm sorry, but I will call it SVEI in a very Italian way. And it's a descriptive sheet for the assessment of the immediate needs of individuals, of people during the emergency. And it's very useful in this scenario, because as you can see in the first part, you just need to put the name and some information about the patient. Then there is a color scheme that allows you to understand how the severity of the condition of the patient. And then in the second part, you can write down the name of the drugs he is taking and the condition is suffering of. For us, was pivotal to have this day a few days in advance to the flight, because we needed to decide how to where to put the patients, to know the number and to know also the conditions they suffered of. And it was made by the doctors and the nurses that were already in Ukraine, and it was very helpful. And also when you did this kind of flight, you don't know if people you meet can speak English. And we struggled a lot because most of them couldn't speak English at all. And so without this way doing in advance, we couldn't have known anything about their condition. As you can see, SVEI goes from green to red, passing through yellow med and yellow. And green patients are a patient that are stable and you don't need to monitor them strictly. Then you have yellow med and yellow, where patients that suffer from a medical condition, but that usually that need to be monitored, but not that strictly. And at the end, you go to the red patient, who is the worst patient you can have, because it's a patient that requires continuous monitoring, and that may require a prompt intervention in case of emergency. As I told you earlier, we couldn't and we wouldn't have been able to transport too many red patients or too many critically ill patients. And we were lucky because, as you can see, most of them were green, so non-ill patients. We had just 31 people with a SVEI that was yellow. And as you can see, 19 out of 31 were children. And so that's also why at the end they decided to bring me with them to help them with the children. Regarding people aged under 15-year-old, as you can see, the major problem that we faced was that they had gastrointestinal issues, because there was an rotavirus epidemic there. And we tried to isolate them, especially because we had also 8 patients aged less than 6 months old. And for them, rotavirus could have been a major issue. And we had as well people with respiratory issues. But the one who scared me and who scared us the most was children with infectious issues, because they had chickenpox. And in Ukraine, people and the vaccination rate is very low. And so we didn't want to start an epidemic of chickenpox during our flight. So we tried to isolate them better, leaving some free seats around them. Regarding the patients aged over 16-year-old, as you can see, also they suffered from the gastrointestinal problems that we had with the children. But the two patients that maybe could have also have been evaluated red in our survey were a girl who had a stroke 48 hours before the departing of the flight. And she didn't undergo any images, and she didn't and she wasn't visited by a neurologist, so it was kind of scary for us to transport her. And there was also a guy with end-stage renal disease that needed to underwent dialysis the exact same day, and his condition were not so stable. Once we landed in Lublin, the boarding process took about 50 minutes. And we need to thank not only our colleagues there, but also the cabin crew members. They were fantastic and they helped us a lot. Also with the dispositions of the patients, because they need to respect the weight balance disposition. And we also managed to do a fit to fly examination, a quick one, before boarding them. And so what we found out was that this way was quite right, and we could have took off the flight without any major issue. During the flight, we had just minor conditions, as you can see here. For children, needed rehydration because of the gastroenteritis. And just one needed intravenous volume replacement because he was about to develop an hypotensive shock. Another, the girl who had the stroke experienced psychomotor agitation, and we treated her giving benzodiazepines by mouth. And another patient developed chest pain, but we performed an electrocardiogram and it was all right. So we just gave him oral nitrates that solved the situation. We were quite proud and quite happy of how we managed the issues that we met during the flight, especially because we avoid them to become serious issues. And so we didn't have to use our advanced life support kit. Just a few take-home messages, because I know that for you it's about tea time and I don't want you to give up with tea. The major lessons that I would like you to have for today is the importance of have a well-balanced multidisciplinary team, especially when you are doing something completely new, as we did. Everyone can add something to what you're doing. And at the end, just 4 of us took part to the plane, but I don't think that we could have done everything without the help of everybody. Then it's in this scenario, it's very, very important to have an efficient triage method, because you cannot have a complete history of all the patients you are transporting. So you just need to have some good and brief information about them that can allow you to do the flight. And a efficient triage method can also allows you to decide where to allocate the patients. Then regarding the equipment, always check that that meets the standards of the company, and that you can actually use it with the battery, and because you won't have any plug on the plane. And always think about the medications you need to bring with you. So also considering over-the-counter medication, because you are not dealing with severely ill patients, and think about that you won't have enough oxygen to treat as much patients as you would like to treat. So it's something always to consider. At the end of our experience, we think that the use of a commercial airplane is a good way to transport and to evacuate people from major crisis places. This allows you to leave the air ambulances for people that actually needs them. and you can transport not that severely ill patients by flight. We decided to do it by flight and not by train or ambulance, because from Lublin to Italy is about 26 to 30 hours by ambulance, whereas with the flight is just 2 hours and a half. So it's something that we need to start to consider and to work on, because it's a very effective and economical way to transport patients. At the end, I would like to say thank you to ITA Airways for giving us the flight for free. I would like to thank my colleagues that were pivotal for the experience and that asked me to go with them. And at the end, I would like also to say a big thank you to the cabin crew members, because they managed and treated the patients with very much respect. And if you want to know something more about what we did, we recently published a paper that and here you can find it, the title and the authors. Thank you very much for the attention.
Andrea, thanks ever so much. That was an absolutely brilliant talk to round the day off with. We've got a couple of questions or things just to clarify, really. How were these patients identified, and what sort of role did you have in deciding who was suitable for transfer? I appreciate you did sort of a medical checkup before you took off, but did you play a role in deciding who would be transferred before that?
No, because we received the lists of patients that were hosted in the refugee camp near Lublin, so we couldn't decide which patient we would have liked to transport. But we decided not to transport just 2 people because they were too ill to fly on a commercial airplane. So it was better for them to use an air ambulance, and that's what we did later.
Brilliant. And obviously, this is an amazing feat that you've achieved. And you've obviously shown that it works. Is this something that you plan on doing more of, or is it going to be applied to sort of different sort of mass casualty retrievals? What's next?
No, actually, we are working with the Italian emergency department in Lombardia to see if it is feasible also for other worst scenario, because we would like to do it also in other countries in which people need just to be evacuated and they have not actual or serious medical conditions.
Brilliant. Thanks so much for your time. That was absolutely fantastic.
Thank you very much.
So we're about to close the day, but obviously we want to get some feedback from you. So you'll receive an email in the next couple of days asking you to fill out a feedback form. And when you fill out the feedback form, you will get a certificate. We're also going to send out the QR codes from the Open Access FutureLearn and the 360-degree video project in Wales. So we'll attach those QR codes to the email that we send out so we can collect our feedback. Over to you, Charlie.
Fine, we're going to round off. I've got some thank yous to close the day. First of all, thank you to all of you that have stayed with us over the course of the day. I hope you've enjoyed it. I certainly really enjoyed listening to the variety of speakers. Thank you to all our speakers who've given up their time to come and talk to us today. There's been such a fantastic range and some great enthusiasm and some really amazing experiences to draw on. Thank you very much to A-Line and the technical team who are all sat off to my right, off camera, who've helped to run the day, and it's all gone pretty smoothly, even with a few sort of small technical hiccups there. So we couldn't have done this day without them, and they've all volunteered their time for free to be here. So thank you to the technical team and A-Line for supporting the event. And finally, thank you to Miriam for co-hosting with me, and Alex and everyone else at Nectar for helping host. And we hope that you join us for future iterations of the National Transfer Meeting.
Which will be next year. So join us for NTN 2025. I'm sure there'll be some information out about it soon. Okay.